Testing.
এটা কি ভেরিফাই এটা হবে Good morning. I think I'm audible to the online participants as well. So this is our third year that we are organizing this program of oncological infections and intensive care from Tata Medical Center. This is the second time that we are conducting this program from this auditorium. Last year we did it from Novotel. So, very warm welcome to all of you for this program, and I'm grateful to all the faculties who have consented to speak or participate in our program, and all the delegates who have joined online as well as who are going to join us online as the day progresses. So, without wasting any more time, I would request our director, sir, Dr. P. Arun, to and as well as Dr. Sanjay Kapoor, our deputy director, to lamp the light and inaugurate the third Tata On Intense ID now. After that, we would have some words of encouragement from both of them. So, Mr. Sanjeev Agarwal, our Chief Financial Officer, has also joined us, and Dr. Sanjay Bhattacharya, our lead microbiologist, will also join us soon.
So now I will request Dr. P. Arun, our Director of Tata Medical Center, Kolkata, to share some words of encouragement with us. Sir, please.
Very good morning to those present in this hall and those who have joined online. It's quite reassuring to feel reassured that in spite of a sparse attendance in the audience, I do get a feeling there are a lot of people watching me in the Zoom. So good morning to all of you. I know from Sudipta that this is the third instance of Tata On Intense ID. And these are focused programs dealing with infection and other related matters, because I went through the program and it is not just infection alone. It covers the entire gamut from diagnostic pathways to diagnostic modalities to even talks on lung protection and even palliative care. But infections do call upon your attention and efforts at every phase of the patient's journey through lung cancer. It is a wonderful initiative, and I must congratulate our team, Sudipto, Soumyadeep, and I must also acknowledge Dr. Bibhuti Saha, who is also a member of Tata Medical Center by virtue of being a visiting consultant. I think as the day progresses, the conference will live up to its name of being intense. So let there be a lot of intense discussion, some intense debate, and in the end, some clarity, some guidelines, or some working rules, and a lot of information and education to younger members of the profession. So with that, I would conclude my responsibility of giving you the inaugural talk and request you to carry on with the program. Thank you.
Thank you, sir. Now I will request our Deputy Director, Major General Dr. Sanjay Kapoor, to share his thoughts about our attempt. Thank you.
Thank you, Sudipta. Dr. Arun, Dr. Saha, delegates, and those online. A very warm welcome to all of you, and my heartiest congratulations and thanks to both the departments, the intensive care, critical care, and the infectious disease department of Tata Medical Center, who have come up with this unique idea. It's a very unique combination of two departments, but a very, very pertinent combination, because the majorly critical care handles is infection or its impact on the patient. It's very relevant for any multi-speciality hospital, and more so for a cancer institute where the treatment, be it surgery, be it hematology or oncology, all is so intense, and the patients are fragile, immunocompromised, and the infection takes over them as almost an overtowering impact. Infection is today's epidemic, rather, we can say, and one of the biggest challenge that every treating oncologist or a treating specialist faces. And many a times, the time taken, the morbidity, the intensity, and the expense on handling the infection during the course of treatment is much more than the handling and the treatment of the primary cause. So once again, I congratulate both the departments and wish this conference good luck, and hope that it will bring a platform for everybody to share their experiences, and we can gain to improve our handling of infection for our cancer patients and in imparting the critical care. Thank you.
Now we'll request our CFO, Mr. Sanjeev Agarwal, to few words about it, because we know in any types of program, academic, non-academic, you need support from the administration and department in different aspects. And he is kind enough to help us to organize our funding, to mobilize it funding, because we believe academics and knowledge should be free. So we do not keep any registration charges, and it was never possible without the support of administration. Please.
Thank you, Doctor. Good morning, all. Welcome to all the delegates, respected director, deputy director, and all our doctors present over here, the colleagues. So I can only say, as a non-medical person, what I understand, infection is the biggest enemy for any disease, and for cancer, yes. So that is what lead to many more problems in a individual patient due to infection. By that, I can only conclude by saying that all the best for this conference and workshop, which will lead to more ideas and developments and help the patient out of that. Thanks a lot. All the best to everyone.
So I would like to invite Dr. Sanjay Bhattacharya, our lead microbiologist, to say a few words as we conclude, go towards the end of this inaugural ceremony. So he has a huge experience of clinical microbiology, which is actually non-existent in India. So he had his training in the UK and has come here. So after my MD, I had been his fellow, where I learned a lot of microbiology, which was lacking in our MD training. And he still supports and guides me in all my endeavors. So a few words from him.
Thank you, Shomodip and Shudipto, for organizing this particular meeting. And I would like to thank our administration, Dr. Arun, Dr. Sanjay Kapoor, and also all the other members of the administration like Mr. Agarwal and others who have helped organize this particular event. Now, in intensive care, we have been going for clinical microbiology ward rounds for infection control, antimicrobial stewardship from almost the very first day of the hospital. So this has been a hugely learning experience for us and enable us to translate our laboratory understanding of infections into the clinical arena. I think both Shomodip and Shudipto comprise a good team, and they have actually got quite a few ICMR grants through which they are actually taking the research into infections forward. I must also acknowledge the fact that many of the other departments, like clinical hematology, etc., many surgical departments, pediatric departments, they are also working closely with ID, clinical microbiology, and intensive care in the management of their patients. So with these few words, I would like to conclude, and all the best to Shomodip and Shudipto for taking this good walk forward. Thank you.
Thank you everybody for guiding us and list us for our inaugural session. And now we'll go to our core academic program. And as Dr. Somadip already mentioned, we try to make a collaboration between the ID and critical care journey while for a cancer patients. So we have what we do. We start with our first talk. So I'd like to invite our chairperson for that talk, Dr. Arindam Mukherjee. He is a consultant pulmonologist in Kolkata Heart Lung Cancer and an ex-TMCN. We worked very closely in a lot of difficult patients, and I must admit he is one of the best pulmonologists that I have ever worked in my short career. Thank you, Arindam, for joining with us. And next, I'd like to invite Dr. Diwakar. Dr. Diwakar Poddar is a consultant in hematology department and cellular therapy in Tata Medical Center. Again, a very close colleague and an extremely knowledgeable person. Thank you, Diwakar. So the first topic for the first talk, I like to invite Dr. Arijit Nag. Dr. Arijit Nag is a consultant in the Department of Hematology and Cellular Therapy of the Tata Medical Center, and his talk will be on the post-hematopoietic transplant acute respiratory failure, how we are going to manage this scenario. Welcome, Dr. Arijit.
Share करता So thank you. So I'll talk on the topic of post-transplant respiratory failure and how we approach. So it's a privilege to be introduced by somebody whom I pester the most and to be chaired by somebody who I seek help from whenever I'm in crisis. So what does the intensivist need to know? Because it's a difficult topic, and transplants are not easy. So just to lay a foundation of what we're going to talk about, so there are two types of transplants that we do in stem cell transplant. It's autologous transplant and allogenic transplant. So essentially, autologous transplant involves giving high dose chemotherapy, and prior to giving chemotherapy, we collect the stem cells, then give the conditioning regimen, which is nothing but very, very high dose chemotherapy, and then give back the stem cells so that we can rescue the patient and the counts can recover. This is just the cartoon till day 0 when we give the stem cells back. If you compare that to the allogenic transplant, it's an entirely different ballgame because we are messing with the immune system. And so we first need an allogenic donor, which can be a half matched or a full matched, related or unrelated donor. We check that the patients and donors are available. It could be a related donor, it could be an international or a national donor who donates stem cells. We start the collection process from the unrelated donor, and at the same time, again, give that high dose chemotherapy. And day 0, we do two simultaneous things. We give the stem cells back from the ones that we have collected from the unrelated donor, and then the actual problem starts. So the patient is in the transplant unit, is sick from the effects of the chemotherapy that we have given, and that's equivalent for both autologous and allogenic stem cell transplant. But around about day 14 is the time when in the autologous stem cell transplant patients recover. Some of the complications can occur around the peri-engraftment time, roughly about day 30 when the patient is back home and recovered. We usually are much more relaxed because the complications probably end here. Not so much for the allogenic transplant because the actual problem starts from here. So once the patient engrafts and goes back home, he has two immune systems to deal with, and then there is a problem of an immune fight between the donor and the recipient immune system, and there is and therefore we have to keep the patient on a long immune suppression, wherein the patient is susceptible to infections. And we need the entire motto of us transplanters during this period is to catch the problems early, treat the problems early, and probably catch it before the patient lands up in the ICU. So basically the problem statement, how big is the problem? It's about 70,000 transplants done in a year worldwide. 30% of the patients have some form of pulmonary complications. So you're looking at about roughly 30,000 patients having about 20,000 patients having pulmonary complications, and these are huge numbers. Infections complications continues to be a major problem in early period, and unfortunately, this is not a problem as much in the western part of the globe, and so if you look at the bulk of literature, you will underestimate the problem that we face as transplanters in our setting. Non-infectious complications have gained significance following advances in the management of pulmonary infections. So basically the same story as aging. The patients are surviving beyond the initial period. So non-infectious complications come in more as the survival rates increase. And we are dealing with lots of these chronic GVHD related complications. Acute lung injury with idiopathic pneumonia syndrome is a major cause of mortality. And one of the major reasons why it's a cause of mortality is because there's always this conflict between managing infections and managing the immune suppression. It's either caught late, or once you catch it and then you treat it, then infections settle in. Pulmonary GVHD with bronchiolitis obliterans is an important long-term complications of allogenic stem cell transplant, causing significant morbidity, and other non-infectious complications, though important, are rare, and we won't talk about them in detail. So before again coming to the specific syndromes, there are two things that we need to understand when we're dealing with these patients. The two main physiologic or pathophysiologic mechanisms are pulmonary edema and ARDS. But in pulmonary edema, you have interstitial fluid collections. It's aggravate. And what are the contributing factors in the transplant setting? Because we administer huge volumes of fluid to the patient to deal with the complications of conditioning chemotherapy. The patients inherently, because they have been sick for a long time, are hypoalbuminemic. So there is lesser retention of intravascular fluids. There is concomitant renal injury from the medicines that we give them, and trust me, they are bad medicines. Cardiac derangement because of either infection, stress-related cardiomyopathy, or maybe because of the long-term effects of the chemotherapy that we have been given them. Infections, when they progress to sepsis and become a systemic problem, lead to capillary leak, and then the lungs are compromised. So essentially in a chest X-ray, you could find features of pulmonary edema, which I'll come to in the next slide. And the bedside ultrasound is a very, very important tool because not often will you be able to
will send the patient for a good straight X-ray film downstairs. So a bedside ultrasound gives you very good information in this situation. A CT thorax, if it's possible to be done, we would look at interlobular septal thickening and bilateral GGOs, and pleural effusions might also be seen, because again, there is this problem of the fluid dynamics. Careful fluid handling is what we transplanters tend to do. Important to keep the fluid balance as flush as possible, especially in the peri-engraftment period, so that you don't flood the lungs. And baseline evaluation of cardiac function is extremely, extremely important. You have to be paranoid to the extent of being paranoid about cardiac problems, so that you anticipate which is the patient which can land up sick. So this is a traditional X-ray, and there are the 5 ABCDs that we tell about pulmonary edema, A being alveolar opacification that you can see over here, bat-wing distribution more in the parahilar distribution, cardiomegaly in patients where there is lung compromise as in here, septal thickening as you can see over here, and effusions which you can see because of the fluid overload. So the ABCDs of pulmonary edema. The next concept is the alveolar damage, wherein ARDS, wherein there is predominantly alveolar damage, and the fluid collects within the alveoli and not in the interstitium. So it's basically non-cardiogenic pulmonary edema, to be on a layman's term. Imaging features will mimic probably that of pulmonary edema, except that probably not that much in a bat-wing distribution, and cardiomegaly are features which will not expect. And there is diffuse involvement. So you can see it's not just in the perihilar distribution, but diffuse involvement of the lung. So if you look at the acute complications post-transplant, you can divide it into non-infectious and infectious complications. Among non-infectious complications, again, you can divide them into pre and early and late post-engraftment period. And infections, again, can occur anytime, especially in allogenic transplants when the patients are immunocompromised. You also have to understand that even when if you've taken away the immunosuppressive drugs, it's an immune system of a baby, because it's just gone into the system and it's just like an infant. So they're very much prone to develop infective complications. Although I'm not going into the details, for a basic understanding, what are the types of infections that we expect in the transplant period? So if you look at the pre-engraftment period, so basically when your patient is in the transplant unit, we are very, very worried about bacterial infections, because A, the patients have mucositis, so there is a problem of gut transmigration of the bacteria. B, the patients can have superadded infections from the environment, and also there can be a possibility of line infections. Once the patient, there's also the problem of viruses, but the problem of viruses probably sets in more when the patient is engrafted. The two main viruses that you're looking at is cytomegalovirus and EBVs, apart from the respiratory viral infections. And again, this is a very, very challenging scenario wherein the patient is immunocompromised, the patient has a respiratory viral infections, but the general tendency is to treat supportively for the viral infections, and at the same time not forget that there could be a bacterial infection that we are missing. We are also paranoid about the fungal infections, because that's a major cause of morbidity and mortality in the post-transplant setting, especially in the allogenic transplant setting, wherein the T limbs and the B limbs take a lot of time to recover. Candida is not that much of a problem for us, because we do give empiric antifungals and they usually cover it in the pre-engraftment period. And once the neutrophils kick in, Candida is less of a problem, especially if line handling is good. And pneumocystis is again something which is always in our differential, and especially when we are doing bronchoscopy, we would always want to do a PCR. So basically 3 main patterns of infection other than the routine bacterial infections. CMV pneumonia has a diffuse ground glassing pattern, and the main problem for CMV pneumonia is the blood CMV levels may not be a good marker of the extent of damage that is going on in the tissues. So although usually when we do get the onset of CMV pneumonia, you would have high levels, but the clearing of the virus from the blood may not correlate with clearing in the tissue. So probably the duration of antivirals is longer. This is a classic aspergilloma. It's not so well defined always in the post-transplant setting, but aspergillus is one fungus we are always worried about. And again, a PCP pneumonia is something that's in a differential, especially when the patient is on steroids. We give lots of blood, rare complication, but this does happen, especially when it develops within 6 hours of a blood component transfusion, which probably goes on almost every day in the pre-engraftment period. It's more when blood with plasma-rich blood is given, which is basically platelets, cryoprecipitates, and FFPs, of which platelets are probably something which we're giving almost every day in the pre-engraftment period. The patient develops more dyspnea, although fever and hypotension might also complicate the scenario. So it's not always that the fever cannot be present in a trally setting, it can be present. echo is usually normal. The lung imaging is similar to that of a pulmonary edema. The thing that you need to do is supportive care, good monitoring, shift to the ICU when you think the patient is not maintaining saturation. The mortality is usually good is usually less if you catch it early. It's usually bad to the extent of 40%, depending upon the severity and the extent of some good supportive measures that you can give. Now, this is an entity which is not often discussed because it's very specific to the transplant setting, which is engraftment syndrome. So when the stem cells are producing enough amount of blood and the neutrophils start coming into the system, that's the point when we say it's engraftment. So technically defined as an ANC of more than 500 for 3 consecutive days. But what happens systemically at this point of time is that there is it is a huge surge of inflammatory cytokines within the system. So, and therefore what happens is there is capillary leak happening. And one of the most important target or hit organs with this scenario is the lung. So typically occurs within 5 days of engraftment. Now, the main problem is it is plus minus 5 days. It's very, very difficult, easy to catch if it's plus 5 days, but it's very difficult to catch if it's minus 5 days. So therein you have to anticipate the problem. You know, this is the time that the patient is trying to engraft. There are other features of engraftment syndrome. And what are they? So if the patient has fever in the absence of infection, if the patient has a diffuse flushing, and which is an erythematous rash, it's not like the maculopapular rash. It's more like a sort of systemic flushing that you have post a viral infection. If the patient has some loose stools, some dyspnea, rapid weight gain. Now, this is very, very important because if the patient has weight gain, fever, and flushing, then it's almost very diagnostic of an engraftment syndrome, provided the temporal relation matches. Some plus minus hepatic or renal dysfunction, and you probably don't want the patient to land up in hypotension. So this is a very, very crucial period where you have to anticipate what is happening to the patient. If it's peri-engraftment period, you think that the graft is just about coming in, the monocytes are picking up, the count has increased from 100, 200, 300, and the patient suddenly starts to have high-grade fever, plus minus respiratory problems, and it's probably an engraftment syndrome. Now, why is it so important to detect it early? Because you can do something about it. So if you know that the patient is having respiratory problems with this syndrome, then you start the patient on high-dose steroids. So it's about methylprednisolone 0.5 to 1.5, roughly 1 milligram per kg equivalent per day, and it needs short duration. So you just need to break off the cytokine cascade. So about 3 to 5 days, rapid recognition, start the treatment, and prognosis is usually good and you're able to salvage the patient. Autologous transplant patients usually have more engraftment syndrome in terms of incidence, but what happens in allogenic transplant is the immediate outcomes are good, but it's seen that as the spectrum of the cytokine or the cytokine profile of this patient is such that many of the patients go on to develop GVHD after this. So the immediate complications are good, but it's usually, if you look at these subset of patients who develop the post-engraftment respiratory distress syndrome, the non-relapse mortality is higher in these patients to the extent of about 38% as compared to less than 20% for patients who do not have this syndrome. Essentially meaning that the immune cytokine profile is primed to the state that the engraftment syndrome patients go on to develop GVHD. So you have to be very, very cautious about catching GVHD early in these patients. The other feature syndrome that's not often discussed apart from the transplant setting is the idiopathic pneumonia syndrome, and this is a bad disease. What happens is there's a diffuse lung injury post-transplant. It's early post-transplant without any obvious cause. So it basically encompasses a group of diseases of which we don't know anything about, which is and which ranges from PERDS to diffuse alveolar hemorrhage as being a spectrum. What happens is the patient lands up with an acute onset cough, breathlessness, fever, diffuse infiltrates on chest X-ray, and progresses very quickly to respiratory failure. Now, what you need to do essentially is that this is the time point where an infection is the major cause of morbidity and mortality. So you must do an imaging and a BAL because it's essential to rule out the treatable infections at this point of time. And why is it essential to rule out infection? Because that's basically the point where you can do something about and salvage the patient. The incidence of idiopathic pneumonia syndrome is about 2 to 10% of the cases. Usually occurs a little bit later than PERDS, but there's a very significant temporal overlap. Now, it's important to distinguish these two entities because PERDS has a very good outcome when you start steroids and not so as in case of the idiopathic pneumonia syndrome. And most patients develop in the peri-engraftment bit. However, if the patients are older, if the patient has got a total body irradiation, presence of acute GVHD and pre-existing lung disease, they are more primed to develop idiopathic pneumonia syndrome. There is a diagnostic criteria for idiopathic pneumonia syndrome, wherein there will be multi-lobar infiltrates on chest X-ray or CT. The patients will be symptomatic because of pneumonia, but the essence of this entire diagnostic criteria is you have to be very, very particular in ruling out all sorts of infections. That is outlined in these points over here, which is the Roman 2. And you also need to rule out cardiac dysfunction, renal failure, and iatrogenic fluid overload, which can contribute to similar imaging features. Can you do something about it? Essentially, you can give good supportive care, start on empiric antibiotics, because essentially you'll end up giving steroids at a high dose. And there is a controversial benefit, but every transplanter in the world will give on, despite the cohort studies showing that there is not much benefit, because maybe some patients will be salvaged. Now, there has been studies wherein they've looked at the cytokine profile, and the main cytokine that has come up is TNF alpha and interleukin 8. Now, these can be, so TNF inhibitors have been tried alone or in combination with steroids. There have been, the randomized trial had shown a better outcomes in terms of immediate lung outcomes, but the long-term mortality is infection-related mortality is also more, because you're heavily immunosuppressing the patient. So every transplanter would know that if you give a TNF inhibitor in the peri-engraftment period, then you are in a big problem, because you eventually end up losing the patient to infections. So essentially, it's still not standard of care, the TNF inhibitors, and so you have to ensure that you catch the patient early, give supportive care. Be cautious about good ventilatory strategies, give steroids, and try to manage infections as best as you can. But eventually you might be helpless to the point wherein the patient might still succumb to this disease, and the mortality can go up to about 40 to 60%. Again, this is something which we dread of. You have a patient who is starting to cough out blood with the sputum, or is intubated and the ET tube aspirate is showing a progressively bloody aspirate, and you see this sort of a picture. Eventually, you're going to lose this patient, because diffuse alveolar hemorrhage, although a rare complication, is almost always fatal, with a mortality ranging to more than 80% in the patients. Luckily, the incidence is not as great, and its incidence is actually higher in patients who have pediatric allotransplant, especially for metabolic storage disorders. Some storage disorders like mucopolysaccharidosis, because somehow their endothelium is more primed to bleed. Onset is typically within the first 30 days. It's also important to remember that all the patients who have bleed do not have diffuse alveolar hemorrhage. So the CT picture, the clinical picture, and the progressively bloody aspirate are diagnostic findings. We still don't know about the pathogenesis, but typically they have a picture like this, the ones that have been shown here, wherein there are alveolar opacities. The treatment, again, is a good ventilatory strategy. If it's infection associated, treat the infection. If it is GVHD associated, try to treat the GVHD. If it's desperately bleeding, recombinant factor 7 can be tried, although it's anecdotal reports. And there is a risk of fatal thrombotic events, which can happen. So you always have to balance the risk of thrombosis with bleeding. But this is only when you're pushed to the wall. Coming to the features that we are most excited about talking, but this is very morbid for the patient, which is lung chronic GVHD. The classical pictures, and we will talk about two such spectrum. One is the bronchiolitis obliterans, and another is the bronchiolitis obliterans with organizing pneumonia. Now, these are very different sort of diseases in which occur post-transplant, and it's a late manifestation. Both of these are late manifestations beyond 100 days. So essentially what happens in bronchiolitis obliterans syndrome is that there is a small airway inflammation, and it's mostly inflammation and fibrous scarring of the walls, as I'll show you in the next slide. This leads to an airflow obstruction, and then there is this air trapping. So if you look at the, So if you look at the picture, essentially what happens is that there is inflammation and gradual thickening and fibrosis of the wall. So there is narrowing of the lumen of the small airways. And so distally in the alveoli, the air gets trapped. So it's important to distinguish in the imaging feature. Now, unlike all other imaging features that you will see, and I'm not sure this is very, very clear. So if you go back and search the images of bronchiolitis obliterans syndrome, what you need to distinguish here is that the white portion is the normal lung. The black portion is the abnormal lung. So basically, unlike all pathologies wherein we seeing the white portion as abnormality, here it's the black portion which is abnormal, because it's air trapping. So it's more air and it's a voluminous lung. So that is an important thing to distinguish. So air trapping and small airway thickening, sometimes with or without bronchiectasis. And usually if you do an inspiratory and expiratory film, there'll be a mosaic pattern because of this air trapping. Other features like bronchial thickening, bronchiectasis, and nodules can be associated, and this essentially does not rule out that there is a POS. You have to be looking at this black portion of the lung in in an inflated lung. Usually occurs in the first 2 years post-transplant, but it can also occur late. What are the scenarios, or what are the clinical situations wherein this usually occurs? Usually doesn't occur in isolation. So if you have a patient who has a chronic GVHD in any other organ system, then it's a patient, and along with the respiratory feature, then you're more likely to dealing with a chronic GVHD. If you're tapering the immune suppression and the patient gradually develops these worsening symptoms, then it's likely a chronic GVHD and a BOS. It usually presents as a chronic cough unresponsive to empiric antibiotics. And the one thing that I always ask the patient is, do you have breathlessness when you go up this flight of stairs? Because that is when he's exerting, and then he's more likely to develop these symptoms. And it's very, very important that if a patient has chronic GVHD in any other organ, please do the pulmonary function test for these patients, because the decline in the FEV1 is the first thing that you can catch. You can probably intervene at this level with measures not going up to systemic immune steroids, systemic glucocorticoids, and you can monitor, and you need to monitor the pulmonary function test serially. So 1 point is not enough. So essentially the diagnostic criteria is FEV1 by FVC less than 70% and FEV1 individually less than 75% predicted. What can you do in these patients? If the patient has symptoms or the patient does not have symptoms. So if you are only catching it on a routine pulmonary function test with a progressive decline in the FEV1, always do it once more. So essentially 2 subsequent pulmonary function tests showing a decline of an FEV1 to less than 75% predicted, then start the patient on the FAM regimen. Now, the basics of the FAM regimen is it's basically inhaled fluticasone, inhaled oral azithromycin 250 milligram 3 times a week, and Montelukast tablets. And this has been shown in a randomized clinical trial showing a good outcome and the primary outcome measure being improvement in FEV1 or stabilization of FEV1. However, if the patient has systemic symptoms, again, the dictum is try to rule out infections and then start the patients on systemic glucocorticoids at 1 milligram per kg. Try to taper it gradually. Parallelly introduce the FAM regimen so that once you have taken care of the acute inflammation, you can keep these patients on long term on this regimen. It's also very, very important to do monthly PFTs on these patients for the first 6 months so that you know what the trend is. There will be 3 types of trends. One in which it's progressively improving, second in which it's stabilized, then we need to continue the same things and probably not taper immune suppression too fast. And there'll be other patients who will temporarily improve and then again started deteriorating. And this is the group of patients who you will be able to catch only if you do a serial pulmonary function test, because you probably want to catch the disease before it has become fibrotic. You want to catch it in the state where you can intervene and cut down on the inflammation so that you can improve the lung function. So prevention and prompt treatment is very, very important. Organizing pneumonia, again, is a very different spectrum of the disease, where it is diffuse interstitial lung disease affecting the distal bronchioles in the alveoli with a patchy distribution. Again, this is a radiologist and a pulmonologist are very essential in helping you diagnose this condition, because unlike POS, wherein FEV1 can help you, the diagnostic picture here comes from the imaging feature. The patient presents with cough, malaise, low-grade fever, and dyspnea. And chest X-ray typically underestimates the degree of the lung damage. So if you do a CT, you will find patchy airspace consolidations, ground glassing, small nodular opacities, and bronchial wall thickening. Now, if you look at this, although this is not a very good picture, but you can see, unlike the one that you saw before here, what is happening is that there is entire plugging of the alveoli with the fibrotic sheath. So it's entire occlusion of the alveoli which occurs here, unlike the narrowing of the air spaces in BOS. And these are the CT findings that you will be seeing. And again, usually you will be seeing these findings more earlier on in the periphery of the lungs and the lung bases. Again, it's important to do a BAL to look for lymphocytosis, eosinophilia, or neutrophilia. It's important to rule out infection and then start the patient on 1 milligram per kg prednisone equivalent for at least 4 weeks and then slow taper over 4 to 6 months. So essentially, again, the dictum of managing BOS is very, very different from managing organizing pneumonia. So you have to keep the patient on steroids and on a high dose of steroids for a longer duration of the time, because it doesn't improve that fast. Few more minutes. So steroid, if the patient is unresponsive, so the patient can be started on azathioprine and MMF. In bronchiolitis obliterans, you probably can taper the immune suppression faster. Again, pulmonary vasculature problems is something you need to keep it in mind. It's more in pediatric transplant recipients, more in patients with pediatric transplants like sickle cell disease, hemoglobinopathies. It usually doesn't occur in isolation. It occurs as a spectrum of other diseases like pulmonary VODs, microangiopathic anemias, and pulmonary embolism. So essentially, if you treat that, you help prevent the progression to pulmonary arterial hypertension, or or you can probably revert this a little bit if you treat the primary disease effectively. So summary of what I've said so far is you're dealing with a lot of different diseases. You have to understand which time point this problem is occurring. You have to understand the context, and the essential mantra always is prevent and treat infections and catch the diseases. Again, how to approach these patients. So if it's a patient post autologous transplantation, the investigation that you want to do is a high resolution CT, non-contrast, bronchoscopy, and a full infective workup. Pre and peri-engraftment period, if you've ruled out the infections and you probably bridge the patient to a point that he's going home, it's best. Then you don't need to worry. Other than that, in the pre-engraftment period, you need to do a serum ferritin, especially in the peri-engraftment period, because usually in the engraftment syndrome patients, it will be in the 2,000, 3,000 ranges, jumping up from below 1,000 or below 100. And then you can catch it early. Check for skin erythema and increase capillary refill time as an index of engraftment syndrome. The patient only has fever. Some low dose hydrocortisone can be enough, but if the patient has respiratory distress, start the patient on 1 milligram per kg of methylprednisone. What do you do in an allogenic transplantation? It's an essentially entirely different ball game. You need to do a CT thorax, preferably contrast enhanced, because you need to catch the fungal infections here. Bedside ultrasound to look for Curly's lines, consolidation, effusion, and an IVC filling, because you need to be paranoid about fluid balance. CMV and EBV titers are important. So peri-engraftment, you need to check for ferritin and probably interleukin-6. Again, interleukin-6 is not standard of care. If you can do it under the context of a clinical trial, it's best, because you still don't know how to interpret that data. Observe features for engraftment syndrome and GVHD. Again, I'm probably harping on this fact more too often, because this is probably what transplanters need to do. Keep the patient as flush as possible in terms of fluid balance. Monitor the cumulative positive balance. Use diuretics liberally. Monitor the hemodynamics and fluid balance as you do use diuretics. If PERDS and engraftment syndrome are suspected, start methylprednisolone early. If GVHD is a possibility, always rule out infections and then consider high-dose steroids. Keep the patients on antifungal cover prophylactically when the patient is on glucocorticoids. If it's a delayed respiratory failure, again, very, very important to do a pulmonary function test to catch the BOS early, especially if it's in the context of GVHD and the other disease, other organs. HRCT lung can probably suffice in this condition, because you're wanting to look at the pulmonary pattern of pulmonary parenchymal involvement. Look for effusions, because if there is minor effusions in this scenario with this typical parenchymal picture, it's more likely to be a GVHD, because serositis is an important early feature of chronic GVHD as well. If the CT and the pulmonary function test corroborates with BOS, start the patient on a FAM regimen. If the patient is symptomatic, start on steroids. As you taper the steroids, put the patient on FAM regimen and keep the FAM going on. Don't stop it, and be very, very meticulous about following up PET CTs, and don't stop. Again, I'll end with this last talk, and I'm paranoid about this. I always have a very heated discussion with the ICU colleagues over this. And again, my last slide is a bit more pragmatic. So this is a study which was done, and you must go back and read why this is very important, because it's a very good study done from MD Anderson, looking at addressing a very basic question. Does fluid overload have an impact on the immediate outcomes of transplant? And to be very brief, so they have graded the degree of the fluid overload in terms of whether there is symptoms, whether there is weight gain less than 10%, more than 10%, patient having other organ dysfunctions, patient going to ICU. Now look at the curve. If the patient has, and what is grade 2, right? What is grade 2? It's symptomatic fluid retention with or without gain, or gain being 10 to 20%. So if the patient starts becoming symptomatic, meaning if the patient has edema, the patient has facial swelling, if the patient has a weight gain of 10 to 20%, just 10 to 20%. Now look at the degree of the change in the outcomes. The non-relapse mortality of a patient who has less than grade 2 overload is less than 10%. It's about 40% for patients who have fluid overload. So be very, very paranoid about keeping the patient as flush as possible. Obviously, don't compromise on the hemodynamics, but try to keep this at the back of the mind, because these patients are different and these lungs are different. Again, as I said, communication between the ICU team and the transplant team is essential. It's important to be courteous. and put your point forward so that the fluid balance is maintained. You also need to understand that the patient's the traditional organ function score don't hold true in cases of transplant, because you'll have innumerable studies wherein you will have, they don't correlate with the transplant outcomes. Shift the patient in the ICU in the daytime and not at night time when the patient has suddenly collapsed, because outcomes are probably better if you shift them earlier. The transplant team again should be realistic about the goals. Just because you've done a transplant doesn't mean that the patient will survive. So it's important to have a good discussion with the family, and this is very important to do it early transplant, and not when the patient is in the ICU. So an advanced care planning is important to have a realistic goal as to what to do when the patient becomes so sick, and this is often ignored. And with this, I'll end my talk. Thank you.
Thank you, Rijit, for the excellent talk. We don't have much time for any questions. One question from any of the audience?
Maybe one more. Is a very easy question, that what is the exact timing of vaccination in hematopoietic stem cell transplant? And the second question, as a medical personnel, why don't you have too much of surge in mycobacterial infections post HSCT, or how many cases of reactivation of mycobacterial infection from miliary tuberculosis or similar you've seen here?
Yeah. So again, we do have higher incidence of mycobacterial infections in the post-transplant patients than in the normal population. Essentially, you're dealing with lesser numbers. So essentially, if you look how many transplants do we do in a year, maybe 100. So essentially, the numbers are lesser, but it's important to rule out mycobacterial infection, especially if the patient's so we'll always do a mycobacterial workup when we do an infective. So we do see more than in the general population because they're immune suppressed. Both pulmonary and miliary patterns. If you look at the larger data sets, about 40% of the patients will have extrapulmonary, and about 60% of the patients will have pulmonary tuberculosis, and this is data from the CDC. And regarding vaccination, in autologous transplant, we start the vaccination at 6 months. In allogenic transplantation, we started at 1 year. Our practice is a little bit different from the CDC recommendation, where it starts at 3 months for an autologous transplant and 6 months for allogenic transplants. We've had a discussion on whether we need to shift, we probably will do in the subsequent time. So the CDC recommendation is 3 months for autologous transplant and 6 months for allogenic transplants. Yeah.
Thank you, Dr. Rijit.
So we'd like to request Sanjay sir to hand over a small memento to Dr. Arijit Nag and Dr. Dibakar Poddar. Sir, Dibakar. Okay, so we'll move to the next session. The speaker for this, we have a session on fungal biomarkers in diagnosis of invasive pulmonary mycosis. The speaker is an eminent speaker, a faculty from the Department of Medicine, All India Institute of Medical Sciences, Dr. Animesh Rai. He has a lot of degrees and papers in his kitty, and he's been recently working on fungal biomarkers, especially on chronic pulmonary aspergillosis. So I would request sir to start the session. I would also request Dr. S.N. Haldar, as Associate Professor, Department of Infectious Diseases at School of Tropical Medicine, and Dr. Sanjay Bhattacharya, Consultant in Microbiology, to chair the session. Please.
Good morning, everybody. So it's good to be back, in one's own favorite city, that is Kolkata. Firstly, thank you very much to Shamadeep and Dr. Sudipta, for inviting me. Now, the work at hand over the next 20 minutes is to talk about fungal biomarkers, and I think I have around 20 minutes to do it. Right, so this is what I'm going to talk about. I'm going to talk about, the commonality of infection, how relevant it is. I'm going to talk about, the common fungal biomarkers, especially the pitfalls. And I'm also going to talk about some personal experience that we have with the fungal biomarkers. So regarding the commonality, yes, right. Right. So, I was talking about the commonality of the infection. So, when we talk about fungal infection, most common type that we see are the mold infection, mainly invasive pulmonary aspergillosis. The second most common would be Pneumocystis jirovecii. The others, they are relatively uncommon, but they can be seen as well, like Cryptococcosis, Histoplasmosis, as well as Thalassemiosis. So this is what we did, 1 year back. We computed the burden of serious fungal infection in India, and we showed that close to 6 crore Indians, they are infected with serious fungal infections. And there also we computed, the burden of the various pulmonary fungal infection, most common of which was invasive pulmonary aspergillosis, close to, if you can see the data over there, 2.5 lakhs per year. Mucormycosis was second, but the pulmonary part was, a small part. More common was obviously the rhinocerebral part. Second most common would be then pneumocystis. Others like Thalassemiosis, much less. Histocrypto, due to lack of data, we could not compute the burden. Now, most of these pulmonary invasive fungal infection, their clinical features, they overlap. Not only their clinical features, their radiological features overlap as well. So this is a nice cartoon from a recent article which talks about the spread of the radiological infection. If you would say, for example, cavities, it might be seen in a number of conditions, histoplasma, mold, and so on. So long story short, what it means that only clinical features and radiological features, they may not be sufficient for diagnosis or suspecting pulmonary fungal infection. Talking about radiological features, we had this debate with the radiologists about CT halosign and their importance in fungal infection. And we did a systematic review on that. We could find more than 100 causes of CT halosign. And more specifically, the gist is given at the bottom. The best diagnostic accuracy was for antibiotic resistant neutropenic fever, that is in immunosuppressed patients. But even then, the sensitivity was a mere 50%. So it's just like, it's just 1 out of 2. So enter the role of fungal biomarkers. So what are fungal biomarkers? So there's a definition for it, but you kind of already know it because it's intuitive. It is something which, kinds of help us in discriminating this disease, fungal disease, from other conditions, expressed early, easy to assay, less expensive, and they are reproducible. So these are actually the characteristics of an ideal fungal biomarker. But unfortunately, as I'm going to speak on it, such an ideal fungal biomarker does not really exist. What are the common fungal biomarkers? I've listed them in the table at the top. So galactomannan, beta-glucan, PCR are some of the common fungal biomarkers, and I'm going to talk about them. Now, fungal biomarkers, they have got their, they have got their place in the algorithm. Most of the algorithms, ASPICE does not have it. For those of us who use URTC MSG or BM ASPICE, I marked it over there. There's a significant role of fungal biomarkers. Now, let us just, over 20 minutes, I think what would be sufficient is if we talk about some of the common fungal biomarkers in a bit detail so as to improve our understanding. So comparing galactomannan and 1,3-beta-glucan, if you see the structure, so both are polysaccharides, right? So this is the structure. So we can see the plasma membrane marked as PM. Beyond that is the cell wall. So the brownish part, the galactomannan, the orangish part, that is the beta-glucan.
Galactoman is mainly used for IPA, 1,3-beta-D-glucan. So it is used for invasive candidiasis, as as topic is primary invasive fungal infection. So there, 1,3-beta-D-glucan is, again, it would be used mainly for invasive pulmonary aspergillosis. What is important is that, one has a clear idea about this. So this talks about the organism in which one antigen is common and is present and the other is not. So if you would see the intersecting part of the Venn diagram, Aspergillus, Histoplasma, Fusarium, these are the conditions in which both may be present, beta-D-glucan and galactomannan. The beta-D-glucan only may be present in Candida and Pneumocystis. And there are, a few conditions, importantly Mucor and Cryptococcus, where both might be absent. Blasto is not common in India. So here is a condition where galactose may be positive and beta-D-glucan may be negative. So it's good to know, though I'm not sure how commonly you would get to see blastomycosis. Regarding the cost, beta-D-glucan is much costlier, at least 2 to 3 times. And what is important for us also to know is, the false results for both galactomannan and beta-D-glucan. So the false positives, if you would see for galactomannan and beta-D-glucan, they're kind of similar. Antibiotics, some IV fluids, mucositis, other infections. And also the false negatives are kind of similar. Antifungal agents given, they would lead to false negative. They might lead to false negative results. Mucolytic agents, NAC specifically, can lead to negative BAL galactomannan results. So it's good to know this. Continuing the discussion of the difference units, galactomannan, we use usually optical density. Beta-D-glucan, it is usually picogram per ml. 1,3-beta-D-glucan usually used in serum. Galactomannan, serum and BAL, they are approved, but there is also some data in other conditions as well. Common assays, BioRad, France, this is the most commonly used assay, platelia that is. 1,3-beta-D-glucan, Fungitel is a more common assay that is being used. In our institute, also Fungi Expert is being used. For diagnostic accuracy, yeah, I have written it depends because, it depends on the host factors, the sample type, and, it also depends on what condition you're thinking about. So for galactomannan, so I've just delineated the host factors and the sample type. If you would see for immunocompromised, for both serum and BAL, it is 1. And here the sensitivity is more or less okay, but specificity is around 85-90%. But if we keep the same cutoff for immunocompetent patient, that is, we keep the cutoff at 1, then there is problem in the diagnostic accuracy. So that's the reason why that the cutoff has been reduced for immunocompetent critically ill. For serum, it is 0.5, and for BAL, it is 0.8. For BDG, cutoff for invasive pulmonary aspergillosis, which we are talking about, because invasive candidiasis, as we have said, that it's usually not a common pulmonary fungal infection. So the cutoff for IPA is based on the cutoff for invasive candidiasis, so which may not be accurate, but the data is evolving over this. Cutoff for PCP or PGP, as we call it, it may be lower because the levels in PGP they are seen to be much higher than in case of invasive pulmonary aspergillosis. Cutoff also depends on what kind of kits you are using. But usually, if you are using Fungitel, anything above 80 or 80 would be positive. Anything less than 60 would be negative. It also depends on the host factors. So for our hematological colleagues, it actually returns the best specificity close to 91% for one sample. And if you're doing two samples of the patient, then the specificity rises further. For all the other, the specificity kind of decreases somewhat. So just a small case scenario, it's very easy to talk about beta-D-glucan and galactomannan in isolation, but for a complicated patient, sometimes it becomes difficult. So common variable immunodeficiency, Hodgkin's lymphoma, we were treated with some chemotherapy. He was receiving IVIG. He was on azole prophylaxis. He presented with acute respiratory failure, hypotension. Mucositis was there. Patient was on some antibiotic for 2 days, which in the ICU, it was changed to piperacillin tazobactam. He also received Ringer's lactate and plasma expander. Somebody thought that patient has tenuous sputum and started NAC. So you consider these two hypothetical situations, and there might be other combinations. Serum galactomannan is raised, beta-D-glucan is raised, or in the second case, both are negative. But if you would see, there are these boxes, the blue boxes, they are instances of false positive. The red boxes are instances of false negative. So in a complicated patient like this, it becomes difficult to interpret these in isolation. And if you add on to that the biofire or the culture grows something, then the situation becomes even more complex. So there is no right answer whether for whether you would be considering pulmonary fungal infection, but the usual norm is you're happier if these values are negative, because often due to the high specificity, you would use it as a as a rule out test rather than a rule in test. Talking briefly about polymerase chain assays. So in our hospital we are using these assays from pathognostics. They can be used both in BAL as in blood. The sensitivity and specificity they claim is pretty good, but actually the values if you would see may not be applicable, which I'm going to show subsequently in one of the studies which we have done. So this is about ASP-LFD. So this is also being validated in our center as a part of a multicentric study. This has also good specificity and reasonable sensitivity in serum and BAL. This actually detects something called the manoproteins in Aspergillus. Compare this with the Aspergillus lateral flow, both of which are point of care assays. So this actually detects the galactomannan in Aspergillus, and here again the sensitivity specificity they are pretty good. If you're suspecting crypto, it's a good idea to do a serum cryptococcal antigen. So this is the LFA which is being used in our institute. It's important to remember that the values, the performance is much better in immunocompromised as compared to immunocompetent patients. And both instances of false positive and false negative, they may be there. So you need to be aware of this. Or, normally, usually what happens is the ID physician or the microbiologist, we should be, aware of this. If the results are positive, then usually, it should prompt investigation for disseminated infection. So depending on the clinical features, you might want to do a blood culture or the CSF antigen and CSF culture as well. So this is some of the cases that we had isolated and we had reported long back. So immunocompetent patients also pulmonary cryptococcuses may not be that uncommon, and they can present with myriad symptoms and the radiological features, cavitation, nodules, and consolidation. They might be difficult to diagnose otherwise if you're not suspecting it. Regarding histoplasma, you can use the antigen, you can use the serology, and sometimes the PCR. In our hospital, the urinary antigen is being used, so we use the OIDX. The ones from Miravista and IMI, they are, to the best of my knowledge, they are not available in India as such. They have got good sensitivity and specificity, especially if you're doing it from, say, BAL and also blood. Serology is not that helpful for acute cases because the antibodies, as expected, they would take some a few weeks, month to develop. Right. So not much about this. Only that pneumocystis. We use PCR. We use an in-house PCR. You can also use the one from pathognostics. That is the pneumogeneous for your BAL samples. Right. I think I have around 4 or 5 minutes left, so I would try to just talk about our little bit of experience that we have. The invasive fungal infections in our medical ICU, they're not that uncommon. So, invasive pulmonary aspergillosis, they are there to the tune of 11% in our ICUs. And the mortality is significant. It is close to 73% for all invasive fungal infection. For invasive pulmonary aspergillosis, also the mortality is around in the range of 60 to 70% again. Now, this is something which we had done recently, and this has been accepted for publication in my courses. So a lot of time we use BAL galactomannan, but the difference between serum galactomannan and the BAL galactomannan is that serum galactomannan is usually undiluted. BAL galactomannan, it actually depends on your pulmonologist, how much of fluid he is giving. So whether he's giving 40 ml, 80 ml, 120, 160, you can give up till 400 ml of fluid for doing lavage. So what we did was that in patients of chronic pulmonary aspergillosis, mind you, so not really invasive pulmonary aspergillosis, but I strongly believe that the same principle would apply over there. So what we did in these patients, in the different aliquots, we serially measured the galactomannan, and we sent for every patient, 1:40, 1:80, 1:120, 1:160, and we mixed 1 ml of that and send it for analysis. And we saw that, the cutoff and the diagnostic accuracy, it differed in the different dilutions. In fact, if you would see, the red ones means the discordant result. So one sample is showing less than 1, the other is showing more than 1, or vice versa. So this was to the tune of 14 to, the highest was, I think, around 22% over here. So 1 out of 5 samples, they may be discordant depending on what kind of, what amount of instillate you're using to your bowel procedure. So I think, this is interesting, and probably we would like to follow this up in patients with invasive pulmonary aspergillosis as well. Right. We again use that the performance of aspergillus in, again, chronic pulmonary aspergillosis. And we saw that, in bowel galactomannan and bowel PCR, they both fared, pretty badly for, diagnosing chronic pulmonary aspergillosis. So normally the idea is that PCR, as I showed you, they would return a value of sensitivity of 80%, specificity of 99%. But when you do it prospectively in a study, and then you compare it with, the gold standard, which is, in this case, it was the ERS ESCMID diagnostic criteria for chronic pulmonary aspergillosis involving the IgG antibodies by immunocap, we see that the sensitivity and the specificity, they are pathetic. The specificity for aspergillus PCR was 38%. What it meant was that in the controls, which were post-tubercular sequelae patients without chronic pulmonary aspergillosis, the positivity rate was higher in that patient. So, long story short, what I mean to say is that these assays, they have been developed outside. They need to be validated in our patients and our population before which we can, use this data and extrapolate it to our patients. Right. So this is the LFD thing which the mycology department had done. It was a multicentric study, and they returned again pretty good values. They said the sensitivity was close to 84% and 100%. As I said, this is a point of care assay. So this is something which can be done easily and quickly. Apart from this, the last 2 points is that we are also trying to develop an indigenous beta-glucan assay in collaboration with TSTI Faridabad, and we have also started to validate the BMS-ICU algorithm. The BMS-ICU algorithm, for all the intensivists and the ID physicians who are using it, it's an algorithm for diagnosing invasive pulmonary aspergillosis in critically ill patients. It has been not validated prospectively ever. So what we are doing is after the patient is dying, we are taking minimally invasive tissue sampling, and we are sending it for all sort of cultures, histopathology, and PCR assays. And what we are seeing is that the sensitivity is not that great. It would be close to around 50-60% at most in the initial 25 samples that we had done. So, exciting time ahead. And, I particularly am very bullish, and, I'm hopeful about the utility of fungal biomarkers. But what I believe is that till now, we are still not reached the stage where we can use a fungal biomarker and say that this fits the bill and this is perfect. But I think it can happen in the near future. And with that, I would like to, end my talk. Thank you so much.
Thank you, Doctor, for an excellent talk. Actually, about 10 years back, we developed a in-house Candida and Aspergillus PCR as part of a DBT project in Tata Medical Center. And our experience was that even in established fungal infections, and by established, I mean something which is, let's say, candidemia is occurring, or where there is clinical radiological signs of invasive aspergillosis, along with maybe culture positive or galactomannan positive, we didn't see a very high prevalence of PCR positivity. In fact, the sensitivity of the PCR was, as you described, was not good at all. So I was wondering that in your evaluation of these PCRs, whether you had seen a similar phenomenon both with Candida and aspergillosis.
Right. Thank you for the question. So I've not worked yet on invasive candidiasis, but for aspergillosis, especially in chronic pulmonary aspergillosis, that is the thing. As I showed, the sensitivity and the specificity was much less. Having said that, but in chronic pulmonary aspergillosis, I mean, as you would be definitely knowing that it's not an invasive pulmonary infection, so it behaves a little differently from invasive pulmonary aspergillosis. In chronic pulmonary aspergillosis, the fungal burden may be low, so low that the culture positivity in our institute, it is to the tune of 12% only. So IgG is positive in all of these, but culture is positive in only 10 to 12%. So I would like to repeat these and try to validate these PCRs in invasive pulmonary aspergillosis. But I believe that as it has been your experience, probably our experience would be somewhat in that line. That is, PCR assays cannot be one-stop solution for our fungal diagnostic workup.
Thank you.
I have just one doubt about, PCR testing, because if you go by the PCR testing of tuberculosis, so you have two things. What we have been doing, gene expert, that is the DNA particle. And as we all know, DNA in a dead bacilli can be positive. So it's all depends on whether you are looking for RNA particle or not. So transcription mediated amplification of RNA protein of TB. If it is positive, then you are having an active bacilli. That is the understanding about TB. But I don't have any knowledge about fungi, whether we can do DNA, RNA, or these sort of things or not. So what we are doing, is it DNA particle with the aspergillus? If that be so, then aspergillus can have a dead bacilli in the chronic, COPD patient. They do have that. So on the basis of that PCR, I don't think it's fair to give them on voriconazole or posaconazole for a long period of time. So what is your take about that?
Sure, I agree with you. So mainly it is, the nucleic acid, the DNA nucleic acid that we're looking at in these PCR assays. And as you rightly said, since Aspergillus is ubiquitous, it's omnipresent, it can be there in anybody's airway, more so in patients having chronic respiratory disease like COPD. So, so there have been some suggestions. People have said that use two samples, don't use one, use them in series. If both are positive, then it increases your specificity. But having said that, I don't believe that even using two PCR assays would help you in clinching the diagnosis, and would say that two PCR assays are positive, you don't see the patient, you don't see the clinical features, you don't see the radiological features. You can straight away deduce that this patient has fungal infection. So I think that is definitely not the case here. So your point is well taken, and I fully agree with it.
But do you have any DNA, RNA sort of thing in fungi?
No, not to my knowledge. No.
Thank you, Dr. Ray, for a nice presentation.
Sir, I think for still not validated. There are some studies regarding that, but it's not a well validated thing, and it's not available also in commercial. So the research setup they are doing on it, working on it. Sir.
Thank you.
Thank you, sir. So I would now request Dr. Sudipto to hand over a small token of appreciation to our speaker, Dr. Animesh Rai. Sir. Thank you, sir. We move on to the next session.
We move on to the next session, and I think for the next session, I'd like to thank our panelists also for joining with us. The next session will be on a talk by Dr. Anindam Mukherjee, consultant pulmonologist from Heart Lung Institute, and his topic will be bronchoscopy in a cancer and hematopoietic transplant patients. And for this session, I'd like to invite Dr. Shantanu Bagchi, consultant critical care medicine, Tata Medical Center, as a panelist. And as another panelist, I'd like to invite Dr. Ray to join us.
Share visible.
Thank you, everybody. Particularly, I congratulate Dr. Sudipto and Dr. Shomodeep, for my longtime colleagues, for arranging such a nice conference. And also, I want to thank them for calling me here. So, my topic is bronchoscopy in a cancer and uh, hematopoietic stem cell transplant ICU. So, I understand this bronchoscopy is ICU is by Sudipto, and this introduction of cancer and HSCT is by Shomodeep. So, I have divided the two topics. That is the easier way of handling this. Changed. So first topic is bronchoscopy in ICU. The first question is it different? Why should we talk about it in isolation? How it is different from the bronchoscopy in general? It have a higher risk. There's a low margin of error. Lack of space, very important. We are not in a bronchoscopy studio in ICU. Shorter time, minimum accessories, tougher situations, and the most important is more expectations. Bronchoscopy is not going to do any magical thing in ICU patients. It's just a tool to take some samples. So this all the difficult things has to be dealt with before we actually go into bronchoscopy. And then comes the indication. First and foremost indication is doing a lavage to reduce the empiricism in ICU practice. Sensitivity of lavage ranges from, for different organisms, different 60 to 90, 7 to 80, 90 to 95, very well. Good sensitivities, and usually specificities are good also. If there is a bleeding, there is to diagnose airway obstruction, particularly few difficult weaning patients, we have bronchoscopy. Is very helpful to understand a reactive airway collapse, airway clearance, guidance for percutaneous tracheostomy that should always be used. I always emphasize on using this bronchoscopy guidance for percutaneous tracheostomy, which makes the procedure very easy. Rarely for difficult intubation. Bronchoscopy should not come in a difficult intubation algorithm in ICU, because it's for OT. When you know there is a unanticipated difficult airway, you can use bronchoscopy for airway intubation. But for ICU, mostly is a unanticipated difficult airway. Their bronchoscopy will kill time. So the other methods should be used first. And atelectasis or retained secretion for clearing, you have to understand it's most common indication, but it's not always helpful. If there is a air bronchogram present on the X-ray or CT scan, this bronchoscopy has shown not to be useful in clearing the secretion or airway collapse. But it is more useful in brain injury patient, in spinal cord trauma patient, in whole lung collapse, and collapse without a air bronchogram. So is there a contraindication? I'll not utter the word contraindication because they are not absolute. There are some higher risk situations where you should be more and more conservative before going for an invasive test. Like if the patient has a severe hypoxemia, if the patient has recently underwent a acute coronary syndrome less than 4 weeks, uncontrolled arrhythmia, uncontrolled bronchospasm, severe lung inflation with a auto PEEP that is around 15 centimeter or 5 centimeter, 5 to 15 centimeter, pulmonary hypertension, bleeding diathesis, intracranial hypertension, chronic renal failure, pulmonary abscess. Because if you go for a bronchoscopy for diagnosis of abscess, there is a chance of contamination of other lungs that has to be kept in mind, and you can suddenly have a pneumonia in the opposite lungs and immunosuppressive patients. And now we come how it complicate the ICU patients. There is some change in respiratory physiology. If you put a bronchoscope in the airway of a ventilated patient, the most of the cross section of the tube has been occupied by the bronchoscope. Increase airway resistance, give to high tracheal pressure, low tracheal respiratory pressure. Expiratory pressure is high, inspiratory pressure is low. Generate more autopip, increase peak pressure, more chances of barotrauma, and hyperventilation. Together, patient can deteriorate immediately and substantially. So these two things have to be kept in mind. That patient can deteriorate immediately and substantially. I will come to it later. 2-3 complications of bronchoscopy related complication I want to mention. One is infection is not high. It is always around 10% or less than 10%. Doing bronchoscopy per se increases the chances of infection is not very high overall and not also in ICU. And a myocardial dysfunction arrhythmia. So like a perioperative MI, the peribronchoscopic MI is also known because there is increase in heart rate, BP, cardiac output, leads to increased myocardial oxygen demand, which in turn can lead to arrhythmia and ischemia. So you have to monitor everything and you have to select your patient as wisely as possible. And continuous ECG monitoring is absolutely necessary. Otherwise, you can suddenly see a broncho patient who is under cover for bronchoscopy is not having a good pulse. So it's a monitoring is must. Hemorrhage, that is the nemesis for any bronchoscopist. You can have a massive bleeding from a trivial trauma within the bronchus. You don't know which artery, which mucosa is going to bleed. So very cautious about it. And severity is classified according to what measures you have to apply. So there are various measures. And as the more and more intensivists are going to do bronchoscopy in the future in ICUs, so I will suggest all of them to have some experience with control of hemorrhage in normal bronchoscopy shoots, like when to raise the bronchoscope, when to flush saline tropical installation, and when to put a bronchus blockade or shift the patient with a one lung intubation to a OT for further management. That has to be decided on spot, and for that it is very important when you also discussing bronchoscopy in ICU, and the person who is doing should be aware of the possible ways, and if not successful, what to do next. One point I always want to mention: if there is a bleeding, you are having a bronchoscope within the bronchus, then always try to identify the carina. And if you can identify carina, try to protect one lung, which is not bleeding. That should be a motto of doing bronchoscopy in hemorrhage. Now we come to the preparation, how you prepare yourself and the patient for a bronchoscopy. The first one is the conversation with patient or his or her surrogate. So my ICU colleagues is Tata, they know that we usually cancel 40% of our scheduled bronchoscopy during this discussion part, because we tell of high risk and somebody has to accept the risk before we go for a bronchoscopy, because it's not a half-done procedure. If you are committed, you have to do whatever needed. So the patient has to understand all the possible complications. Understanding the expectation of the ICU team, what the ICU team is expecting, whether the ICU team is expecting a lavage only, they need a biopsy, or they need a clearing, and I could plan accordingly. Sometimes we need to do a bronchoscopy just to take out a clot. Then the plan should be different and assess the patient's condition critically. So by this point, I want to mean that neurological status of the patient has to be assessed. But you should not get the blame that after the bronchoscopy, patient is suddenly unresponsive. It is very unlikely to happen. So before you commit for bronchoscopy, you should assess the patient yourself, medicine card to be reviewed, and also all ongoing infusion to be checked before you go for a bronchoscopy. And ascertaining risk-benefit ratio with the patient party, with the ICU consultant, and with the other consultant involved in the team, that how much benefit you are going to offer from your bronchoscopy. So let us discuss a small case. She's Mrs. KB, 89-year-old lady, brought to ICU subacute shortness of breath, and diagnosis made also was a possible right valve malignancy, right pleural effusion because of the right valve collapse. On BiPAP, 15-liter oxygen, X-ray right valve homogeneous opacity, HRCT collapse. So should we do a bronchoscopy? That is the most important question. It's a very tricky situation. Patient may die during the bronchoscopy. But you don't have a diagnosis. You may try. We have tried, and we found a foreign body. When removed, the lungs are absolutely clear. So what I want to mean that indication depends on very individual understanding of the situation and also discussion with all the parties involved. Preparation, adequate space for bronchoscope and bronchoscopy should be ensured before you go for the bronchoscopy. ICU team should accompany throughout, ensure oxygenation, increase the oxygen supply, whatever ways possible, ensure anesthesia. And then after you ensure that oxygenation anesthesia is okay, then ensure your scope safety, because you are not going to do single bronchoscope. You are going to do bronchoscope in the future also. So use a bite blocker, even if going through a ET. Nasal route may be avoided if extra gadgets are there, and scope should not collide with anything, because scope mechanical damage are non-insured. So you should not damage your scope. Doing any brave procedure does not help. without ensuring scope safety. So this comes early. Ensure adequate hemodynamic monitoring, ensure backup. Backup means all the accessories that may be needed and a OT. Their patient can be shifted if there's something bad happens. Minimize bleeding risks to correct all the coagulation parameter when and when whenever positivity. Go by the side of the endotracheal tube if possible, because that decreases the airway pressure little. If not possible, go through the ET and use the highest possibility. Use a catheter mount to minimize ventilator disconnection. Spray as you go. Local anesthesia is must even if the patient is paralyzed, because it helps. Quick in and quick out is the motto, and always try to find the carina. Always try to find the carina. If in your tube and you are not seeing carina, then you are too deep in the right main bronchus. Take out the tube, see the carina, go further. If you are not seeing the carina, you don't go further. That is the basic motto of doing bronchoscopy. Everywhere, also in the ICU. If high risk of bleeding is anticipated, try to switch to rigid bronchoscopy. There you can have more control of the situations. And this is in general acute hypoxemic respiratory failure. We have there are various, these kind of charts are available, various studies have been done. So it is in 50 to 60% cases, it can actually help in changing the management after a bronchoscopy. So this much we are discussing on the Dr. Sudipto's topic. Now we come to Dr. Shomodip's, which is a tougher topic, that should we do a bronchoscopy in an immunosuppressed patient? Should we do it early? And how should we do? So this Dr. Onimesh has already shown us this picture a little differently, only for the fungus, but these all opacities can be fungus, can be viral, can be bacterial. Pattern recognition is an essential part for the bronchoscopist and for the intensivist who are planning for procedures. Whether it's a consolidation only, whether micronodules, whether macronodules, whether cavitations, and what you are expecting most. Because according to that, you can order things to do in your lavage. So pattern recognition very important. So CT is the most important non-invasive test. Then comes all the biomarkers that helps, and then comes the basic question: should we, where the bronchoscopy comes actually in this algorithm? So Dr. Orijit has told us there are so much non-infective causes which can cause a respiratory failure, and before you actually go for a bronchoscopy, you should understand that all the most of the non-infectious causes has been excluded, or bronchoscopy is needed to exclude them. Then you should get a good CT scan. Without a CT scan, doing a bronchoscopy not necessary. Most of the cases, until and for diagnostic purpose, you can definitely shift a patient to CT and get it done. If you not that sick that you cannot shift the patient, bronchoscopy is usually help not much in that patient. It is too late to identify something with bronchoscopy, intervene and help the patient. So have a CT scan, then do a bronchoscopy. If positive, go for targeted therapy. If bronchoscopy is negative, we have to go for the empirical therapy. Do it simultaneously, possibly all non-invasive testing, all the biomarkers, so you have better idea. So this is an RCT. This RCT has from the primary outcome, they have shown whether it is safe or not. Doing a bronchoscopy and immunosuppressed. So it is safe. But it is not more diagnostic than non-invasive test also. So ultimately it has shown it is comparable. Rely only on non-invasive test or going for bronchoscopy along with non-invasive test does not actually differs in diagnostic yield, but it also does not increases the mechanical ventilation or intubation rate. Then comes this article. It's a extract from the AFARM trial. AFARM trial is a trial on the immunosuppressed for respiratory assist. That is whether a HFNC BiPAP intubation, which is going to help. And from where, when these patients who have underwent FOB and who have not underwent FOB were taken out, then we have this chart where we are saying that if you do a FOB, you are definitely diagnosing more causes. But these causes are usually early anticipated, and most of the cases they are treated. So when we come to the mortality, in this Kaplan-Meier curve, it is not showing that, this is not a Kaplan-Meier curve, it's a plot, but it is not showing that the mortality is less with bronchoscopy. On the contrary, it is showing if you do a bronchoscopy in immunosuppressed, in a large cohort of 1,687 patients, there is increased mortality. Though it is not an RCT, it's a post-hoc analysis, not much believable, but this is a point to carry in your mind that doing bronchoscopy is not going to solve all your problem. Even it can increases the mortality. And Dr. Onimesh has discussed very elaborately on this, that some biomarkers may be a little better when we do it in lavage, like galactomannan. They can have a better sensitivity and specificity rather than their serum counterparts. And so they can be used. Whenever you put a bronchoscope inside, you can also have samples for that also. And this is another trial. This trial has been particularly done in hematopoietic stem cell transplant patients, and they have shown that doing an early lavage is better than doing a late lavage with a decreased mortality. So there are trials in both ways. Whether you should do a bronchoscopy and not do a bronchoscopy, that still is not a recommended thing. It also depends on a lot of understanding and individualization. And also we know that if you do for a multiplex PCR, then the lavage is the base sample to do a multiplex PCR. So that's all I want to discuss on this topic. I have not gone into the differentials of acute hypoxemic respiratory failure that has already been dealt with. What I want to conclude as that doing bronchoscopy in ICU, whatever ICU you are working, first thing is to doing it properly. First thing is to being expert at it and not putting your patient in any kind of risk by doing a bronchoscopy. If that are ensured, then we can discuss about the indications. And the indications are individualized, ICU specific, and according to that, the bronchoscopy in ICU can be done. Thank you.
Thank you, Dr. Arindam. I think this is a very pertinent topic. We give doctor referral for non-intubated hypoxic respiratory failure patients for bronchoscopy. And I think exactly this is the part we discuss, whether it is risk benefit wise, it is beneficial to the patient or not. So any comment from the panelists?
So very nice presentation, doctor. So, okay, right. So, obviously, doing a bronchoscopy in these patients are very challenging. So, two comments, and I wanted your opinion regarding this. So, you showed that patient on BiPAP. So, previously, you used to, do a lot of bronchoscopies on patients on BiPAP. Now we have moved to high flow nasal cannula. So, I guess that would also be your practice because it makes the bronchoscope is life a lot easier if you're doing it on high flow nasal cannula. And the second point is, especially when you're doing it in immunosuppressed patients, what we have noticed is that post bronchoscopy, hospital acquired infection, mostly due to, the bronchoscopy, that may be a problem. So what we try to do, we have not been able to fully successful, is to use single-use bronchoscopes in immunosuppressed patients. So I feel that even that, can help in some way in decreasing the post-bronchoscopy complications.
I agree with you. The issue is that the cost. So even we are using in here Tata a lot of AMBU bronchoscope, but that has to be reused. We cannot afford at 35,000-40,000 as an instrument cost for a single bronchoscope. It is not possible till now. I think it will be possible in AIMS. In Chandigarh, they are also doing, but they are also doing ETO on that. So that is the issue. And secondarily, if you have a dedicated ICU bronchoscope and regularly disinfected, high-level disinfection is done, then usually it is also very safe in giving secondary infection. It is not that easy to get an infection in a bronchoscope which is properly disinfected with Sidex, 20 minutes dipping, proper cleaning, mechanical washing. That can be done.
I agree with you. So, the only
The
point.
problem is that most of the center, what they do, they bring their bronchoscopy instrument to the ICU.
Okay.
That is not done. That is not helpful. But if you have a dedicated bronchoscope for your ICU, then it's done. And another thing, I have a little doubt about this AMBU scopes is there. These scopes are not very good for therapeutic procedures. So if you are in a problem, then these bronchoscopes can suddenly break down.
So absolutely, they're not supposed to use for therapeutic procedures. That is one. I would like to just end with a question: how commonly do you end up doing anything beyond bronchoalveolar lavage in your ICU patients on oxygen?
So that's a very important.
For example, TBLV,
question.
because I've seen catastrophes happen, and we are a little wary about that, but we sometimes
very important question, sir. So I personally prefer not to do transbronchial lung biopsy in a mechanical ventilated patient. We'll refer the patient for surgical lung biopsy. Putting a rigid bronchoscope, doing a cryo is also very difficult. So how I have trained or I have learned that if your patient is in mechanical ventilation and you need a biopsy, the best way to do it is surgical lung biopsy. And now the VATS has made the life a little easy. The surgery can be done easier.
In the just one slide, you have said that doing bronchoscopy in ET tube, we always go by the side of
Yes,
the
sir.
tube.
Yes, sir.
That means outside the tube?
Yes, sir. I want to mean they go through your nasal way and then you enter the vocal cord by the side of the tube, deflate the balloon, you can go beyond the tube, take the lavage and come. It
The
helps in
question
2-3
is,
ways.
if you are doing just diagnostic, then it takes about 1 or 2 minutes
Diagnostics,
maximum.
okay. This is
Yeah.
particularly for percutaneous tracheostomy, sir. If you are doing a tracheostomy and you are having a bronchoscope guide, if you put the bronchoscope in the ET tube, it's for almost 3-4 minutes.
Tracheostomy is fine.
If you are going by the side of the ET tube, you can place the ET tube properly. You can have a proper observation of your needle going in and then take it out. So complication is a little less. You need a little smaller diameter bronchoscope like our pediatric bronchoscope, and a tube size 7.5 to 8 is okay. You can go by the side.
Yeah, that's the point. I always tell my junior that if you have scope to put a 8 tube, then always do that. Don't go for 6, 6.5 or 7, because
true.
my bronchoscope is 6. So if my unit bronchoscope is 5 or 4, then you can go for 6. So it's always advise them to use that size because you have a well access to that tube and you can go.
One more thing, it was a very nice presentation, our old friend and colleague Dr. Arindam. So from the, there is a recent paper in NEGM regarding prophylactic platelet transfusion before central venous cannulation. So from your practice, although we are aware still, do you follow anything like that before bronchoscopy in hematological patient?
We have a platelet which is more than 50,000.
That you make 50 or 15 you follow?
50. 50 is the ideal we want. But if a Orijit's patient come and we cannot have a platelet over 15, so 15 we consider. It's like a in a mudi dokan with Orijit always.
Thank you.
But oncology setup.
Laksai.
Got it.
But you cannot say it in the presentation.
30,000 now we have.
Thank you, Arindam. So we like to conclude our first part and we will take a small break. Before that, a small memento from our side to Arindam. Thank you. We'll take a small break for a tea and we'll get back by 10 minutes. So we'll take a small break for the tea and we'll join in 10 minutes.
ল্যাপটপ কানেক্ট করা যাবে না, জুমে আছে তো। জুমে আছে, কোনো অসুবিধা নেই। আমি তোকে পিন ড্রাইভ দিয়ে দিচ্ছি, তোমাকে আমি হোয়াটসঅ্যাপ করে দিই, করে দে না হোয়াটসঅ্যাপ। অডিটোরিয়ামটা খুব সুন্দর, দারুণ, খুব সুন্দর অডিটোরিয়াম। এই তোমাদের অডিটোরিয়াম তোমরা এমনি ভাড়া দাও না, টাকার কাজে না না, ভালো কিন্তু অডিটোরিয়ামটা, এটা তো এই পাওয়া যায় না। আমি পিন ড্রাইভ করে না, পিন ড্রাইভটা খুলবো। আমি তো কলকাতায় যতগুলো
পিন ড্রাইভ
পেন ড্রাইভটা কেন
কি ইজেক্ট করতে চাও?
হ্যাঁ, ওর প্রেজেন্টেশনটা আমি পেন ড্রাইভে দিই, ওর কিন্তু পেন ড্রাইভে দিতে পারি, মেল করতে না পারি। এবার শুনছি ফার্স্ট অঙ্ক ইন্টারফেস আমার এখানকার এই
এইটা না, জিটা না,
বেশি বলবো
ওটা অনেকক্ষণ আগে
ক্লোজ করি।
হয়েছে, তুমি দেবরাজের প্রেজেন্টেশন পেয়ে গেছো? পেয়ে গেছো প্রেজেন্টেশন?
So, welcome after the debate session. And after that, we will start with a very interesting talk that is on steroid in diffuse pulmonary disease. That we know that in intensive care, we have a very low threshold. We just want to add steroid and expect some miracle when the patient is not improving. And to throw some light on that, I'd like to welcome Dr. Debraj Josh, consultant in critical care and pulmonology, Apollo Multispecialty Hospital in Kolkata, and he's my junior in my college. So welcome. And I'd like to ask Dr. Animesh Roy to chair the session.
Somadip, thanks to Sudipto Da as well as Somadip for inviting me to speak on a topic of steroids in DPLD. So before going to what are the two things, so we need to know what is steroid and what is DPLD. So DPLD, as it is there from the nomenclature, although it is not used nowadays much, the term which is nowadays much more used is the interstitial lung disease. So it is a heterogeneous group of the disorders which will impair the gas exchange function of the lung by disrupting the alveolar wall, and how steroid will act in diffuse parenchymal lung disease. So over the coming 15 minutes, what I will show different cases, and each of the, because we all know ILD encompasses of different subcategories like idiopathic pulmonary fibrosis, like NSIP, like organizing pneumonia, like hypersensitivity pneumonia. So what I have tried, I will show different cases, and in different cases, what is the role of the steroid and what is there in the literature, whether there is a consensus among all the literature, or whether there is no clear-cut guideline regarding how much steroid, or whether actually it is to be given or not. So how does steroid act? So steroid in anywhere in the body, the mechanism of action is similar. The mechanism of action is that it will inhibit the leukocyte traffic and access of the leukocytes to the site of the inflammation, number one. Number two, it will interfere with the function of the leukocyte, fibroblast, and endothelial cell. And number three, it will suppresses the production of the humoral factor involved in the inflammatory process. So if you ask me, it will have a role in both humoral immunity as well as cell-mediated immunity. It has a role in both of the cases. And in any of the cases, what is required is the binding to the glucocorticoid receptor, and adverse effect can be minimized by the reduction of mineralocorticoid activity, because when you are using the steroid, we all know there are three activities like glucocorticoid, mineralocorticoid. Here you are targeting the glucocorticoid activity of the steroid. So or whatever side effects which used to happen with using of such a high dose of steroid, we tend to reduce the dose of the mineralocorticoid activity by selecting those steroids which are more potent, which have more potent glucocorticoid activity rather than the mineralocorticoid activity. So it will inhibit the nuclear translocation and function of the pro-inflammatory cytokine like AP1, NFK beta, and synthesis of the anti-inflammatory proteins. So it depresses the production of the pro-inflammatory cytokine and increases the anti-inflammatory. Now, use of the steroid is dependent to some extent on the staging of the ILD, which is very important. So apart from some of the ILDs, usually it starts from the inflammation phase and ultimately it goes to the fibrotic phase. So steroids anyway are going to be effective much more in the inflammatory phase rather than the fibrotic phase. Patients with sarcoidosis, cryptogenic organizing pneumonia, acute hypersensitivity pneumonia, and eosinophilic pneumonia gradually and generally respond rapidly and usually had a very good response leading to the rapid recovery. So use of steroid in DPLDs, the steroid treatment increases the FBC percent and DLCO in non-fibrotic HP, but not in the fibrotic HP variety. And in fibrosing ILD, although the complete reversal is not possible, short-term corticosteroids still have a role in stabilizing rapidly progressive disease. To summarize, what do I mean to say? So in non-fibrosing ILD, we all know it will improve. It will improve the FBC, it will improve the DLCO percentage, it will improve the symptom perception, everything. However, in non-fibrosing ILD, in fibrosing ILD, although it doesn't have a typical role in preventing the fibrosis, still it may have a role in rapidly progressive disease. And in connective tissue disease ILD, available data are contrasting, and previously we tend to use the dose of steroid much more, But nowadays, we are tend to in much more in favor of using other immunosuppressive drugs rather than steroid. And in whatever category of disease we will be talking about, we tend to reduce the dose of steroid and wean the dose of steroid as quickly as possible. So this is the use of steroids in DPLD. So if we go in systemic sclerosis, as we all know, there is a strong recommendation against the glucocorticoid, and even if it is used, the dose of 10 mg or more should not be used to prevent the renal crisis. And in all other categories, you can see myositis, MCTD, rheumatoid arthritis, Sjogren. So you can see there are multiple other immunosuppressive agents which are nowadays in our basket, so that even if we tend to use the glucocorticoid, the important term is the short-term glucocorticoids are there. So it should not be used for a prolonged period of time. Previously, what we used to do, we used to put our patient on a maintenance dose of 5 mg, patient is put on a long term. So nowadays, we are not using that much. Now, studies have shown benefits, including improved modified Rodnan skin score and improvement of stabilization of PFT. So, but high dose steroid, as I already told you, is contraindicated to prevent the risk of the scleroderma renal crisis. And oral glucocorticosteroid with or without another immunosuppressive agent are first-line therapy for symptomatic patient with sarcoidosis with abnormal pulmonary function test and infiltrate. So sarcoidosis is a disease in which the oral glucocorticosteroids are always the first-line treatment of the choice, and probably the only disease in which we tend to use the steroid over a longer period of time. And gradually we do not replace with the, usually we do not start immunosuppressive agent only when your patient has a relapse or when the patient has a again refractory kind of sarcoidosis, then only you tend to start other immunosuppressive agent along with the steroids. Now I will go to certain cases. So this is the first case. The first case, this is a 65-year-old male who presented with an insidious onset, gradually progressive shortness of breath, cough, generalized weakness, arthralgia, and on examination, clubbing present with an bilateral. So in a nutshell, we are dealing with a patient of 65-year-old who is having interstitial lung disease. On chest X-ray, HRCT was done, which was again classical of the ILD. So you can see the significant amount of traction bronchiectasis has already happened. Honeypungim with a subpleural predisposition, chest X-ray you can already appreciate. And the histopathological investigation, transbronchial lung biopsy was done, which revealed a feature of the usual interstitial pneumonia. And the bronchoscopy guided cryobiopsy was done, which actually revealed the finding of UIP. So now in a background of UIP with no significant other history, so probably we are dealing with a patient of idiopathic pulmonary fibrosis. And as usual, we have put the patient on antifibrotic drug. Now, after 1 month, so in IPF, steroid is not recommended in any guideline, and this has been in use for almost 10 years. So after 1 month, this patient again presented with increased cough with expectoration, increased breathlessness, fever. He was on antifibrotic drug for last 1 month. No pedal edema, chest, you will not be able to appreciate anything because always there will be bilateral crepitation. Now this is the CT scan. So what we should do, and you can see in the first CT scan, again I'm going to the first CT scan. So yeah, here you can hardly appreciate any ground glass. So there was no ground glass in this CT scan. Now your patient presenting with increased shortness of breath, and you can see there are a lot of patchy ground glassing is there. So what could be the main important reason? The most probably he could have got some kind of viral infection or something which led to the exacerbation of the ILD. And the patient has a high total leukocyte count and high ESR compared to what was there in the previous examination. So now this is a question whether the decision was right or not. So antifibrotic drug with a pulse dose of methylprednisolone 0.5 to 1 gram per day. So when we are talking about pulse dose of methylprednisolone, it is not always the 500 mg dose. So in ILD patient, what we used to define the pulse dose, it is around 0.5 to 1 mg, 1 gram per day. So for 3 days. Now, So is there in the literature which can certify those things that the pulse methylprednisolone has been given even in presence of high total leukocyte count? So there has been in nowadays in recent literature significant shift away from the corticosteroid, not only in the IPF routine treatment but also in acute exacerbation. The international consensus still offers a weak recommendation for the use of steroid, but their efficacy is far from accepted, and significant debate exists regarding the appropriate type of the steroid, appropriate dose of the steroid, appropriate duration of the steroid. This is another article which has been published in Expert Review of Respiratory Medicine. So they found that they administer systemic corticosteroid and most patients are treated with 500 to 1000 mg of methylprednisolone daily for 3 days. And they have found, along with the Japanese guideline, that they should be treated with corticosteroid, including pulse therapy. So these are the two literatures which which suggested and which found beneficial result with a pulse dose steroid of 0.5 to 1 gram per day in a patient with acute exacerbation of IPF. However, in guidelines or other literature, it is not recommended. You can use acute exacerbation steroid, the dose, but not the pulse dose steroid. But it is debatable. And high dose of, this is the contrast study, that the high dose of corticosteroid are not that much beneficial in acute exacerbation of ILD, and clinical outcome will mainly depend upon the clinical condition and extent of the lung injury from the acute exacerbation. So probably it will depend upon the cause of the acute exacerbation. In viral kind of exacerbation in the later phase, like the first week or onwards, probably they will respond better to the dose of steroid, not likely typical to the pathophysiology of ILD or not thing in the viral pneumonia or those kind of setting. So this is very debatable how much steroid to be used or not to be used in acute exacerbation. Now going to second case. So this is a 50-year-old male who presented again with a classical history of ILD. I will not go into details. On radiology, you can see this is a very typical CT scan where you can see bilateral consolidation by basal consolidation. So you cannot typically coin this CT scan with an ILD patient because this is a bilateral consolidation, patchy consolidation. So it is very difficult to say whether the crepitation is due to this consolidation or whether the patient per se is having some kind of ILD or not. And the patient is having normal total leukocyte count, and bronchoscopy was done, high pass cell, but the culture, gene expert, everything came out to be negative. So the patient primarily treated with antibiotics and the nebulized bronchodilator, no improvement clinically as well as radiologically. Then because we excluded all the infection by doing the bronchoscopy, then we started the patient on the steroids. Systemic steroids were added. Patient improved clinically and symptomatically and discharged with oral macrolides and oral steroid with tapering dose. So probably this was a case of cryptogenic organizing pneumonia, which, or we cannot, when we used to coin the term cryptogenic, when we were unable to find any cause or whether we are unable to label this organizing pneumonia to any etiology, then we coined the term cryptogenic organizing pneumonia. So steroids are generally accepted to be the standard treatment for cryptogenic organizing pneumonia. However, no optimal treatment modality has been precisely defined. So the classical dose is till date 0.75 mg per kg per day prednisolone for 4 weeks, followed by 0.5 mg per kg per day for 4 weeks, then 20 milligram per day for 4 weeks, 10 milligram per day for 6 weeks, and 5 milligram per day for 6 weeks. Also, there are heterogeneity of bronchiolitis obliterans organizing because all BOOP doesn't behave in the same way. In BOOP also, there is a term called organizing pneumonia and bronchiolitis obliterans. So whether the organization pattern is much more or whether the obliterans pattern is much more. So if the organization pattern is much more, we can also use some little bit higher dose of steroid like 1 mg per kg per day for 1 to 3 months, again 40 mg per day for 3 months, and 10 to 20 mg. So there is a controversy regarding the use or duration also. Duration is much more controversial. Many are an advocate of using it for a 3-month period. Here you can see it to be used for almost 1.5 years. similar kind of North American study. So this is case 3, a 46-year-old female who presented again with a typical ILD-like history. On past history, there is a polyarthritis with plantar fasciitis since 2017. PET-CT proven inflammatory disease of multiple joints and bilateral plantar fascia, diagnosed as undifferentiated CTD, ANA positive, room air saturation 92 to 94%, and chest bilateral crepitation. So if we go to see the lung cut, I will not go into the mediastinal cut. So you can see bilateral patchy ground glassing present, not typical distributed but symmetrical. So more or less bilateral patchy ground glassing involving all the lobes with an interstitial septal thickening. Although the term NSIP is coined, but it is not a typical NSIP pattern. Transbronchial lung biopsy, cryobiopsy was done to evaluate the cause, and the diagnosis of NSIP was made. The treatment which was given again was antifibrotic and oral corticosteroids. So antifibrotic and oral corticosteroid. Now again there is a question. Although in the although in the transbronchial cryobiopsy there is presence of the non-specific interstitial pneumonia. So if it is non-specific interstitial pneumonia, then we should not have added steroid. But if we go by the radiology, looking at the amount of ground glassing, then steroid should be added and antifibrotic should not be added. So we also are typically not sure as a clinician what exactly we are dealing with, and we are giving the patient with a steroid in addition with the antifibrotics. This is case 4, a 41-year-old male who presented with a non-productive cough for 1 year, progressive shortness of breath. So again with an ILD kind of history, and had a past history of primary biliary cirrhosis, ANA and SP100 antibody positive, room air saturation of 94 to 95%. Rest of the investigation normal. I will directly go to the CT scan plate. So if we see the CT scan, so here we can see there are multiple patchy centrilobular nodules present throughout both the lungs. In many of the cases, there are presence of the Trinbart pattern also. So exactly we cannot correlate this CT scan. If we go downstairs, much more nodular pattern with a bibasal septal thickening and dense consolidation. Here also in transbronchial lung biopsy, there is a usual interstitial pneumonia pattern. Now, this is why every pathology report should not be believed. This cannot be a patient of IPF. Even when I am getting on histopathology UIP pattern, so the treatment should not be just with an antifibrotic, depending upon the amount of ground glassing or those things. So the patient was given immunosuppressive agent with a steroid and mycophenolate mofetil because the clinical history was suggestive of an autoimmune disease with a background. So probably we are dealing with some kind of CTD ILD, and the patient responded very well with the steroid and MMA. This is case 5, a 59-year-old male patient who presented with a recurrent history of hemoptysis, had a past history in October 2022 with a left upper lobe consolidation with hemoptysis, similar presentation with right upper lobe involvement in December 2022, and room air saturation of 88 to 89%. On blood investigation, strongly positive C ANCA, which was present. So probably dealing with a patient of granulomatosis, polyangiitis, or Wegener. Sputum negative for everything. Urine also 10 to 15 RBC. CT abdomen revealed pyelonephritis, and echocardiography moderate pulmonary arterial hypertension. So we straight away underwent for the renal biopsy. This is the CT scan. You can see patchy confluent area of consolidation with a ground glass opacity. This is not typical of Wegener, but if the when you are doing the bronchoscopy, if in this kind of CT scan you are unable to find anything in the culture or the galactoman and everything comes out to be negative, and with a background of strongly positive C ANCA, this may be per se manifestation of the Wegener itself. So in renal biopsy, the findings were interstitial nephritis with an ischemic glomerular changes, and the diagnosis of granulomatosis with polyangiitis was made. This patient was initially started on pulse dose of methylprednisolone followed by oral prednisolone. So this is a case in which the lung finding, although were not typical to start with an high dose pulse methylprednisolone, but based on the other parameters, we put our patient on the pulse methylprednisolone. This is another case, a 56-year-old male patient who presented with an, again, typical ILD history. And if you see the radiological investigations, so this, the left-hand side is the 28th November 2022, and the right-hand side is the 13th March 2023. Here you can see the ground glassing amount has increased significantly compared to what was there almost 5 months back. And this is the better one. Even in the lower portion of the lung, there is a significant increase. And when we sent this patient for other investigation, anti-dsDNA borderline positive, anti-RNP-SM positive, other factors came out to be negative. Transbronchial lung biopsy, there was presence of bronchiolitis obliterans organizing pneumonia. So we probably missed the diagnosis in the first time when it was in the beginning phase. Later on, when it engulfed into the mature phase, then we were able to establish the diagnosis, and then we put our patient on high dose steroid and patient responded. This is another patient, a 33-year-old female patient who presented with a cough, shortness of breath, didn't improve, use of multiple times systemic steroid, typical ILD kind of history. This is the radiological investigation. You can see not typical interstitial septal thickening or those kind of thing, multiple nodules scattered throughout both the lung. So when we do, this is very classical. When we do the expiratory scan study, we can well appreciate multiple areas of the air trapping and mosaic attenuation. And with a typical history, probably we are dealing with a patient of hypersensitivity pneumonitis. And this hypersensitivity pneumonitis, when we did do the transbronchial cryobiopsy, you can see in report also there was presence of hypersensitivity pneumonitis. So in all the cases, it is very difficult to find out the offending agent. So the classical treatment is removal from the offending agent. When you are unable to do so, and when your patient is that much symptomatic, you should put your patient on the steroids. So patient was managed with a 3-month course of tapering dose of oral corticosteroid. Last case, the 47-year-old female, again with a dry cough, progressive shortness of breath with a typical ILD-like history. This is the CT scan. So you can see there are presence of bilateral nodules along with interstitial septal thickening, not that much lower predisposition, not that classical lower low predilection. So when we go this, this patient was diagnosed earlier as a patient of sarcoidosis, and patient was started on steroid, and significant radiological and clinical improvement on a chest X-ray was happened, and he was discharged with oral prednisolone ICS plus formoterol inhaler. And on follow-up, you can see this is the CT scan. So we can well appreciate that much amount of ground glassing or that much amount of nodules which were present in the earlier CT. So it was reduced, and the prednisolone was gradually tapered down to 5 mg over 2 weeks, and MMF was added and patient was put on. So why this patient was put on immunosuppressive agent in spite of stopping the steroid? Because the patient had a recurrence of the sarcoid. So that's why he was continued on the steroid dose. So clinical, again, just to last 3-4 slides, the clinical course and outcome of RA-associated UIP. Previously, although 50% of the UIP treated with steroid and immunosuppressant presented improvement, but without significance. So previously, any patient of RA-ILD, we tend to use steroid for a long period of time, not that much in nowadays. We tend to prefer the immunosuppressives compared with the steroids. So take home message, steroids effective in mostly acute exacerbation of all ILDs. So whenever you have a patient who is presenting with an acute exacerbation, they are mostly effective in all subtypes in acute exacerbation. It is used much more in HP, cryptogenic organizing pneumonia and sarcoidosis, not to be used in fibrotic ILDs that much. Infections always to be ruled out before initiating the steroid, particularly giving pulse dose steroid or high dose of the steroid. PCP prophylaxis to be given in all patients who are receiving pulse dose of the steroid. Thank you very much.
Excellent cases. Just regarding case 4, I was just going to the history and the CT pattern. There was no honeycombing in that. And it's a kind of ILD which I thought it could be not UIP, anything other than UIP, but the biopsy says UIP. And I was just wondering that about that biopsy, it's very important that how good or how bad your pathology is, because you are giving very tiny tissue. And I stopped doing, transbronchial biopsy because my histopathologist was saying every time there is no lung tissue, there is no this, that is. Then I stopped doing that. But in all your cases, you have a good tissue, and
Sir,
also
yes, sir.
and also they have commented. But again, this NIP or NSIP and UIP is sometimes all depends on the, I think, more radiological than histopathological. Histopathological becomes very difficult in that way. So what is your take about your institution?
Sir, as you already pointed out, the experience of the pathologists, particularly in seeing different ILD subcategories, is very minimal. So we cannot blindly trust on them. This is number one. Number two, what we used to do previously with the conventional transbronchial lung biopsy, with the crash artifact and all those things, the quality of the specimen was also not up to the marks. Third, nowadays we are using cryo. So with the use of cryo, the size of the tissue, it is almost 2.5 times than what was used to be with the conventional transbronchial lung biopsy. Now there are two school of thought. Now suppose this patient had an UIP. So one school of thought is that, so what you are having UIP, it is not a homogeneous quantity. So your lung may have an NSIP pattern in one position, it may have an UIP pattern in another position. Second thought is that what is there in the NSIP may eventually convert to UIP. So it may be that the pathologist had found out the portion which is the UIP. But if you go by the radiology, because we all clinicians, we will also give a substantial amount of importance to the clinical history, physical examination, as well as the background, whether if the patient is having any CTD kind of presentation and radiology, as you already pointed out. So in absence of that much amount of substantial fibrosis, and particularly when the patient is having that much amount of ground glass, so we all, as a clinician, we will always be inclined to give the steroid and immunosuppressive trial. If your patient doesn't improve within a span of 6 months, then we can have a repeat CT to look at whether the eventually fibrosis part has increased or not. Then we may think of starting antifibrotic drugs.
Thank you.
Right. Thank you, Devraj, for that impressive collection of cases. But I'm just wondering, at Tata Medical Center, there might be a scope of using steroids beyond the realm of DPLD or ILDs. So your comments on the use of steroids in other diffuse lung diseases, for example, severe community-acquired pneumonia, PCP, COVID, and ARDS. So briefly, if you could just point.
So if we start with pneumocystis, so it is much more straightforward. You tend to use the steroid because it is clear cut. Along with the use of cotrimoxazole, you need to use the glucocorticoid. So there is no confusion regarding the fact. In ARDS, it is much more controversial whether you should use, you should not use. There are multiple trials in favor, against use, even if it is used in the second week, not in that much dose of the steroid. So it is not that much clear cut. Third is that in patients with a severe community acquired pneumonia, again, it is much more debatable whether in a patient without any septic shock or without any patients, like the septic shock criteria of using steroids, if a patient doesn't fulfill. So to use that much amount of steroid in a community acquired pneumonia, in which in most of the cases probably we are dealing with some kind of bacteria. So I will never advocate use of that much amount of the steroid in community acquired pneumonia. In any patient presenting with a diffuse alveolar hemorrhage, because as we already told, in particularly in onco patients or hematological malignancy where you are dealing with such a low amount of platelet, with presenting with a hemoptysis. So in those kind of patient, it is impossible to do the bronchoscopy, as Arindam were also telling. So in those kind of patient with a radiological diagnosis of diffuse alveolar hemorrhage, you are unable to pinpoint the cause. Probably the cause is some kind related with the platelet. So in any category of the diffuse alveolar hemorrhage, steroids act well. So probably in oncological setup, so diffuse alveolar hemorrhage is one of the very important. Second important thing is that many a times the problem with usage of steroid, we tend to have a lot of ground glassing and all those things. But your patients also, because of the immunosuppressant nature of the individual, also tend to have a lot of atypical infection like fungal, CMV, PCP as well. So it is very important to do the bronchoscopies if possible before starting the patient on randomly on steroid, apart from the diffuse alveolar hemorrhage due to low platelet. So these are the oncological background in which we tend to use the steroids.
Thank you, Devraj. Thank you.
Thank you, Dr.
Thank you,
Devraj.
Sudipto.
We just want to get a small token of appreciation. Thank you, sir. So we'll go to the next session and it will be a panel discussion. And after the introduction of ceftazidime avibactam, at least we all aware, we are having a lower threshold to give it empirically. And probably we are moving away from polymyxin-based therapy in our critical practice. But we know that there are bugs which are not covered by ceftazidime avibactam, and for example, acinato. So whenever we are giving empirically, it can be a little tricky depending on your unit's practice. And for that, we have a very eminent panelist along with the moderator. So first, I'd like to welcome Dr. Sushruth Bhattacharya, who is the Director of Critical Care AMRI Hospital, and sir will moderate the session. And the panel will have Dr. S.N. Haldar, Assistant Professor, Department of ID and AM from Kolkata. Sir, please join us. Dr. Ajay Krishna Sarkar, who is the Clinical Director of the Critical Care Unit of Peerless Hospital. Dr. Shaurya Ghosh, who is a Hematology Consultant in Tata Medical Center. And Dr. Sanjay Bhattacharya, who is our Head of the Clinical Microbiology Department.
Good afternoon, and I thank the organizers for inviting me to this academic session. And we have got an eminent panel. We have one clinician along with the chest specialist, Dr. Ajay Sarkar. We have got, I think, an infectious disease specialist, Dr. Haldar, I guess, yes. We have got a microbiologist, Dr. Bhattacharya. And we have got Dr. Ghosh, who is infectious disease. You are in hematology, sorry, you are in hematology. So anyway, we have got more or less all our, critical points covered while we plan to embark upon embark upon a discussion on one of the main problems of our treatment of infectious diseases nowadays in critical care, that is the resistant bugs. Basically, we mean by resistant bugs, these are mostly gram-negatives. I'll ask, of course, the panelists what their experience is, but we feel that mostly it's their gram-negatives, and mostly the question starts creeping in once they're carbapenem resistant. And then we have got the problem of what to use, because whatever we use, the results are always not very good. And there are some issues about what antibiotic to use. After the first emergence of the carbapenemases, we were tilting towards an age-old antibiotic group, that is the polymyxins, that is polymyxin B and colistin. And now we have got some new antibiotics which are novel BLIs combined with old beta-lactamase, novel beta-lactamase inhibitors. So before that, with this short introduction, let me start with the panelists. I'll start with the clinician first. Ojeda, in your ICU, I think you'd be, speaking on behalf of most of the ICU in Kolkata, what do you feel are the main germs, resistant germs in mostly hospital-acquired infections?
Currently, in my ICU, and as you have rightly pointed out, that most of the ICUs in Calcutta are having gram-negative infections more than gram-negative positive, and of which Enterobacteriaceae, mostly the Klebsiella is the organisms we are having major chunk. It's about nearly 60%, and out of which many of them are CRE. So carbapenem is resistant. So now, if we go little bit deeper, CRE in Western world, it's mostly KPC, but in our institution, it's mostly OXA or NDM or both. And that is the scenario. And that is why we are not getting adequate response to the drugs, whatever is available right now. Even with the newer BLI, even with your old, drugs like polymyxin or colistin group of drugs, many a times it's not working. Probably we'll be discussing later with that. And other than Enterobacteriaceae, we do get Acinetobacter. Still, I'm getting on and off Acinetobacter if they are staying for more than 10, 15 days. That was the observation I have, because I was regarding this, panel, I was going through the records and in my unit. So Acinetobacter is a problem if your patients are staying for long. We do get Pseudomonas on and off. It's not more than 10, 15% in my unit. And sometimes Stenotopomonas I'm getting. Occasionally I'm getting Burkholderia. That is the usual scenario in my
Burkholderia
unit.
cepacia.
Yeah.
So I'd go to right now to our microbiologist. Sir, you are the on the other side of the sort of tables, or what do you say, that where the patients are blinded, but you get the samples. So what in you do you only see the samples of this hospital, or you also see samples from outside? Or
no, we actually process only our samples.
so this hospital will be slightly biased because they are catering to a particular group of patients, mostly oncological patients.
Sure.
But do you feel that the menace remains the same, that the same type of bacteria which you feel are hospital-acquired infections, they are have got the same resistant pattern, or do you have something else?
More or less, it is the same. I agree with Dr. Sarkar that Klebsiella is the most important bacteria, and the multi-drug resistant Klebsiella, extensively drug resistant Klebsiella, and sometimes pan-drug resistant Klebsiella are something which is MDR, XDR, and PDR Klebsiella are the main things. We do have the other things that he has mentioned, like Pseudomonas and Acinetobacter. I would say that also in UTI, we do get multi-drug resistant and extensively drug resistant E. coli. We do get very few resistant gram-positives, particularly MRSA or VRE. VRE, we do sometimes get bacteremia or in UTI, and MRSA mostly from skin and soft tissue infections. Sometimes, very occasionally, from respiratory infections. Okay, so this is our profile. But we also should not forget there is another type of drug-resistant organism, which is a multi-drug resistant Candida, Candida auris. So Candida auris can cause fungemia. It can cause sometimes urinary tract infections, intra-abdominal infections. So we do see Candida auris every month, actually, maybe
about couple of candida auris, which are significant every month. So that's.
So we got the picture right now. So even in say normal multi-specialty tertiary care hospital and then oncology tertiary care hospital, the spectrum does not change much. The main organisms remains gram-negatives, possibly Klebsiella pneumoniae, followed by Acinetobacter and Pseudomonas. Sometimes you have occasional multi-drug resistance E. coli, and as Ojada has mentioned, you can also sometimes get something like a Burkholderia or so. So we'll keep our discussion into this three major organisms, gram-negatives. That is the Klebsiella pneumoniae, Acinetobacter, and Pseudomonas. Possibly these three would be the main gram-negative organisms which are creating the problem in our hospitals, particularly hospital-acquired infections. And many of them, as already pointed out, are resistant to carbapenems. So that was our main weapon, maybe 1 or 1.5 decades ago. But right now they have, for hospital-acquired infections, possibly. I'll ask the infectious disease specialist. What do you feel is the status of carbapenems once they were the first-line empiric therapy for hospital-acquired infections? Do you still recommend it for a hospital-acquired serious infection? Do you go for directly for this carbapenems, or you choose something else?
Sir, basically, sir, it depends from where the patient is coming from. If the patient is coming from the community and the patient is not having any risk factor, then I'm
asking only about hospital-acquired infections.
Yes, sir. About hospital-acquired infections, it's better to start with meropenem. But sir, as sir is also saying out, there are two kind of organisms. As one, sir, you have mentioned Klebsiella. Another one is Pseudomonas and Acinetobacter. So for Klebsiella, sir, the resistance mechanism is mostly enzyme mediated, like oxafortate, as sir earlier mentioned, NDM, and all these things. NDM is our unique problem, which is not prevalent in USA or UK. Regarding Pseudomonas and Acinetobacter, the resistance mechanism, it mostly not enzyme mediated. It is porine channels and efflux pump. So the problem is separate. And to start with, meropenem is a good choice. But sir, I think one point I should mention, that is initiation of antibiotic should not consider only the organism. Apart from this, the site of infection, the pharmacokinetics, pharmacodynamics of the particular antibiotic, all these conclusively considered for treatment of a patient. To start with, meropenem is a good choice. But the problem is, if the bug is like the Klebsiella, as the mostly we are getting very bad kind of Klebsiella nowadays, hypervirulent Klebsiella. For Klebsiella, if the straightway is, if it is meropenem resistant, then we can do carbaat test. And if it is like oxafortate.
No, my question was slightly different. My question is that, do you feel, I've got a serious, suddenly one patient has come, the patient was in hospital for more than 48 hours, maybe a few days, and the patient has suddenly developed a sepsis. It may be a blood stream infection, it may be
Yes,
pneumonia.
sir. Yes, sir.
And right now I want to start the patient anyway on an empiric combination. What
Yes,
is your preferred combination at that point of view? Do you still feel that I should start off with the previously the patient was only
Yes, sir.
getting possibly
Yes, sir.
augmented?
Yes, sir. I got your point, sir. So it depends on our hospital epidemiology.
No, I'm asking what do you practice?
Sir, my advantage is I am working both in government setup as well as corporate setup. So I am able to see the both pattern of organisms. For hospital acquired, for government hospital, so it's meropenem is a good choice for it. And for the corporates, mostly the patients are, as I'm working tertiary care, so most of the patients has got multiple exposure of the antibiotics. But to start with, meropenem is a good choice, but ultimately it depends on the epidemiology of your hospital.
No, I'm asking specifically that suppose you have got a infection like this in your
Sir,
government
if
hospital.
my ICU is last 6 months, I have mostly got Pseudomonas and Acinetobacter. Then probably
this is your corporate ICU.
Yes, sir.
Right.
So in that point of time, if I am suspecting Pseudomonas, then to start with, if last 6 months I have got immense Pseudomonas with most of the resistance pattern is porine challenge or deflux from, then it's better to start with combination therapy. And if it is Acinetobacter, then it's better to start with polymyxin with Salvactor.
No, my question was, sorry, I'm
Yes,
asking
sir, yes,
again
sir.
and again.
No,
My
yes, sir.
question is, what would be your empiric therapy? I don't know whether it's I have sent for the cultures. Right now, the patient has come with a septic shock. and I want to start an empiric therapy. I feel that it is a gram-negative, and I've got a corporate hospital. The patient was possibly exposed to some
Meropenem is a
antibiotics.
good choice, sir.
Meropenem.
To start with, yes, sir.
Right. And okay. I'll go to the hematologist now. I go back one step backwards, that you possibly are treating patients with hematological malignancies or bone marrow failure. Do you feel you have got the same spectrum of resistant bugs, or does your what do you say, the bugs are different?
So I'll answer both questions, the spectrum and then what is our empiric policy. So spectrum is more or less the same what we get. We have an additional problem in hematology, and especially in the transplant setting, where we have the neutropenic patient, and so our antibiotic policy is slightly different. And in our transplant unit, we also do something called as a surveillance culture. So prior to the patient coming into the transplant unit, we get an idea about what bugs that patient is carrying in the GI tract. Because the moment that we give conditioning chemotherapy and total body irradiation, there is transmigration of these bacteria, and usually we have published data to show that there is around a 50 to 60% correlation between the microbes in the gut and what we are eventually getting as a bloodstream infection. So and if we look at the spectrum of microbes, it is similar. We are getting a lot of, and our patients have a lot of MDROs because they have undergone multiple rounds of intensive chemotherapy prior to transplant or even during chemotherapy. So they are exposed to a lot of carbapenems, they are exposed to a lot of beta-lactamase inhibitors. So we get a lot of multi-drug and extremely drug-resistant Klebsiella, E. coli, and Acinetobacter. Now, when these patients come into the transplant unit, we are hitting them with even more chemo and radiation in terms of the conditioning. And then there is a prolonged neutropenic phase of almost 3 weeks. So during this time, our policy is that if the surveillance, now I'm coming to the empiric policy. So if the surveillance cultures show, let's say, an ESBL, which is, we have the sensitivities. So we usually start with a dual combination therapy of BL, BBLI, and an aminoglycoside. So for example, piperacillin tazobactam and amikacin. Now, if the patient has ESBL, which is resistant to piperacillin tazobactam amikacin, then usually we start with meropenem amikacin. That is our empiric policy. Sometimes we find, let's say, in the surveillance of the stool, we find that there is NDM or OXA48 positive organism in the GI surveillance. In that situation, sometimes our empiric antibiotic first line may be ceftazidime avibactam with aztreonam and polymyxin B as first line. This we are doing here because we've had multiple patients not doing so well, like the patient gets a febrile episode. Within 12 hours, the patient is in septic shock, and sometimes the patients cannot be salvaged. In this situation, depending on the clinical situation and the microbiological data that we get from the surveillance, by escalating upfront to this kind of aggressive antibiotic policy, we have been able to salvage a few patients.
Thank you. So one thing I'd ask the microbiologist, basically about the surveillance culture, he pointed out that he does the surveillance culture from GI, that is the stool culture. What I recently read was very interesting. Previously, we thought that our respiratory tract is basically a steroid place, unless infected, basically. But right now, they are telling, even like the gut, the lung has got its own flora. And even the lung flora may get what they are right now calling a term, they're using dysbiosis, that one bacteria suddenly starts getting very strong. And if that bacteria perchance is resistant, then the patient will get infection from that. So do you feel that if I go for a surveillance culture, what should be our policy, in particularly high-risk patients like bone marrow transplant patients, etc.? Do you recommend this, or do you recommend something else? Do you?
So actually, we have been doing the surveillance culture for almost 11, 12 years now.
Now, this technique, we had modified and used it, and we do use two types of samples. One is a stool sample, another one is a throat swab samples. The positivity rate of the stool sample is obviously higher than the throat swab samples. It needs to be told here that we are not reporting any organism. We are reporting only those organisms which are either MDR, XDR, or PDR.
If you find at all.
Yeah. So we are not
No,
interested
I'll
in
get back to you.
sensitive organisms at all. Okay. So only if resistant organisms are detectable, we find. So what we find is that obviously the stool has a greater repository of resistant organisms than the throat swab, but you can find even resistant gram negatives in the throat swab of the patient who are otherwise looking quite well. So we have been using this strategy, taking the analogy of MRSA to start with. So what was the policy with regard to MRSA in developed world is that before any major intervention, it could be surgery or ICU admission, you screen the patient for MRSA. If you find the patient MRSA positive, you decolonize the patient. And if you are to use an empirical antibiotic in the case of an infection, particularly sepsis, you cover the patient with an anti-MRSA agent. That logic, we have actually used it with the proviso that for resistant gram negatives or for VRE, there is no decolonization regimen as of now. But how this surveillance results helps us, it helps us in a couple of ways. One is that we are alerted by the fact that the patient is already colonized with multi-drug resistant, sometimes extensively drug resistant organisms, and which in the case of the BMT patients or the chemotherapy or radiotherapy transplant patients, it can have a gut transmigration, and that we have seen in quite a few patients. The second way it helps is that it helps also in infection control, that it alerts that you have to do standard precautions very rigorously with regard to these patients. Third is that it actually highlights the fact that you need to have a lower threshold of escalation to a higher generation antibiotics if things are not going well with your traditional first line antibiotics. So this has been our strategy. And
Yes, so we'll go to the next question. There is some, I'll take another 10 minutes.
10 minutes.
Right.
10 minutes.
So
Regarding
we'll go right down
surveillance.
to Ajoyda. We'll skip this part, Ajoyda. Ajoyda, I am asking your opinion about this empiric therapy. Then we'll go for definitive therapy. We'll go three things. One, empiric therapy. We have already got the idea of what the bugs are usually. Now we have got what the empiric therapy. I'll take your opinion about the empiric therapy. And we have got to think about a surveillance culture and how do I diagnose the patients who are at high risk for developing multiple drug resistant infections. Next two things, I'll come to you. Before that, I'm telling my plan. Two things I need to discuss after this. One is that how do we diagnose, go over the diagnosis, and last is definitive therapy for specific organisms. So I'll ask you, do you feel that in your ICU, when you get a severe sepsis, whom you feel that might be a hospital-acquired infection, say 5-7 days after infection already on antibiotic, do you feel your first empiric therapy is meropenem if the patient previously got only maybe say amoxiclav? In spite of that, the patient has got a severe infection in ICU. Do you start off with the meropenem or do you something else?
I answer meropenem. I'll go for carbapenem group. Definitely, over the years, I have a strong feeling that if your carbapenem is sensitive, then your patient will go home. If your carbapenem is resistant, then you don't know what will be the outcome. Whether it's sensitive to colistin or sensitive to BLBLI newer generation, there is a big question. But if your meropenem is sensitive and MIC is good, less than 0.25, then definitely if you give that with a... my answer is always will go by penem. First,
no, but you yourself have said almost 60-70% of your flora are resistant to penems right now. I see hospital acquired. So in that patient, I'm saying a patient in severe shock. I won't find the time next time to have my culture and change the antibiotic by next 2 days. That is like that. So I don't have the time. So what is your empiric antibiotic, one antibiotic or antibiotic combination in that
if it develops in my unit, then it's obviously meropenem, because what I'm saying, that hospital acquired infection many times is coming from your ward.
No,
And
I'm
there-
talking in your ICU, the patient was there for
in
last 5 days.
ICU, if he had been, because all by Penem, we have shifted from BLBLI to Penem. So already on Penem, and if he goes into shock, septic shock or other things, then definitely it's not working. I have to go for newer BLBLI, and considering your the organisms we do see mostly Klebsiella and it's Ox and NDM. So my unit is using combination simultaneously, BLBLI newer, avibactam, ceftazidime plus aztreonam simultaneously, and it's depending on the creatinine. That is empirical treatment.
I'll ask Dr. Haldar.
But I won't go for another colistin adding, because the combination therapy and the therapy which you have been used as combination, but it's a one unit, there is no difference. Different studies have shown that.
So, Dr. Haldar,
Yes,
I'll
sir.
ask you again. I'm talking about your corporate hospital where there is more chance of having a higher resistant germ. So, a patient, again, I'm telling the same scenario. The patient was there in the hospital of the ICU for 5 to 7 days. The patient has already received meropenem, and now the patient goes into a severe septicemic shock.
Yes, sir.
Possibly a bloodstream infection.
Yes, sir.
And you feel it might be gram negative. So, what would be your empiric therapy in that case?
Yes, sir. So a patient who is on meropenem and patient is going bad, and at that point of time, that's why, sir, I am saying the epidemiology of my hospital. Like previous 3 months, what kind of bug I am getting? If it's Klebsiella, then I have.
No, you have not got any drug. First day, the patient has gone into a septic shock, severe septic shock.
Yes,
the
sir.
patient already had meropenem
Yes,
previously
sir.
because
Yes,
of
sir.
some other reason.
Yes, sir.
Right now, there is a breakthrough infection or a super infection, whatever you want to call it.
First, I should search why the patient is deteriorated.
No,
Where
we
is
feel
the,
that clinically we feel there is no pneumonia, possibly that's a blood
yes, sir.
infection.
That's the first thing. Where is the site of infection? That's
That
I'm
we are
saying.
feeling that possibly clinically it feels like a bloodstream infection.
Yeah.
What is your empiric antibiotic combination in that case?
Yes, sir. So even in bloodstream infection, septicemia or the worsening shock, apart from
What's
back,
in the first time he has gone into a shock?
Yes,
Previously, he
sir.
was receiving a meropenem because of possibly a pneumonia.
Yes, sir.
And right now, he has gone into, there are central lines, and right now, there is no worsening of pneumonia, no hypoxemia. But from this morning, the patient has gone into a severe septic shock with high blood count and high CRP.
Yes, sir.
So, and a metabolic acidosis. So, what would be your combination in that case of antibiotics?
If I am thinking of the offending agent, I have to suspect first, sir. Then I will start ceftazidime, avibactam, aztreonam as the profound shock within a very short span of, mostly it is likely Klebsiella, because in Acinetobacter and Pseudomonas the shock should not be so much profound. But apart from the bacterial infections, I have to think of other infections also, because only fungus which can cause this kind of septic shock is Candida. So if the patient is having some risk factors for Candida, in addition to that, I have to add antifungal also.
So, I'll go to Dr. Bhattacharya. Sir, do you agree to this regime? A patient who has already received carbapenems, right now a suspected bloodstream infection with severe septicemic shock. So, what is your empiric activity? I have not got anything. I've sent for the cultures, I've sent for the gene expert, etc. But
Yeah, so at the moment we are using ceftazidime avibactam with aztreonam as the primary empirical agent because we are essentially targeting Klebsiella and the possibility of E. coli and to some extent Pseudomonas. So these are the agents which are covered by this combination. If we don't see a response in the first few hours, or the patient is deteriorating even further, we go on to add polymyxin just to cover Acinetobacter, which is not covered effectively by this combination.
so, why do you wait for few hours? If a severe septicemic patient is there, why not give the polymyxin in the upfront and then stop it if you feel that there is no polymyxin?
Yeah, yeah, you're right that it depends upon how bad the patient is. We currently are not using polymyxin also in combination or colistin in combination with ceftazidime, avibactam, and aztreonam in all the cases. We tend to wait, and that is based on the.
Patient, I've made you the condition very clear. This is a patient in severe septic shock. with a suspected bloodstream infection, I've asked, should I use a empiric antibiotic combination of only ceftazidime avibactam with aztreonam, or should I add a polymyxin with that?
So at the moment, we are not using polymyxin for all such cases, but we have a low threshold of adding polymyxin. If we see that the patient is deteriorating despite that, we of course add an antifungal, particularly when many of the patients are neutropenic and have other risk factors for fungal infection. The other thing why we don't add polymyxin, if you look at the frequency of isolation of the organisms, then Klebsiella E. coli is far ahead than Acinetobacter. If Acinetobacter number actually goes up, then we would have no hesitation in adding polymyxin from the word go.
So my take is that you use that this ceftazidime avibactam with aztreonam as the first line therapy. If only there is an outbreak of Acinetobacter, then you consider polymyxin being the first combination.
Yeah.
Otherwise, you only add polymyxins if there is.
If the prevalence of Acinetobacter is high, or the patient has had a previous Acinetobacter infection, or we see a deteriorating condition despite the addition of this agent, or non-response.
So, Jada, do you agree to this regime or not?
Yeah, absolutely. Because I don't agree that we should add a poly everything. Because you are adding poly means you don't have anything in your hand. So, and you can add, because Klebsiella is likely organism. So you have given the right drug, right duration and dose, and wait for some time. And if it works, then fine. If it doesn't work, then you have to add polymyxin. That will be your last resort.
So what we have till now,
antifungal, probably those who are working like Sudipto's unit and other units, they are probably the first place one should go for antifungal as well. Because in my unit, we don't get fungal infection so frequently because we don't have any transplant unit. And just one thing regarding surveillance, it's my, at times I was thinking that should we go for routinely surveillance culture? Then I went through literature. It's a two different scenario. One is our unit, one is Sudipto's unit.
No,
In our unit, I
hematology
don't
unit,
think we should go for surveillance culture routinely because there are few points: 3 days surveillance, 7 days surveillance, 15 days
This possibly
surveillance.
works in basically
And nothing
very
is working. So
specific.
literature has tell us that in a unit where transplant or immunosuppressed agents are frequently used, their surveillance culture doesn't have any role. So probably we are okay. We don't do,
So we have almost come to the end of our discussion. The time is short. We have got several unanswered questions. You may ask them if you feel like afterwards to the panelists. The decision we have come to is that most of our resistant bugs are gram-negative, of which Klebsiella remains the main, it takes the major chunk, and followed by Acinetobacter and Pseudomonas, and sometimes some odd bacteria. Fungus is, of course, a consideration, particularly in specific units. And for treatment, empiric and specific therapy of Klebsiella, we prefer which are resistant to carbapenems. If they are sensitive to carbapenems, as Ajay has found out, carbapenem is the choice. If they are sensitive, it would be better than any other drug. If not, or if we suspect it is resistant to carbapenems, then we go to newer combinations like ceftazidime, avibactam, along with aztreonam. I have not discussed why you need to add aztreonam. We can discuss it afterwards directly with the panelists. Only if we feel that this is not working, or we have got reasons to believe that the major bacteria at that point of time is not Klebsiella but Acinetobacter or maybe some other thing, then we add a polymyxin to the regime, or we change to a polymyxin-based regime. So that is there. Anything any of you would like to add after this? Short comments. We have got just 2 minutes.
Just one new BLBL, I was just going through literature. It's called cefiderocol. It's coming, and I have seen that works in all the A, B, C, D. Everything will be covered
But
with
the first
that.
trial was not very
No,
good.
interestingly, they have recommended. But when we see I think it's a some trial, I've forgotten the name, but there the FDA has given caution because the 28 days mortality
It was
was
not good.
higher in
Right.
that group rather than in the, so I don't know, this is a contradictory literature
Possibly it
report.
will need a
Yeah.
combination. Possibly as a
But
single drug,
perhaps
it
that
will
is the drug which probably if it works for all, then
super
it's a
drug.
business.
So it was a
Any
very
other combination?
very promising drug, sir, but studies are not so much promising like its theoretical aspect. I just mention one drug, cefepime zidivectam. That's a drug which we can. It's in India at present. It's not available. But if we want, we can take it from the outside India. It is the drug for Pseudomonas. It acts against all the resistance mechanisms for Pseudomonas. Klebsiella, we are having good drug. Acinetobacter, we are not having very good drug. For Pseudomonas, it's a very promising option.
Any other short one sentence comment?
Yeah, we have been doing synergy testing for ceftazidime avibactam with aztreonam, and we found that this combination is not always synergistic. Okay, and second point is that while it is okay to use ceftazidime avibactam in high resistance settings as an empirical treatment, we should also develop our own capacity to do these NDM octane tests. So otherwise, it will always be empirical, which is not good for.
No, we are doing it. I did not have the time to go into that, but that's a thing we need to discuss. Anyway, I think we are end of our time. Thank you. And if you've got any questions, you can ask personally the panelists afterwards. Thank you very much. Thank you.
Thank you, everybody. Just a small token of appreciation from the Tata Medical Center. Just. Haldar. Thank you. And now we are moving to the next session. So our next session will be on perioperative management, and in cancer patients, the postoperative pulmonary complications are very, very common. So,
I'll introduce it. Yeah, so we see a lot of postoperative pulmonary complications in our cancer patients. Often we find like it's very difficult and it's a dilemma whether it's an infective complication of an infection not picked up in the PSC or whether we're dealing with something else. So Dr. Shoykot Sengupta, who is a senior consultant in the Department of Anesthesia at Apollo Multispecialty Hospital, is here to speak on this topic. And I would request Dr. Rudonil Nondi, our consultant in Department of Onco-Anesthesia and Pain Care, to chair the session. Sir.
Good afternoon, and thank you, Sudipto and your team, for asking me to come to this meeting. And we will talk about postoperative pulmonary complications. Okay, it's a reasonably good burden. And if you look at across various institutions, across various units, it ranges between 5 to 8%. To define postoperative pulmonary complications, this was the traditional way that patients would have in the postoperative period, things like atelectasis, bronchospasm, pneumonia, exacerbation of the lung disease. This has been expanded to bring into its domain acute upper airway obstruction, complications, or exacerbations of OSA, effusions, chemical pneumonitis, edema, hypoxemia due to ACS, and also mechanical tracheal laceration and rupture. So let us go through this topic in a case of a problem base. So if you have somebody with an uneventful open biliary duct exploration who was an asthmatic, well-controlled, and a smoker, and on the second POD, complaints of respiratory distress, which began mildly on the first POD, now is tachypneic, tachycardic, reasonably good blood pressure, saturating around 92% on room air, has pain at the site, and in auscultation, you find basal crackles and rhonchi bilaterally. So what would this kind of take you towards? We then have a radiology image. The one on the left is the preoperative, and on the second postoperative day, you have something like this showing up on the right upper area. So this would make you think that we are dealing with atelectasis in the second postoperative day. It happens to decreased compliance of the lung tissues, impaired regional ventilation, most commonly due to retained airway secretions, and inadequately dealt with postoperative pain, which interferes with spontaneous deep breathing and coughing. And it develops after sometimes. It will not come in immediately in the first maybe 12, 24 hours, but develops after 24, 36 hours. So the management will depend upon one question that you ask: does the patient have abundant secretions, which is defined by frequent expectorations with expectoration of large amounts of sputum? If the patient has abundant secretion, the answer to that would be then apply some kind of positive airway pressure, which can be beneficial. If there is abundant secretion, then the therapy becomes different. It will be dealing with chest physiotherapy and suctioning as appropriate. And with abundant secretion, the next question after chest physiotherapy and suctioning would be, do you straight away go ahead and do bronchoscopy? Go back to radiology and try and see if you can see an air bronchogram. If you do not see an air bronchogram, then this is a patient who might benefit with bronchoscopy. If you see air bronchogram, this is not a candidate who should immediately go for a bronchoscopy in the postoperative period, because your airways are pretty okay in that case. Is positive airway pressure beneficial in those without secretions? The answer to that, if you look through several reviews and meta-analysis, you will see that it is beneficial. If you look at the Kaplan-Meier curve on the top right, you will find that the patients who have been given early positive airway pressure therapy are less likely to go on to the ventilator, and they're more likely that they will stay for lesser amount of time in the ICU and in the hospital. So positive airway pressure in patients with atelectasis in the postoperative period without abundant secretion is definitely beneficial. Once you've dealt with this scenario, let's go to another case scenario. A 65-year-old male who is known to have COPD, subacute intestinal obstruction, undergoes an exploratory laparotomy with resection and anastomosis. On the first postoperative day, becomes dyspneic, chest tightness, wheezing, rapid shallow breathing, tachypneic, saturating low, despite supplemental oxygen. The hemodynamics are okay, and you find wheeze and auscultation. It is here that you are now dealing with an exacerbation of the COPD and you're dealing with bronchospasm. Why would bronchospasm happen in groups of patients in the postoperative period? It could be due to even mild kind of aspiration, which is triggering it. Histamine, which could be released by a variety of drugs, including anesthetic agents. Allergic response to other medications, exacerbation of the disease process, or a reflex constriction of the bronchial smooth muscles, which could be due to any kind of tracheal stimulation or tracheal instrumentation, as well as secretions and or suctioning, endotracheal intubations, or any other surgical manipulation is done as well. And this commonly can happen while the patient is awakening from anesthesia and the bronchodilatory effects of the inhalation anesthetics are on the wane. Typically, again, in the postoperative period, your therapy would remain the same as in a patient with acute asthma. So targeting a saturation of 90% with bronchodilators like salbutamol, and adding inhaled anticholinergic agent like ipratropium. Severe, you then have continuous nebulization, and you can think of systemic or even inhaled steroids as well. So that was about bronchospasm, very common in the post-operative period. Let's go to another scenario, a 55-year-old who has undergone a Whipple surgery and was electively post-operatively ventilated for around 8 hours. On the third post-operative day is having fever with cough and expectoration and shortness of breath, again tachycardic, reasonably tachypneic, saturating low, and has a counts which is going up. So what would this make you aware of? And this was his preoperative X-ray on the left-hand side and a post-operative X-ray on the right-hand side. This would be something that you're dealing with an infective scenario in the post-operative period, and this should remind you of a thing like pneumonia happening in the post-operative period. But infiltrates in the post-operative period on a chest X-ray should also make you aware that you could be dealing with things like even a non-infective things like atelectasis, which has not got infected as yet, pulmonary edema, pulmonary embolism, or any kind of an acute lung injury due to several things that can happen in the perioperative period. And is there a role? This is something that I think this was a Korean publication which looked into whether procalcitonin or CRP can be helpful. Not very, very helpful. It can be helpful in the early first postoperative day or second postoperative day, the role of PCT and CRP. But as you go further, the role of PCT and CRP in distinguishing between the non-infective causes can become a little tenuous. Is there any clue as to what is the surgical procedure happening and what organisms can happen? There has been from the surgical data and the trauma database, you'll find that for traumatically injured patients, it is things like, this is Western data. I could not find Indian data. It could be organisms like Haemophilus influenza and Streptococcus. For neurosurgical patients, it's more likely to be staph. And Pseudomonas or Acinetobacter can happen in all groups of patients. And for abdominal surgery, you're looking at anaerobic organisms as well. Management, it will be, I think, I did not reiterate what you would do is you start empirical therapy after collection of the specimen and sending it to microbiology, and then taper your antibiotics up accordingly. Now, these are the common ones, the accepted definitions. Let's go into the extended list, like an acute upper airway obstruction, which happens immediately in the postoperative period. If you're dealing with stridor, the obstruction is still incomplete. And when you have something like aphonia happening, you then think that this obstruction is complete and you're dealing with an acute medical emergency. And is usually due to things like laryngeal edema, vocal cord paralysis, or injury due to a mechanical cause, laryngospasm, obstruction of the tongue, or other soft tissues. Is an acute emergency, and the best way to deal with it is to have a definitive airway in the trachea, like an endotracheal intubation. And it may not be always possible. The best way would be a direct laryngoscopy, if it is possible, or a video laryngoscopy. You can have difficulty in scope in guided intubation because the passage may not be as visible as you would want it to be. Exacerbation of OSA is a common thing because you remember all your anesthetic agents, sedatives, opioids relax the pharyngeal muscles and may increase the frequency, severity, and duration of the upper airway collapse. The anesthetic agents per se also blunt the hypoxic and hypercapnic respiratory centers, which compromise the arousal response. And after surgery, they usually are lying supine, which also exacerbates the effects that happen due to OSA. So the manifestations would be more severe, more prolonged episodes of oxygen desaturation during sleep and worsening of hypercapnia despite your positive airway pressures. The best way to treat with them is to have them nearly upright after surgery, have good pain control, try and avoid narcotics if as far as possible, and have adequate pain control. This is one place where restrictive fluid therapy in the intraoperative phase has been shown to be beneficial, and immediate institution of positive airway pressure after the extubation of the trachea is beneficial in a great extent. Things like pleural effusions are very common, and usually you don't have to do much about it because they resolve spontaneously within a couple of days. This is another common thing that can happen. Say this is a 55-year alcoholic cirrhotic liver who presented with bleeding. I don't know how often it is done in many centers today. A Sengstaken tube was put in under sedation. And after 2 hours, the patient has difficulty in breathing and is kind of tachypneic. And when you do a chest X-ray, you get a feature like this. But the same patient, after 2 days, nearly has complete resolution and is also symptom-free. So what would you be then thinking that you're dealing with? This is aspiration, and you're just dealing with chemical pneumonitis, which has an abrupt onset of dyspnea and tachycardia. Fever, bronchospasm, hypoxemia, cyanosis, and pink frothy sputum can appear, and infiltrates may appear in both the lower lobes, usually within the first 24 hours, and if they resolve spontaneously. More common in pediatrics and obstetrics. The clinical course can vary. Full recovery is the usual outcome, and this full recovery can happen within 48 hours. The patients who do not, these are the kind of clinical markers, who do not develop cough, wheeze, or a desaturation of more than 10%, and radiological abnormalities are not appearing within 2 hours, are more likely to have complete resolution. Unfortunately, there could be people who go into an pneumonia or an aspiration pneumonia and also progress to things like ARDS. So what would you do if you have witnessed it? Is turn the patient, provided the cervical spine is okay, and do suctioning. And if there is an iota of doubt about the airway reflexes and consciousness, intubate the trachea. Unwitnessed, monitor it for the first 24 to 48 hours, because this is where the period is, whether they're resolving or they're not resolving, and treatment is till then supportive with supplemental oxygenation and non-invasive ventilation, or maybe conventional mechanical ventilation. Do you give steroids and antibiotics to all? The answer is not indicated. They don't give it. Unless the clinical findings do not resolve with the first 48 hours, then you start thinking of giving antibiotics. Now, this is what the book teaching is. I know things in the ground, in the reality, might be a little different. So let's look into this 5th case scenario. A 70-year-old ischemic heart disease, query dilated cardiomyopathy, who has undergone an HIPEC surgery. On the first post-operative day, has shortness of breath and distress. Heart rate is 105, irregular, hypotensive, tachypneic, saturating low, and this is what the X-ray looks like. Yes, this is obviously pulmonary edema, which in the post-operative period can be either cardiogenic, can be non-cardiogenic, or a combination of both. Cardiogenic usually would appear in the first 36 hours when there is a positive fluid balance, which is significant. And it is, should be identified with a chest X-ray, or if you put in a PA catheter, which we hardly do nowadays, with an elevated PA pressures, or through bedside echocardiography if you find that the PA pressures are high. Unfortunately, some of the diagnosis only happens with autopsy. The management would be diuresis, supplemental oxygenation, assisted ventilation, and in selective patients, vasodilatory therapy. You could be also dealing with non-cardiogenic pulmonary edema, which is nothing but a negative pressure pulmonary edema. This is typically if the patient in the postoperative period has an acute upper airway obstruction following extubation. And then when you are good and you have relieved the obstruction, then the person becomes dyspneic and you have pink frothy sputum appearing from the mouth and the pharynx. And if you do an X-ray, you might find bilateral infiltrates in the chest radiograph. So this is negative pressure pulmonary edema, typically happen once the relief of the obstruction happens and can be delayed for several hours. This is one of the caveats. So if you have had a patient who has had an obstruction or a laryngospasm after extubation, monitor these patients closely for the next 24 to 48 hours. Risk factors: obesity, short neck, OSA, acromegaly, and shared airways or surgeries on the upper airway. And the reason why it happens, I think most of you would know that this creates this negative intrathorax pressure, which is so much that the pulmonary vasculature fills up and the alveoli get filled up with water. The treatment would be supportive, supplemental oxygenation, diuresis, bronchodilators can help. Most patients would possibly benefit with after the relief of after the relief of airway obstruction would be endotracheal intubation, because PEEP can help in dispersing the water. So many units, if you have got a pink frothy sputum, intubate the trachea instead of looking for supportive therapy. Finally, if you have a patient after a particular procedure, coronal chest X-ray, which looks like this, and an axial CT scan, which looks like this, subcutaneous emphysema, pneumothorax developing, pneumomediastinum developing, what would you be thinking about? And the patient is hardly able to talk, think of mechanical injury like tracheal laceration or rupture. Unusual but well described respiratory compromise, and as I had, subcutaneous emphysema, pneumomediastinum. And the therapy would be most often a surgical repair. If it is mild, then only conservative management. So the take-home message is that pulmonary complications are a major cause of morbidity and mortality in the immediate and later postoperative period. Atelectasis is possibly the most common postoperative pulmonary complication. Bronchospasm is also very common. Pneumonias, if they usually develop a little late. Acute upper airway obstruction is the one that would bother us most in the immediate postoperative period. And things like obstructive sleep apnea, if somebody comes in for any kind of surgery, be it airway surgery or a non-airway surgery, please be reminded that it can lead to problems immediately as well as in the later part of the postoperative period. Thank you very much.
Comment from Rudroni.
I said just want to make two comments that preventing postoperative pulmonary complication is very important, and the role of rehabilitation and the optimum pain control. These two probably that is in our hand.
Absolutely. I think, Rudrana, I can't agree with you more. I think because of the constraint of time, I did not specifically look into the strategies to reduce the postoperative pulmonary complications, because that's a huge gambit. And absolutely well taken that things like we have figured it out, rehabilitation before not only cancer surgeries, but even before non-cancer surgeries, major surgeries, be it thoracic surgeries or upper abdominal surgeries, but even in other areas like limb surgeries. We have figured out that rehabilitation things, very simple things like incentive spirometry.
Exactly. Doing just
incentive spirometry, motivating the patient, and the other things like if you have your hemoglobin levels high, if you have your albumin levels high, these are the who do not have an infection in the preoperative phase, who have done things like quitting smoking in the preoperative phase. These are people who would do pulmonary wise much better than those who have not. Definitely.
Shokata, I would like to add one thing. Probably there is a, particularly in our center, we do long cases, very long cases. The patients are on ventilator for 10, 14 hours. So one intraoperative protective bundle for ventilation. So how do you think that will?
Absolutely.
be
Yeah, I
able
think it's just like taking what the critical care or what you have learned from ICU, the ventilator care bundles. You just take those ventilators. You can apply some of them. You cannot apply all of them. So you can take them into the OR, like even simple maneuvers like lung recruitments, for
Exactly.
example.
Exactly, that's
In
what
the
I'm talking about.
intraoperative phase, maybe you do it regularly after say every 90 minutes. Lung recruitment. This can decrease the incidence of atelectasis in a big way. And lung protective strategies, like you don't bombard the lungs with huge volume,
Right,
you will
right.
less
So
likely to have
most of our machines don't have very advanced mode of ventilation in the OT. So our anesthesia stations will usually have either pressure control or volume control. So what I have seen that using pressure control can minimize the total pressure and the plateau pressure.
As long
can
as your
bring down.
targets remain
Yeah.
all right, if you look through literature, if as long as your targets remain all right, the mode of ventilation will not influence that much. So, but even if you're
And
looking at
increasing the PEEP,
recruitment,
intraoperative
you
PEEP
just
and,
don't need
yeah.
very fancy ventilators. You can manage it manually, by, you are not going to do it all the while. So every 90 minutes you can do it.
Yes.
And basically,
Yes, sir.
in most of the anesthesia patients are sedated and paralyzed. For paralyzed patient, you usually do not need very advanced ventilator.
Absolutely.
It's required when the patient is breathing and you have to accommodate his ventilator recovery. Please.
Sir, what is the take of non-invasive ventilation? Like you mentioned CPAP in a post-GI surgery patient.
I'm glad you brought this up. Surgeons used to be, I use the term, used to be very wary of NIV after a GI surgery, especially if there has been an anastomosis, right? If you scan through literature, it has been shown that with the settings that you use, whether it is a 12-6 or a 14-8 kind of a setting, it has now been categorically shown that they do not influence anastomotic integrity in any way. And if the mask is good and if you have trained the person well, you will not even also have gastric insufflation, which is significant to cause a distress in the postoperative period. So please feel free to use non-invasive ventilation if you think that that person needs it in the postoperative period, even in persons who have had a GI surgery. Thank you.
Thank you. Thank you, sir, for an excellent presentation.
Thank you very much.
Now we'll a very small token of memento to sir from Tata Medical Center.
Thank you.
And also a small token to our own Dr. Rudranil. Now we'll take a break for lunch and we'll try to rejoin by 2 o'clock or 2:10 at max. Thank you, everybody.
স্টার্ট করি। ঠিক আছে। So, good afternoon. Welcome back after lunch. So, we would start with the session on NTM, pulmonary disease and update. Speaker is none other than Professor Vibhuti Shaha, the Head Department of Infectious Diseases and Advanced Microbiology at the School of Tropical Medicine, Kolkata. Okay. So, the session will be chaired by Dr. Joviraj Rai. He is the Associate Professor and Head in the Department of Infectious Diseases at IPGMER and SSKM Hospital, and Dr. Gaurav Goyal, Consultant Microbiologist of the Tata Medical Center, Kolkata. I would request them to please come in the front row and chair the session. Sir, if you could come. Screen sharing আছে? করে দিন।
So, good afternoon. We are starting the session. So it's our proud privilege to welcome Dr. Professor Bhuti Saha. Sir is a known figure to the people of medicine, internal medicine, infectious diseases, and tropical medicine all over the India. So he has been instrumental in set up various facilities in the School of Tropical Medicine. And we are also fortunate to have his guidance over the years in Tata Medical Center. So we welcome sir and for the very important lecture, NTM pulmonary disease and update.
Thank you, Chairperson sir, for your kind words of introduction. Please excuse me because I'm having a very bad voice, so most of it may not be audible. So let me try. No, move করছে না. Okay. Okay, thank you. So, these will be my points while we're discussing the issues. So let's start with the patient whose details have been provided by Dr. Shushmita Raichoudhury, who is a consultant pulmonologist at Fortis Hospital. A 60-year-old male who came to them from other hospital with a history of fever, cough, breathlessness at rest and wheeze, no hemoptysis, smoker, which is stopped for 2 years, uncontrolled diabetes, and he had been taking over-the-counter oral steroids for breathlessness off and on for last 10 years. He had a high count of 26,000, CRP was 133, procalcitonin 1.33, cardiac markers are okay. HbA1c was 11.4. And this is the thorax CT scan. You can see fibrosis and cavities here. So they did a fiber optic bronchoscopy and the bile fluid was sent. Bacterial culture didn't show any growth. Fungal culture, no growth. Bile galactomannan was 0.66. Serum was 1.36. AFB smear was positive, but gene expert MTB was not detected. They did a culture. It showed a growth of non-tubercular mycobacteria. Mycobacterium cancersi was grown. And they, you can see the culture, and they went for a LPA, which it was shown to be Mycobacterium cancersi. So then why should we bother about NTM? If you look at the world literature, the incidence and death is increasing globally. Initially, we thought they are only saprophytes, they are only affecting people who are having defecting lung functions or immunosuppressed. But now it is being seen in increasingly in young children, adults without any underlying known immunocompetent immunodeficiency. They're difficult to treat. They have become very much resistant to antibiotics in some cases, dispersed all over the world, and very common in the tropics. That's an area of concern for us. So they are ubiquitous, living all over the world, environmental saprophytic organisms. They are present in the water system, soil, and the vegetation. We know that they belong to the genus of Mycobacterium. And till now, over 170 identified species have been discovered, and newer ones are regularly being identified. They are microaerobic, needing 6 to 12% oxygen, lipid-rich wall, and metabolic characteristics. They result in a very slow growth, and they can withstand a wide range of environmental temperatures. They do not grow steadily in standard bacterial media, and they are resistant to antibiotics and disinfectants. In fact, the first was described just after Mycobacterium tuberculosis after 1882, and then a lot of them have been identified, and big names. So important one is Mycobacterium avium complex, inside which you have many known names, but you can see some of them, Mycobacterium intercellulare, and others have very many names are there. I'm not going to describe them. And other common NTM are Mycobacterium xenopi, fortuitum complex, and Kansasi. And another important group is Mycobacterium abscessus group, MABS. And they have been grouped separately. And under them, you have subspecies like Sensu stricto, Macilens, and Boleti. So these are the subspecies under abscessus. In other words, you can divide them into, according to culture time, rapidly growing mycobacteria, which form colonies within 7 days, in which you get the abscessus complex, Chelonia, and fortuitum. And the slow-growing ones, which may take up to 12 weeks to grow, in which you have the Mycobacterium avium complex, Xenopi, Kansasi, Simi, Malvolens, and Zulgai. So this is important for deciding on the treatment. Disease, they form mainly 3 types of disease: fibrocavitary disease, which you saw right now, nodular bronchiectasis disease, and hypersensitive pneumonitis. Very insidious in onset, and they grow over periods of months or years. So what are the host factors? If you look at the important host factors for pulmonary NTM infection, you can have a structural or functional lung compromise, which may be due to some genetic or acquired defects. Genetic, is cystic fibrosis, alpha-1 antitrypsin deficiency, primary ciliary dyskinesia, pulmonary alveolar proteinosis. Acquired, you have bronchiectasis, COPD, chronic aspiration, and lung malignancy. We have that there is Lady Windermere syndrome, where you have post-mesoval women with slender body habitus. And drugs like anti-TNF-alpha therapy, cytotoxic therapy, steroids, and others like vitamin D deficiency or aspergillus can contribute to them. There are certain environmental risk factors and risk factors on the part of the organisms. What are they? If you look at the environmental factors, tropical climates and geographical areas are the vital, where they grow very much. Soil characteristics, animal reservoirs are there, and water reservoirs like lakes and aquifer are there. Man-made, you have domestic hot tubs, potting soils, domestic animals, and shower aerosols. In fact, it is spread from shower aerosols. In the healthcare facility, contaminated water sources and equipments are there. And if you look at the bacterial organism properties, they have a lipid-rich cell wall which survives and grows in diverse habitats. They form biofilms, importantly, and persists there. They can produce aerosol, and antibiotic and disinfectant resistance is there. And as we discussed, they have a stringent growth requirement. They have low doubling time, difficult to isolate, and they need special media to grow them. How is the disease burden? It is spread all over the world. You look at US, Europe, Asia, you have all there. In Europe, it's mainly MAC. South Korea, Japan, China, they are also showing increase of NTM lung disease. You have them in Brazil, Taiwan, and Middle East. In India, the NTM isolation rate is about 0.2 to 5.9 per 100,000 persons, whereas the disease is 0.8 to 100,000. In fact, you have a very good review by Dr. Sharma and others. If you are interested, you can have a look at that in IAMR. Most common globally are MAC organism, though prevalence varies. MAPs are also significant problem, particularly because high level of antibiotic resistance, and they are more in the East Asian countries in Japan, Korea, and Taiwan. And they are also a difficult problem in patients with cystic fibrosis. And with increasing age, we are seeing increasing prevalence of the disease. What are the diagnostic criteria? You have well-set diagnostic criteria. So you have clinical criteria, pulmonary symptoms like nodular capillary opacities in chest X-ray or HSCT that shows a multifocal bronchiectasis with multiple small nodules, and appropriate exclusion of other diagnoses. Microbiologically, you either have to have a positive culture for at least 2 separate exported sputum samples. If the result from the initial sample is non-diagnostic, you can repeat the smear sputum culture, or positive culture, at least 1 from bronchial wash or lavage, or transbronchial or other lung biopsy mycobacterial histopathologic features, you get a granuloma or AFB and positive culture of NTM, or a biopsy showing mycobacterial histopathologic features, that is granulomatous inflammation AFB, and 1 or more of the sputum or bronchial washings as culture positive for NTM. So you have to fill the criteria to make a diagnosis of NTM. Key laboratory features, the staining procedure preferred is fluorochrome method. Specimens should be cultured in both liquid and solid media, and they should be identified to the species level, because you can have various methods like DNA probes for MAC, Cancer C, and Gordoni, and also HPLC there. And you can also have a rapid growing mycobacteria. For them, you can have other identification techniques like in vitro antibiotic susceptibility testing, DNA sequencing, or PCR restriction endonuclease assay. For identification, you can use molecular tests as line probe assay or gene sequencing probes. MALDI-TOF can be used, and nowadays you are going to use NGS. Next generation sequencing is going to be the technology for the future. Drug susceptibility testing is important. You need to do it in broth microdilation for the drug susceptibility, and you have to test macrolides and amikacin, and also for microorganism cancers, you have to test for rifampicin, because you have to decide on which drugs to use. And for MAC, there's a clear correlation between the baseline macrolide susceptibility and the outcome of a treatment of rifampicin therapy to the macrolide. Because in MAC, you can get populations that are macrolide resistant. For amikacin, you have MICs of more than 64, they are not going to be effective. For abscesses, you have to do both in vitro correlation, and you may have resistance to macrolides, which may be present in the initial testing, which is known as constitutive resistance, which is mediated by the mutation in the 23S ribosomal RNA gene, or it can develop after incubation in a macrolide containing media at least 14 days, which is the inducible resistance mediated by erythromycin ribosome methylase ERM41 gene. Inducible macrosatellite resistance is present in most of the strains of abscesses, subspecies abscessus and boleti, but is absent in macillosis. This is important, so you can decide on the treatment regime. For other NTM species, drug susceptibility testing to macrolides, fluoroquinolones, linezolid, tetracycline, aminoglycosides are used to guide the treatment regimen. So when you are deciding to treat the treatment, you have to take consideration of the factors. There are host factors, disease severity, disease progression, and clinical relevance. Host age, increasing age is there is a risk of intolerance to drugs. You have to think of the comorbidities, drug interactions, because there are many drugs may be there, so you have to think of the drug interactions. What does the patient want, and what are you aiming at? Are you aiming to cure, or are you to just control the disease? Disease severity you can assess by the radiological features and the clinical features, and also microbiology. Disease progression you have to assess by radiological, clinical, and micrological methods. And clinical relevance, you need to know what is the NTM species, is there any underlying immunosuppressive condition, and in patient of lung who is needing lung transplantation, you need to eradicate the microorganism abscesses. So what are the policies? You need to manage the underlying disease and associated comorbidities. This is important. You should consider what is your goal, whether you're going to cure the disease or to control the disease. And if you are, when you're going to cure the disease, it may not be possible. So you may have to stabilize disease progression and control the symptoms. So in that case, you may have to choose a better tolerative regimen, avoiding drug intolerance. And of course, the management plan has to be after discussion with the patient and the party and a shared understanding of the rationale of the treatment. So it was sometimes said that a patient who has NTM pulmonary disease, whether we wait and watch, watchful waiting, or you treat. Now the recommendation said that in patients who meet the diagnostic criteria, they suggest initiation of treatment rather than watchful waiting, especially if the patient has a positive acid fast sputum smear or cavitary lung disease. So you need to treat them. So these are the drug susceptibility testing. You can look at the drugs for the microbiome, cancer, and abscesses, and you have the the MICs and breakpoints. You can have a look at this. So when you're trying to treat MAC-PD, pulmonary disease caused by Mycobacterium avium, MAC, so then you can have a fibronodular disease, you can have extensive cavitary disease, or you can have a refractory diseases. So drugs are here, azithromycin, ethambutol, and rifampicin are the drugs of choice. In fibronodular disease, you can use thrice a week, azithromycin, ethambutol, and rifampicin. Whereas if it is extensive cavitary disease, then you have to give a daily regime, and also you can add amikacin thrice a week. And if after 6 months of treatment you are not seeing adequate response, then it's a refractory disease. Then you have to use amikacin suspension as inhalation. So this is a timeline when you do. At the beginning, you do a baseline chest CT and other evaluation for the bronchiectasis, ocular examination, susceptibility testing, CRP, antibiotic regimen. After 4 to 6 weeks, you see the patient again. See, is it tolerating the drug, safety, potential worsening is there, drug levels, if you can do that. Then you see it every 3 months, ongoing, evaluating the patient every time. And at 3 months, you can do a sputum culture. At 6 months, you repeat a CT scan, see if the patient is tolerating the treatment, see if the patient has already converted, sputum converted. If the sputum conversion is not there, then you see the drug levels and secondary infection there. At the end of the therapy, you again do a CT to see the chest has improved or not, with how the patient is doing, how much is the risk of relapse of chronic suppression, and you have to monitor the patient every 3 to 12 months because there is a chance of relapse always. How long to treat? They are treated for at least 12 months after the culture conversion. Now coming to cancer C and Xenopy. So for cancer C, you have azithromycin, ethambutol, rifampicin, INH, or moxifloxacin. Usually use azithromycin, ethambutol, and rifampicin. Sometimes if you decide to use INH, then you have to give INH daily. Others, in case fibronodular disease, you can give thrice a week. Whereas in cavitary disease, everything has to be given daily. And if there is a documented rifampicin resistance, then you use moxifloxacin. And for Xenopy, you can have many drugs like azithromycin, moxifloxacin, ethambutol, rifampicin. So fibronodular disease, they are treated daily. See that they always need a daily treatment. There is no scope of intermittent therapy for Xenopy. So daily treatment is given. And in severe disease, you can add amikacin. So this is how you treat this Xenopy infection. So patient with cancer infection treated for at least 12 months. And patients with Xenopy infection, they have to be treated for at least 12 months after the culture conversion. For abscesses, you need to look at whether there is a macrolide susceptibility testing is important. This, depending on that, you decide on treatment regimen. You have the initial phase, you have parenteral drugs and oral drugs, and the parenteral drugs have amikacin, imipenem, or tigecycline, and you have to choose 2 or 3 of them. In case of macrolide susceptibility testing pending, and when there is a resistance, you need to choose 2 or 3 of them. And here also, when there is inducible resistance, you need to choose 2 or 3 of them. And the oral drugs, they are azithromycin or clarithromycin. In fact, azithromycin is better because daily given drug interactions are less. Or clofazimine and linezolid, you choose 2 to 3 of them. And when it is susceptible, you can choose lesser number of drugs. So this is, you can choose 1 to 2 from this group and 2 from this group. And this is for the initial phase, and then continuation phase, you reduce the number of drugs. You use only oral drugs. From here, you use 2 to 3, and you continue the treatment as for long as required. How long to treat? You can choose a short or long treatment depending on the expert consultation. So what are the factors? Patients with nodular bronchiectasis disease, they need lesser duration treatment than the cavitary disease. Patients who have been affected by lung disease caused by differing abscesses, subspecies, their treatment would differ. susceptible to macrolides and amikacin will decide how long to treat. And of course, if there is an expert, you can consult him for how long to treat. Surgery, do you have any role of surgery in NTM pulmonary disease? Well, in selected patients with NTM pulmonary disease, you can go for a surgical exploration. So who are the patient? Either selected patient who are failing medical management, who have a big cavitary disease, where there is drug resistance isolate, or complications like hemoptysis or severe bronchiectasis are there. They may undergo surgical resection of the diseased lung. Well, you need to benefit the ways and risks because there will be risk of pneumothorax and other complications. And of course, a person who is an expert on this surgery, because he needs a special type of surgery, should be preferred be done. Therapeutic drug monitoring. Well, we do not have any randomized trial. It is known that there is significant drug interaction between clarithromycin with rifampicin or rifabutin. So when you are considering there is a drug malabsorption, underdosing, and clinically important drug-drug interactions, then you can consider of TDM. So situations may be patient who is having delayed sputum culture conversion, treatment failure is there but not explained by non-adherence or drug resistance. Patients who are receiving amikacin or streptomycin therapy and that risk of ototoxicity or nephrotoxicity, and patients who have medical conditions like reduced renal function when they are suspected to leading to subtherapeutic or toxic drug concentration. In those situations, you can go for a therapeutic drug monitoring. So I'll conclude by saying that these problems, you are seeing more number of NTM tests, but you need to have a definite documentation and you need to go by the valid set down criteria. So you have to specify, this is very important. When deciding on the treatment, consider host factors, whether the person is willing to get treated, whether you're planning for cure or control of the disease. You plan and counsel the person before starting the treatment. Susceptibility to NTM to macrolides and amikacin. And in case of cancer, you need to see for rifampicin sensitivity. You need to monitor closely for the progress and adverse effects of drugs because there are a lot of adverse effects of drugs. And many a times you have to interrupt treatment, maybe stop treatment because of the drug toxicities. And of course, you have a very limited scope for surgery. So thank you very much for your kind attention.
Thank you, sir, for excellent presentation. And I know you have a lot of experience in treating NTM patients. We often face situations where we have a gene expert negative and AB positive from a sputum, and repeatedly so, but we don't get any furthermore, any culture or LPA. LPA, as you know, LPA is not available in everywhere easily. So in that regard, if there is a cavitary lung disease and patient is having off and on fever with not gaining weight rather than weight loss, so do you want to treat it? And in that case, if we want to treat, what should we treat? Rather in a RGM rapid growing mycobacteria or non-RGM mycobacteria?
Actually, Jogirath has raised a very pertinent issue and very practical issue which we are facing day in and day out. We have colleagues from microbiology here, but let me admit that in most of the hospital settings, government hospital settings, we are, especially regarding mycobacterial cultures, we are having lacking. So, in fact, if I talk of School of Tropical Medicine, I remember previously we had labs which were doing mycobacterial cultures, but right now they are not available. I'm not sure whether you have that in SSKM hospital also. So the issue which you have raised is a very important issue. The setting is there, the patient background is there, TB you have excluded, gene expert is negative, and maybe you have put that in the, so I think you should put that in culture. So if culture helps us, if culture grows, then our problem is sorted out. But if the culture does not show anything, and you don't have any other evidence of tuberculosis anywhere else in the body, and the clinical setting is that of NTM, first you have to take a call on that. You have to discuss with the person. And see, if you look at the treatment, most of the treatment are overlapping. So only the duration of treatment and all those things are. So in that case, I think in our setting, it may be rational to discuss with the patient that this is possible. I'm not very sure. If you agree, we'll start treatment. and we'll be monitoring. I know if you don't have anything at the beginning, so you don't have any chance to have an end also. Maybe in that case, we can treat for 1 year with a regime of clithromycin, erythromycin, ethambutol, and rifampicin or something like that. And if there are cavities or extensive disease, you can add amicus initially. So that can be a choice, but this is not rational. But in our setting, as you and I work, maybe that's the only way out. Unfortunately. No, no. The issue is now you have excluded tuberculosis. Gene expert is negative. It's a fairly sensitive test. Gene expert is fairly sensitive. You can repeat also. But if your gene expert is negative, so TB is excluded by all practical means. Then and then, as I said, then you can try to look at any evidence of tuberculosis elsewhere in the body, lymph node, hepatosplenomegaly, because TB can be present there also. So if you have evidence of that there, then it's more likely TB. Or if it is not, then you can go for working. It's not an ideal situation. What we are discussing is not an ideal situation, but the practical situation. But if you give both, you don't know which one is working. So it's better to choose one which is the most likely diagnosis, treat the patient, see if the patient is improving or not. If it is improved, continue to that. If it is not improving, think of the other possibilities. So that's how we can move about.
Sir, we have a question. In medical colleges, which have huge, they also must be having lots of bronchoscopy samples, are having isolation of non-tubercular mycobacteria. So we also have some situations here. So how do you take a call? I mean, obviously the gene expert was negative, initial negative. The culture takes time to grow. Acid fast stain don't always pick up the acid fast bacilli. And on the top of that, the bronchoscopy specimen has grew some bacteria, routine bacteria, for which the patient was started treatment on. So by the end of 2 weeks or 3 weeks, when we have the culture positivity and the gene expert negative from the culture, many times patients have shown some clinical response also. So, obviously it's a difficult sample to repeat, and patient may not always in a position to go the repeat procedure. So in this, these are the routine situation. You also must be having lots of such situation in medical colleges. So how are the decisions taken for continuation, for starting of NTM treatment?
So you said, what I understand that you said that you did a bronchoscopy, gene expert is negative, and some rapid test for NTM is positive, but the culture is not growing.
No, culture has grown after 2-3 weeks positive.
Okay.
And from the culture, MTB is negative. That means we are suspecting a non-tubercular mycobacteria. And by that time, patient has shown some clinical improvement because some E. coli, Klebsiella was isolated from the bronchoscopy initially.
So the patient was not started on any specific treatment. He was started on some antibacterial.
Yes, yes.
And now he's showing growth of some mycobacteria. Okay. Now, so if this is showing some mycobacteria, you can go for rapid diagnostic test from that to species, because if you need to know the species of that, because species will differ. The treatment is little different between different species. So you do a rapid diagnostic test like the LPA was done in this patient. So you can go for that. And if it shows some mycobacteria, go on the treatment for that. Because you cannot ignore the growth. If your mycobacterial growth is there, you cannot ignore. Bacterial infections are very commonly associated with them. Many of them have Pseudomonas co-infection. So only bacterial infection is not going to explain the whole picture, and there is a growth of mycobacteria. So we need to give importance to that. We do a speciation from that, and as per the speciation, you can need to treat. So that's should be the strategy.
Thank you, sir.
Thank you, sir. I would like ask you to discuss with sir. We can short of time. Yeah.
Thank you, sir.
So, thank you, sir. Thank you for the presentation. I would request Dr. Sudipto to hand over the small gifts of appreciations from us to the speakers and the chairpersons. So hand over the appreciation to Dr. Jogiraj Rai. Dr. Gaurav Goel. So now we would move to the next session. The speaker will be online for the session. So the next session will be on pneumocystis jirovecii pneumonia in non-HIV immunocompromised individuals. The speaker is Dr. Umang Agarwal. He's a consultant on infectious diseases at PD Hinduja Hospital, Mumbai. So he has sent his recorded audio video to us, and he will be online for discussion. The session will be chaired by Dr. Shumi Banerjee, consultant pulmonologist at Tata Medical Center, Kolkata, Dr. Shayan Chakraborty, consultant infectious diseases at Amri Hospital, Kolkata, and Dr. Devranjani Chattopadhyay, consultant, Department of Hematology and Cellular Therapy, Tata Medical Center, Kolkata.
Video, MP4 video.
Good afternoon, everyone. My name is Dr. Umang Agrawal. I'm an infectious diseases consultant at Helvija Hospital, Mumbai. At the outset, I would like to thank the organizing team of Tata Intense and Dr. Soumyadeep especially for inviting me to give this talk. Well, PCP is something that we have all seen in our clinical practice. We have all treated these patients. However, this particular bug is fraught with nuances, and I'll be dedicating a few slides to basically highlight the same. So this is going to be the outline of my talk. I'll start with a brief introduction, talk a bit about the structural peculiarity of this particular bug, which can actually address future potential therapeutic targets. What are the present controversies in treatment, PCP in HIV versus non-HIV? How does it differ? I'll talk about one case and wherein we had lots of diagnostic conundrums, and I'm sure that you would have faced this kind of a challenge as well. And I'll end the talk with certain unmet needs which needs to be addressed. So a talk on PCP is incomplete without mentioning this dear gentleman with an impressive mustache, I might add. Well, his name is Carlos Chagas. He was a Brazilian scientist, and as the name suggests, he was actually the one who discovered Chagas disease. Though not many people know that he was actually the first one to observe pneumocystis in Trypanosoma cruzi infected guinea pigs. At the time when he saw the structure, he did not know that it was actually a different bug that he had seen. He actually thought that it was just a part of the life cycle of the trypanosoma that he had encountered. This particular discovery happened in 1909, but it was in 1911 that the Delaunay couple from France actually identified it to be a different bug altogether. Now, when we talk about controversies in PCP, the biggest controversy of our times has actually been whether this particular bug is a protozoa or a fungus. And frankly, it took 80 years for the medical community to finally realize that it was a fungus. So the controversy starts with the discovery of this particular fungus itself. Now, it has a very unique structural peculiarity, pneumocystis. This particular bug cannot grow in fungal cultures, so we cannot really do susceptibility testing for a lot of drugs, and that does become a bit of an handicap as far as research aspects go. The cell membrane is actually made of cholesterol, not ergosterol. So ergosterol is actually the target for drugs such as azoles as well as amphotericin. But because the cell membrane has cholesterol, azoles and amphotericin don't work. So that is why they don't work. It exists in two forms. So if you actually see the one on the right upper hand panel, the A part, this is known as the trophozoite or the trophic form of pneumocystis, which is basically lined only by a plasma membrane. And look how beautifully it adapts itself to the alveolar epithelial cell. Yeah. This particular form is responsible for division of this particular bug, and it interacts with the alveolar epithelial cell through the fibronectin present, which eventually elicits an inflammatory response as well. I'll tell you the importance of this in some time. The more fascinating form is the cyst form. Now, one thing I wanted to say that as far as the trophic form is concerned, it does not have a cell wall. And this is one form which does not really have any beta-D-glucan in it. However, the cyst form, the wall of this particular cyst has lots and lots of beta-D-glucan. And interestingly, although this is not really the form that keeps replicating, it is this particular form which can actually interact with the alveolar epithelial cell and set off an innate immune response. Now, in PCP, we need to understand the basic problem with pathophysiology is not the bug, It's the immune response that it elicits. All right. And this is one peculiarity of the cyst, that it can elicit an innate immune response, which is responsible for the major morbidity and mortality associated with PCP pneumonia. So if you actually look at the life cycle, I'll tell you why that is important as well in some time. Uh, basically, this is basically the haploid form of the trophic form. The two haploid forms conjugate to form the diploid form, eventually forming a precyst, and then the subsequent cycles happen. Now imagine a situation. Presently, we all know that the treatment of choice for for pneumocystis is actually TMP-SMX. We all know that. But imagine, so we also know that echinocandins are something that have been tried in this particular instance in certain refractory cases. But imagine a situation that the trophic form has just gone into the alveolar epithelial cells. It conjugates, it's formed the precyst. Eventually, the precyst forms a cyst, lets out the trophozoite, and the entire cycle happens again. What if we start the echinocandins to begin with in the management of PCP? It will help in preventing the formation of this particular cyst wall because that is full of beta-glucan. That's number one. Secondly, because this particular cyst can interact with the alveolar epithelial cells and set up an innate immune response, it can indirectly actually cause an anti-inflammatory effect as well, you know. Of course, now this is just theory. We don't have any randomized control trials to do that. But this, for me at least, is quite fascinating to understand whether this particular life cycle can be employed for me in my clinical practice. Now, as I told you that TMP-SMX is the treatment of choice for PCP, and we also know that the dosing is almost 15 to 20 milligrams per kg. But have you ever thought where this particular recommendation came in from? Well, I did. And when I actually researched it, we actually found that this actually came in from a paper in 1975, wherein 20 children who had PCP were divided into two groups. 6 of them received a small dose, that is 7 milligrams per kg per day, and the 14 patients received 20 milligrams per kg per day. What did they find? That patients who had received high dose TMP-SMX, out of 14, 12 survived and 2 died, while in the low dose group, out of 6 patients, 4 survived and 2 died. And on the basis of this, the entire foundation of using high dose TMP-SMX has been built. While this was an exemplary paper, this was the first time that TMP-SMX was ever tried for the management of pneumocystis pneumonia. We can understand that it's been 50 years since then, and we have not really come up with anything else for this particular bug. Now, over the past few years, there have been some studies which have tried to understand whether such a high dose is really required in PCP or not. Can we really get away just with a low dose of low dose of TMP-SMX? And what did they find? That this was a multi-center retrospective observation study with the propensity scoring done, which showed that compared to 15 to 20 milligrams per kg, if you're using a dose of around 8 to 10 milligrams per kg, the clinical endpoints of the clinical efficacy is similar. The overall incidence of adverse effects is much lower in the low dose group, and the likelihood of completing the initial treatment is much higher in the low dose group. So whether using low dose or high dose, it has nil effect on mortality, but it does reduce side effects. It does ensure treatment completion. So probably I think it's time to veer away from high dose TMP-SMX management and maybe try to see if low dose works or not. Of course, it has still not become a recommendation, but I'm sure, but in near future, this is something that might be looked into. There is no doubt about the use of steroids in PCP. This was a Cochrane review, which was published in 2015, which showed that if steroids are used, there is a 44% relative risk reduction in mortality at 1 month, and around the number needed to treat is around 9. It reduces the need for mechanical ventilation by 62%, which is quite amazing. And the recommendation is to start steroids ASAP, and if not ASAP, at least within 72 hours of initial PCP treatment. So steroids definitely help, and undoubtedly so, isn't it? Because we know that the basic pathophysiology in PCP is not because of the bug, it's because of the immune response elicited due to the bug. Now, when we talk about PCP in patients with HIV versus non-HIV, we know that PCP is a bug which is pulmotrophic, rather it really loves the lung. But the patients who are immunocompetent are able to keep it at bay. However, as far as immunosuppressed are concerned, we will divide those patients into HIV and non-HIV, and how does the clinical as well as the overall manifestation differ. So this was an interesting paper in 1989, which showed that compared to non-HIV patients, HIV patients with PCP had a very high fungal burden, which can be seen in this particular table on the left. But the inflammatory response is quite low compared to patients who did not have HIV but had some kind of immunosuppression, either a malignancy or a transplant or whatever. So this is very important. Now, we also know that as far as PCP is concerned, higher the inflammation, lower is the saturation and poorer are the clinical outcomes. And that is what this particular study definitely showed. And this is when it was postulated that PCP related to non-AIDS will be associated with poorer outcomes. That was in 1989. Even at that time, we knew this. And now there have been several studies which have actually validated this particular theory. The first one was in Portugal, which was published in 2019, which showed that higher mortality and need for invasive mechanical ventilation was observed in patients who had non-HIV PCP compared to HIV PCP. And this was a study from Japan, which showed lower survival in non-HIV PCP versus HIV PCP. So we know that if you have a patient who is immunocompromised host and does not have HIV, and if he gets PCP, the overall prognosis of this patient is much poor. Now, let's start with this particular gentleman. This was a patient which we had seen around 3 or 4 months back, and I'm basically presenting this case to enumerate the diagnostic conundrums that we had with him. So he's a 66-year-old gentleman, diabetic. He was diagnosed with Goodpasture syndrome in December 2022. And thereafter, over the next 2 months, he was given pulse steroids. Had plasma exchange. He was treated with plasma exchange, had received 4 doses of cyclophosphamide. So lots of immunosuppression. And at the time, he was on TMP-SMX prophylaxis as well. He actually presented to us in August with, while he was on steroids, 5 milligrams a day. So that's just a minimal dose along with other thiopate. So what really happened this time? He had dry cough for 1 month, fever for 2 weeks with some mild breathlessness and intermittent hemoptysis. The cough had settled a bit with coimoxiclav, but the fever was still ongoing. CBC showed pancytopenia, and that is when he was admitted for further management. So he gets admitted on the 14th of August with pancytopenia, urine routine showing some hematuria. ANCA is negative. Bear in mind, this patient has Goodpasture syndrome. His CRP is 96 and the routine workup was negative. I'll be telling you about the HRCT test, which basically showed lots of nodules with some ground glassing here and there. And given that this patient had Goodpasture syndrome, had recently been given high immunosuppression, after which it had to be lowered down, and that he had cytopenias, vasculitis was something that was properly considered. They had gotten a BDG done. This is before we had come into the picture, which was still negative. So at the point, they had stopped the allopurinol azothioprin in view of cytopenias. Physolon had been increased and 2 cultures were sent, but no antibiotics were started, assuming that this is more of a vasculitis rather than anything else. However, around day 5 or day 6 of admission, his fever was still persistent. And that is when the primary physician was a bit concerned, after which he did repeat the cultures. The neutropenia was not really improving despite stopping everything for 4 or 5 days. He was commenced on meropenem and doxycycline empirically after sending the cultures. 3 days later, despite meropenem and doxycycline, this patient has come from the community, mind you. So this was not a bad combination to begin with. So meropenem and doxycycline, the fever is still ongoing and cytopenias are recovering slowly. At this point, a PET scan was done, which showed a break in the GGO, and that is why a bronchoscopy was done. And what did the bronchoscopy show? Routine cultures were negative, galactomannan was negative, fungal cultures were negative because there was some ground glassing that got a PCP by immunofluorescence done, which was negative. But the PCP PCR came positive with a CT value of 28, which is not that lower value. I mean, 28 is a significant value. Now, interestingly, that is when we got called in. And if you see here, by the time he had been called in, he had no fever for almost 24 hours. Of course, a bit too early to really judge, but that is when that is when the cotrimoxazole was commenced, given that the patient had the right risk factors. He had a subacute onset of illness, etc. I'll be discussing that in some time. So when we actually came in, the patient was non-hypoxic. So that was a very important clue for us. And despite around a month of treatment, he is non-hypoxic. And of course, the fever had subsided and the patient was feeling much better by the time we were referred, even before before the TMPSMX was started. So the question here was, do we really treat or do we not treat? So what were the factors in favor of treatment? The patient is an immunocompromised host with subacute onset of symptoms. The CT is showing ground glass opacities with some peripheral sparing. And the PCP PCR which has a CT value of 27 or 28, which is significant. It is not something that can be ignored as a colonizer. What were the points against? Well, we did have an alternative explanation for fever. The patient had neutropenia for some time, could have been just a neutropenic fever. The beta D glucan was negative. We do expect that high values in PCP, of course, and the clinical response had commenced even before we started Septra or cotrimoxazole. So when we talk about TB diagnostics, so whenever we are talking about a CT value, that's basically a semi-quantitative PCR. It is always very difficult to differentiate colonization from a true infection. And there have been some studies done to see if there is a specific CT value at which we can be sure that this is colonization or infection. So this was an interesting study which was published in 2016, which showed that for an HIV positive patient, colonization was excluded if the CT value was less than 27, while PCP infection was excluded if it was more than 30. So more than 30, it was colonization, less than 27, definitely an infection. However, for an HIV negative patient, given we know that the fungal load in HIV patients is higher compared to non-HIV, subsequently, even the PCR CT values would be higher for non-HIV patients compared to HIV. And that is what they found, that if the PCR value is less than 31, it was more likely to be an infection. However, if it was more than 35, it was more likely to be a colonization. Now, apart from the CT value, another thing that can be used is something known as the fungal load, PCP fungal load, wherein they find that the fungal load in colonization is much lower compared to that of PCP infection. Now, the problems with this particular testing is there are several PCRs available, each with a different value for fungal load. Each PCR has a different target. Presently, only the mitochondrial PCRs have been validated. So that again becomes a problem. And of course, you have different cutoffs in different studies. So we are not really sure that if I get a fungal load, for example, of 25 lakhs, what do I make out of it? Is it a significant virus? Is it a significant fungal load? Is it not a significant fungal load? We are still not sure. Another test that we can employ is, of course, beta D glucan, which can differentiate colonization from infection. This was a meta-analysis done from 23 studies, including 997 patients, which showed that the sensitivity and specificity of this particular test was 86% for non-HIV, 94% in HIV, and for specificity, it was 79%. Well, we had done a recent study which we have submitted to ECMID. This was actually done by our fellow Dr. Kruti Malur, who had taken lots of pains and she had worked really hard on this particular paper. And what she found was that the serum beta D-glucan value of 383 picograms per ml was 85% sensitive and 82% specific to diagnose PCP. It was also found to be an independent predictor of diagnosis as well. So BDG is something that can really be helpful in clinching the diagnosis, for instance. But what do we do? So what can we do if we combine different kinds of modalities together and see how it works? So that seems to be a plausible explanation. And this is one study that does that, which recommended that you combine the fungal load obtained in PCR along with the BDG for better differentiation of infection from colonization. Frankly, in our study, we did not find that, but our sample size was just 100. So we are not absolutely sure whether that works, but at least in this particular study, it did. So, even with this discussion, you can understand that there are so many discrepancies amongst different studies, and we are still not sure what is the right value of PCT value, what is the right value for the fungal load, etc. And that is where controversy does come into play. Now, coming back to our patient, we repeated a BDG which was again negative. Now, this patient had been into illness for almost a month, is not desaturating, has two BDG values which are negative. CT is not very impressive. And we just have one test with a significant CT value of PCP, but no other evidence. And for this particular reason, the plan was to hold the cotrimoxazole and see how the patient does. Now, fortunately, it's been 3 months. At 3-month follow-up, he's doing very well. So at this particular point of time, our decision to not treat him actually worked. But it could have really gone either ways. But see, ultimately, it all boils down to your gut instinct. It boils down to your clinical suspicion. And all these factors come into play whenever you're dealing with a patient with PCP, especially in a patient without HIV. In HIV, it becomes a bit easier because if you have a CD4 count of less than 100 or less than 100, you're almost certain that you need to treat it. Less than 200, yes, definitely. But in a non-HIV patient, it's always a conundrum. So what are the present challenges in PCP diagnostics and therapeutics? What sample should we use? Should we use BAL or induced sputum? We have different cutoffs for each sample. Semi-quantitative or quantitative PCR? And if yes, which PCR? Should I use a mitochondrial PCR? Should I use a non-mitochondrial PCR? We don't know. What is the target of that particular PCR? Does the patient have HIV? Does the patient not have HIV? How do I interpret the results of these tests? What is the pretest likelihood that a particular patient actually has HIV? So these are the challenges in PCP diagnostics still into play, which really warrants a lot of research. And of course, now as far as the therapeutic aspects are concerned, I've spoken to you about the high dose and low dose TMPSMX. But what is the right dose? I feel, is it 10 milligrams per kg? It's 15 milligrams per kg. It's 20 milligrams per kg. No idea. Can earlier kinokinin therapy help? I told you about the plausibility of using it early, maybe at the outset to begin with, maybe for the first 5-6 days, and maybe thereafter we can cut it off. But do we have any studies for that? No. Does it work? We don't know. But definitely something worth looking into. And ultimately, it just boils down to your clinical suspicion, radiology, and ultimately it's a gut instinct. And that is the major challenge that we have for PCP altogether. And I would like to end my slide by this particular quote, which is so true as far as PCP is concerned. Thank you.
Hello, Dr. Umang.
Any comments from the?
Thank you, Umang, for the nice presentation. Dr. Umang is online. We will just take you as a panelist so that you can speak as well as you are visible. Just a minute.
Umang is online.
Yeah, he's online. He can listen to us.
Okay, so thank you. Wonderful. Few times that we have the PCP PCR report positive and we are compelled to kind of treat, and you rightly discussed about the colonization and the infection part. So I just have one question. There was one study done by Dr. Rajiv Soman, I don't know, from Jupiter Hospital or Hinduja, regarding the use of gargle lavage for using as a sample for PCP. So your take on that?
So I think they had done that particular study in Jupiter only, and they had found good results with it. But there are not I mean, the experience in their center was quite good. So I think in difficult situations wherein really you are not left with any other option, this is something that might be useful.
Okay, was that
Dr. Umang,
PCP
can you just
PCR?
turn on your video? I think you will be audible now. I mean, visible now.
Was that PCP PCR or the staining?
No, it was a PCP PCR.
Okay.
Am I
Okay.
audible?
Yeah, yeah, you're audible. You're not visible. You can turn on your video.
Sure. Oh,
Very good afternoon.
it's written you cannot start your video because the host has stopped it. So,
No, no, we have allowed you just a minute. Just a minute. Anyway, let's go ahead. Anyway, let's go ahead. Yeah, sorry. Let's go ahead.
Hello, Dr. Agarwal. Myself, Dr. Shumi,
But
I'm a
mute.
pulmonologist. I just want to ask about PCP prophylaxis. Actually, we have to plan for a long-term steroids in cases of ILD and other, rheumatoid arthritis and all cases. So when we should start this PCP prophylaxis?
so generally we have been searching for that answer as well for the longest time. Unfortunately, there are no real recommendations. But what we generally do, wherein we are anticipating that the patient is going to be on steroids for a long time, especially at a dose of at least 0.3 to 0.5 milligrams per kg for over maybe 3 weeks, 4 weeks, 5 weeks. And we are expecting that particular steroid dose to continue. In that case, we do offer PCP prophylaxis in certain patients. Now, if you look at it from a practical point of view, I think the most that we have used this is in cases of TB meningitis, especially those who have had a paradoxical CNS response. In those cases wherein we know that the patient will probably require maybe high to medium dose steroids for a period of 4 to 5 months. In those particular patients, we do offer prophylaxis. If you ask me if there is any evidence to it, unfortunately, nothing that I could find as yet. But if you actually look at the pathophysiology of PCP, it's very interesting. What they actually say is steroids, whenever you're giving the steroids, that will predispose more to PCP. But the chances of PCP happening are more when you're actually tapering the steroids rather than when the patient is on high dose steroids. But either way, so this is one practice that we generally follow.
Hi, Dr. Omang. This is Debranjani from hematology.
Hi.
I have a question, sir. So the thing is,
Yeah.
very often the place where we come across PCP is in our post-transplant patients. Especially, I have encountered it on 2 occasions when the patients had chronic GVHD and one of the patients had a chronic lung GVHD. And like you rightly pointed it out, in this particular patient where we had the chronic lung GVHD, we actually had the PCP in her when we were coming down on her steroids. So when she was on very low dose of steroids, we had her PCP. So I'd like your opinion on the duration. So initially we put her on, she was requiring the ICU setup. She was almost in the ICU for about 3 to 4 weeks. And after that, we were able to wean her off and presently she's discharged. So what would be your take on the duration and the dose of treatment of PCP in a post-transplant setting and the need for steroids concurrently with Septran?
Okay. So just if I could understand the question well, you're asking me more from the treatment aspect rather than from the prophylaxis aspect. Is that correct?
Yes, absolutely.
All right. So as I'd shown you in my earlier slides, as far as non-HIV PCP is concerned, the fungal burden is not much of an issue. Now, frankly, I've just quoted one study, but there have been several studies, if you see, which show that even if you use a relatively low dose of Septran, rather than going from 15 to 20 milligrams per kg of Septran, if you're using 10 to 15 milligrams per kg, for instance, the overall efficacy is similar and the side effects due to Septran are relatively less. And given that the fungal burden is not expected to be an issue in this particular setting, I would probably go from 10 to 15 milligrams of TMP SMX to begin with. I wouldn't mind actually putting that patient on an echinocandin to start with. As I told you, I think although this has not really been studied, but theoretically it makes a lot of sense that if you are able to lyse the cysts at an earlier stage, then the chances of that cyst inciting an inflammatory response can also reduce at that particular point. So it indirectly also has some kind of an anti-inflammatory activity. So if the patient is sick, I would probably start that patient on cotrimoxazole along with echinocandin. I will optimize the dose of steroids, probably 40 milligrams VD to begin with, and then see how it goes. If you actually look at the dosing of steroids as well, all the recommendations have come in from patients who actually have HIV-associated PCP.
Yes.
However, we know that the inflammatory response is stronger in a patient who has a non-HIV PCP. So if 40 milligrams BD of steroids is not working, I won't shy from giving a higher dose at that particular point.
Right. Okay. Thank you.
Thank you, Dr. Umang. Thank you. Thanks to the chairpersons. I would request Dr. Shudipto to just give a token of appreciation to our chairpersons. Dr. Shumi Banerjee. Dr. Devranjani Chattopadhyay. Umang, your gift will remain with us.
I'm sorry?
Your gift remains with us.
Of course. Thank you so much, everyone. It was
yeah. Most welcome. Our
it was
pleasure
an
to have
absolute
you
pleasure
online.
interacting with everyone. Sorry?
Our pleasure to have you online. Thanks a lot.
Thank you so much. Take care. Bye-bye. All the very best.
Thank you. Thank you. Bye.
Bye.
So our next presentation will be again on critical care, back to critical care. And I'd like to invite our next speaker, Dr. Chandrashri Chakraborty, Senior Consultant in Critical Care, Apollo Multispecialty Hospital. And his talk will be on advanced ventilatory modes and closed loop ventilation and AI. And I will request Dr. Shashwati Sinha to join us as a chairperson. Shashwati ma'am is a Senior Consultant in MRI Hospital, Kolkata.
Hello. Thank you, Shudipto, for inviting me today. There's been back-to-back quite a bit of difficult topics. And this is one topic which is, again, very difficult to follow on a lecture basis. It's more of a workshop topic. It's probably a little bit too long to cover in 15-20 minutes time. So I'll try to basically highlight on certain things and then move and leave maybe 2-3 minutes for questioning if there are interested people. So how can I move it? Not moving. Okay. So some people call it advanced modes. I will probably just say these are newer modes of ventilation. And why do we need it? Probably because these variables are self-adjusted and not limited to a single parameter, which basically means that if there's a threshold of one component is reached, it shifts to other alternative set parameters. So what are the controls that a conventional mode uses? So it uses cycling, it uses limits. And these newer modes usually have dual control. Either they have dual control, that means they're using two things to cycle, or they can be also open versus closed loops. So what we mean by closed loops is basically that the modes takes feedback from the patient parameters and adjusts accordingly to best suit the patient needs. What would be an ideal mode, newer mode? So it must be adaptable to a wide variety of patient or different patient conditions, able to adapt to changing lung mechanics on a breath-to-breath basis, utilizes the protective ventilation strategies, shortens weaning time, and shortens duration of mechanical ventilation. This is ideal. But obviously, the newer modes are still far from it, because most of the newer modes, if you see, it doesn't have very good studies to show that they have actually been able to change outcome to a significant extent. These are, if we say the newer modes, it probably, this is a kind of a more or less list of that, which is VAPS, volume support, ASV, PAV, MMV, APRV, NAVA, and NeoGanesh. And as you can obviously understand, it's not possible to go through or describe all of them. Dual control within a breath and dual control in subsequent breaths. These are the two ways in which dual control happens. Dual control within a breath example is VAPS, and in subsequent breaths are like PRVC or ASV. So among spontaneous modes, just like volume support, we have just like pressure support, which is the most commonly used spontaneous mode. Among the newer modes, we have volume support, where we can fix the volume that you want to give and the pressure adjusts. Or it can be a PAV. I'll come to a little bit of PAV. And there are some hybrid modes, which are volume assured pressure support, pressure regulated volume control, adaptive support, bi-level or APRV, and mandatory minute ventilation. So PRVC, or pressure regulated volume control, is again a servo controlled closed loop system. It combines both modes, dual and hybrid. It takes feedback from the patients, modifies the ventilatory support, and monitors the patient respiratory mechanics. It behaves like pressure control, but it has got a guaranteed minute ventilation, and the set volume is achieved by changes in pressure. So as we know that what happens in pressure control and what happens in volume control, if you take pressure regulated volume control, that is, they will have a stable tidal volume, stable minute ventilation, and flow varies with demand. So it has advantage of both modes. It benefits a variable flow from pressure control, but it guarantees the minute ventilation of volume control. So usually it starts with an inspiratory pressure of 5 to 10 centimeters above P of 5, and it measures the tidal volume and the P plat and calculates the compliance and compares it with the set tidal volume. And then it auto adjusts to give the tidal volume with the lowest positive inspiratory pressure. Here, the limit is pressure, the target is the set volume, the cycling is time, and the trigger is the patient or time. So what varies is really the flow or the inspiratory time. So because the flow varies or the inspiratory time varies, it's important to understand that it's not very comfortable for very awake patients. Because with every breath, if you get a different flow or a different TI, then it's kind of, it causes dyssynchrony. And if you have a high inspiratory drive, that also kinds of tells the ventilator as if they need less they need less minute ventilation, and in that way it increases the work of breathing of the patient. So these are things which are sometimes a problem with PRVC. The same problem actually happens with pressure support ventilation as well. So some people say that a set it and forget it mode, it should not be the initial mode upon initiation of mechanical ventilation. And in high respiratory drive, because of adaptive targeting, the ventilator decreases the total minute ventilation, leads to overall increase in work of breathing. So it should be set in patients with a stable respiratory drive. Now, a little bit about ASV, which has become probably, in my opinion, the most accepted newer modes across the world. If you look at Hamilton's adaptive support has taken over the world. Most of the nurses, if you talk Europe or US, they love using this mode because it's kind of a mode in which you can put the patient, and most of the time the mode self-weans the patient. So what is the basic principle? I'm going to spend a little bit on this mode, and then if I have time, then a little bit on PAV, and that will be all. So if if you look at the respiratory system mechanism, so the basic principle on which ASB works is it will calculate from the initial breaths, it will calculate the compliance and the resistance of the respiratory system, which basically has two components. One is the patient and the machine. So if the compliance is low, which basically means a patient with, say, pneumonia or ARDS or pulmonary edema, the machine basically tries to give low tidal volumes and high respiratory rate. On the other hand, if they find that the resistance is a problem, then they will give a slow, deep breath, just the way we give to asthmatics. Now, the operating principle is at the pressure control mode. It's a pressure control with a minute ventilation guarantee. Now, this is the only place of ambiguity in ASV where the physician has to guess what is the minute ventilation that the machine needs to give. So is it 100%? Is it less than 100%, 120%, 130%, etc.? That is the guesswork. You have to do some guess and start it. And then obviously, depending upon your blood gases, you can come down or adjust the minute ventilation. But this is the area of guesswork that the physician needs to give. The general trend is, or the general guidelines is, that you start around 120 to 130% of minute ventilation. The minute ventilation is again what the machine calculates from the patient's ideal body weight, and then it calculates the minute ventilation. So now sometimes there is an advanced form of ASD, which is called an IntelliVent, when the machine takes feedback from the ventilator in the form of the end-tidal CO2. And this IntelliVent makes it a complete closed loop ventilation, which means that the machine takes feedback from the patient and therefore tries to adjust the minute ventilation. If it is not an IntelliVent, then you have to adjust the minute ventilation depending upon the ABG analysis, what you do. So this automatic adjustment of settings to optimize work of breathing is always happening. And there's a feedback based on respiratory mechanics. In 1950, Otis and Mead developed this equation, which is called the Otis and Mead's equation. I'm not telling you to remember it, but it basically tells you what should be the optimal respiratory rate at which the work of breathing is minimal if the equation of motion is followed, right? So for example, if you have a target minute ventilation of say 6 liters per minute, it can be achieved in so many different ways. Let's say if you give 600 ml of tidal volume, you need 10 breaths, or if you give 150 of tidal volume, you need 40 breaths. So how much does the machine give? Because you are only setting the minute ventilation, right? So how it works is that the machine makes a kind of a box plot. So in which it takes a minimal respiratory rate beyond which the respiratory rate will not go down. That's the apneic threshold. Let's say 5, 6. And then it takes an upper limit, which is say here. So above which obviously there'll be a lot of auto peep. As we know that in all forms of conventional ventilation, our expiration is passive. And because expiration is passive, if you give a very high respiratory rate, there will be gas trapping. Except there was only one mode of ventilation, which has now, for some research work, has gone out of use. We used it at one point of time. It's called a high frequency oscillator, where the expiration was active. And there we could give respiratory rates up to, say, 120 or 180. But now it is not used anymore. So otherwise, you always have to limit your respiratory rate. And then you have a tidal volume below which it will not go, because this is the minimum dead space ventilation. Again, it can be calculated from the patient details. And It will not go above a particular tidal volume because of the risks of barotrauma, etc. So this is the box in which the machine will play. The machine will play. Now, this line is constructed based on the mechanics of respiration. Okay. So this is how the ASV screen looks like. So this is the line which is constructed from the equation, Mead's equation. And it says that if to maintain a fixed minute ventilation, the respiratory rate and tidal volume should fall within this line. And this is the box. And this box becomes more like a rectangle, a flat rectangle or lying rectangle in patients where the compliance is low. And it becomes like a vertical rectangle in patients where the resistance is high, like a asthmatic or COPD patient. So this is the principle on which it works. So this is what I said. So if you have a low compliance, you have a wide rectangle like this. And if you have an obstructive lung disease, it becomes a narrow rectangle. So any change in lung mechanics which pushes the patient beyond margins of ASV square window tends to automatically make change, brings back the minute ventilation inside the square window. Okay. What you said obviously the ideal body weight, you said the minute ventilation, and the rest of the things like the PEEP and FiO2 and the trigger and the expiratory trigger sensitivity and high pressure alarms, like you said in all conventional modes. If it can measure the CO2 from the endotracheal CO2, from the end tidal CO2, then it can adjust the minute ventilation. If it cannot, then you will have to adjust the minute ventilation. Okay. Now, how does it wean? So weaning is you can decrease the minute ventilation. Say you have set 100%, you decrease it by 10% with frequent assessments, and it can be tapered up to 25% of minute ventilation. Once it's down to 25% of minute ventilation, this is when the ASV parameters are minimal. And the ASV gives you a prompt that you can shift to spontaneous breathing, or you can actually see that the patient's respiration is above what the machine is giving. And it automatically switches from pressure control to pressure support kind of mode. And then you can extubate. So P inspiratory of 8 centimeter water above baseline, and you can extubate. So it's again an auto weaning mode, and that is the advantage. What is the problem then? So the problem is that what I found whenever I have used ASV, I've been fortunate in using ASV when I have worked abroad in quite a few places, is that if you have a pure kind of a respiratory problem, for example, you are dealing with pure obstructive lung disease, it will work well. If you are dealing with pure, low compliance, it will work well. But whenever there is a mixture or there is a leak or there are other problems happening, then again, I think conventional modes are better. And that is where you have to come back. Okay. Sudipto, do I have time or no? 5 minutes? Okay, then I'll just give a little bit of PAV and that will be all. Because as I mentioned, it's not possible to cover newer modes. And anyways, I'm old and old school both, so I take time. So proportional assist ventilation, again, so what is proportional assist? And what was the need of it? It is basically something very similar to pressure support ventilation. It is found in Puritan Bennett 840. Pressure support has been the major way in which people have used spontaneous modes for weaning for a very long time. But just like PRVC, the problem with pressure support is the machine can misinterpret a high inspiratory drive for a low requirement. And therefore, the work of breathing can keep on increasing. That's number one. The second is exactly the opposite. That means a high pressure support can fool the brain of the patient, and the carbon dioxide can drop below the apneic threshold of the brain, and then the patient goes into a periodic breathing or a chain Stokes kind of a breathing. So these are problems of pressure support, which and there are some more problems which has been found pretty recently, and therefore there are a group of physicians or intensive care physicians who now think that proportional assist is probably slightly better than pressure support, especially a group of French and Canadian physicians who have been trying to popularize this. So what is it? It basically delivers variable pressure support to reduce patients' work of breathing. So instead of fixing the pressure support, you say, or you fix that what is the work of breathing that the machine needs to take away from the patient. Okay, it self-adjusts with each breath, and the settings are again a work of breathing bar. The rest of the PEEP and FiO2 and sensitivity remains the same, the way you set in pressure support. So the bar looks like this. This is how the PAV bar looks. The work of breathing is a measurement of the amount of energy which is expended to move a liter of gas into a patient. And the equation of motion, which is basically the total work done, is divided between the muscle and the machine, right? And if you look at what the machine can do, it will be basically totaled into the percentage of assist. So the ventilator assists the total work of breathing and divides the work between the ventilator and the patient as per the amount of pressure support dialed. So for example, if you want, say, 25% of the work, so the patient does 25% of the work and the vent does 75% of the work, and you select that a percentage support of 75% is necessary. If you decrease the percentage support, the work of breathing patient shifts to the right. And if you increase, the work of breathing of the patient shifts to the left. It is important that this box should be within the green window. If it falls towards this side, that means the patient is doing more work. If it falls to this side, it means the machine is doing more work than required. And obviously, because the work of breathing is what is constant, so the pressure support changes based on the patient's efforts. Okay, so it regulates the pressure output of ventilator moment by moment in accordance with the patient's demand for flow and volume. The muscular effort and the airway pressure assistance are better matched for PAV than for pressure support. So indications are again patients with work of breathing problems or with worsening lung characteristics, asynchronous patients who are stable and have an inspiratory effort, and ventilator-dependent patients with COPD who are difficult to wean. Okay, so here the advantage is that the patient controls the ventilator variables. The patient controls how much of pressure support is required, not you. You don't have to dial that. The trends changes of ventilator efforts over time. So you can automatically see that yesterday the patient's work of breathing was somewhere else, and today it has decreased. So now you can further come down on the dial to the percentage support. And finally, if it's below 25%, you can probably wean it off. Okay. The disadvantage is that patients must have an adequate spontaneous respiratory drive, which is mandatory for any spontaneous mode. The tidal volume and the peak inspiratory pressure varies. The air leak can cause excessive assist, and therefore it's not a great mode if you have an air leak from any reason. And the trigger effort may increase the auto PEEPs. Okay, I'll not go into airway pressure APRV. That will be again a big talk. Again, thank you, Sudipto, and I think I'll restrict the talk to here and put it over to Shashwadidi if you have any comments or questions. Thank you.
Thank you, Chandrashish, for giving a lot of insight into a very difficult topic in a short while. My only question is, in the Indian setup, where we, in the Western world, where they use a lot of IntelliVent, although they have a lot, not only a lot of physicians, but also respiratory therapists who can take care of the ventilatory setup. So what do you think these newer modes, especially this IntelliVent, can have in our situation where adjustment of the ventilator, weaning, would it really be of lot of help, or do you think it's going to create more complacency and people might just set and forget?
I think it will be useful for post-surgical units like cardiothoracics and surgical units, transplant units, where you really don't need a lot of intensive care input.
Right.
You can put it and forget it, and it kind of self means. You are right. We don't have nurses or respiratory therapists who weans patient in our country.
Yeah.
In pure medical units, probably I don't think it will make a huge outcome difference.
Yeah.
And that's why it has not picked up that well in pure medical units.
Yeah.
Yes. The other problem is that ASV is a mode which is only restricted to one company, that's Hamilton. So if you don't have Hamilton,
If you don't have
can't get
Hamilton, then you are not used to it.
You can't get it. Yeah.
Thank you.
Thank you very much.
Rest, I think we can continue the discussion in the tea break. We'll take a 5 minutes tea break and we'll come back. Small token from Tata Medical Center. Please join for the tea 5 minutes, then we'll come back. Madam, session আছে ম্যাডামের সেশন আছে এরপরে এখন না ইউ করে মানে আমরা বেলা ভিস্তা নিয়েছি বেলা ভিস্তা তো এসভি আছে
Can I listen?
After the tea break, on respiratory multiplex PCR on SARI in cancer and hematopoietic transplant patients. So are you overdiagnosing with the new modality that we are presently used to diagnose bacteria? So to moderate the session, I'd like to invite Dr. Debjani De. He is a MD microbiologist, gold medalist, and is the national lead of BioMedu. Ma'am, please join us. And I'd like to invite the panelists. Dr. Shayan Chakravarti, consultant in ID in MRI Hospital, Kolkata. Dr. Shomen Shaha, the consultant microbiologist, Medical Super Specialty Hospital. Welcome, sir. Dr. Shashwati Sinha, senior consultant, critical care hospital. Please, ma'am, join the stage. And Dr. Joyiraj Ray, assistant professor, associate professor, and head of the Department of ID in IPG. Welcome, sir. Over to you, ma'am.
Thank you so much for the kind introduction. At the outset, I would like to thank the organizers of Tata Intense, Dr. Shudipto and Dr. Soumyadeep for inviting me. My sincerest gratitude to you. And I'm indeed honored to be moderating this panel of stalwarts. And to set the context on what we are to discuss in the next 30 minutes, respiratory multiplex PCR for SARI in cancer and HSCT patients, are we overdiagnosing? Does this work? This slide changer? Yeah, okay, all right, okay, sure. So to discuss, to put things to perspective, HSCT, the number of HSCTs has gone up substantially, with more than 50,000 HSCTs being performed annually. In spite of substantial improvement in peri-transplant care, there is still a rise in pulmonary complications, both infectious as well as non-infectious. And this is a severe deterrent for the success of, of course, totally. So this is a severe deterrent for HSCTs that are being performed. So we need to look into the infectious complications. Specifically, in this session, we'll be looking at the infectious complications. So to put things to perspective, pulmonary complications and respiratory failure are common, occurring in up to 2/3 of HSCT recipients in totality. And the CFR, that is the case fatality rate in particular, is as high as 90% in some of the recipients of HSCT. Some investigations also suggest that as many as 80% of HSCT recipients will experience at least one episode of pneumonia, and pneumonia is the cause of death in 20% of HSCT patients. So this is the magnitude of the burden that we have at hand. Coming to malignancies, pneumonia are estimated to complicate nearly 10% of hospital admissions among cancer patients, notably including patients with hematological malignancies. So what is the challenge in this cohort of patients? So the enhanced susceptibility in this patient population is because of the aggregate effect of the disease, treatment-related immune dysfunction, disease and treatment-related anatomical derangements, healthcare-associated pathogen exposure that in totality leads to the exact nature of the individual's patient susceptibility, which is enhanced to the disease. What makes it even more challenging and a conundrum is that the attenuated signs and symptoms in these patient populations, and of course certain mimics, the non-infectious mimics, which have a similar presentation, which have to be dealt with. So the cardinal features of pneumonia, such as fever, cough, purulent secretions, and leukocytosis, may be dulled or blunted in these patients, and they are more predisposed to atypical pathogens, opportunistic infections. So here the clinician needs to really be vigilant and have a high suspicion. And of course, the mimics, such as the non-infectious mimics like bronchiolitis obliterans, diffuse alveolar hemorrhage, and cryptogenic organizing pneumonia have to be looked into. Then there is always a challenge the clinician has to face in terms of differentiating between a colonizer ventilator-associated pneumonia, and ventilator-associated tracheobronchitis. So those are the challenges. So therefore, even when the clinical presentation is strongly suggestive of pneumonia, alternative diagnosis have to be revisited and the diagnosis must be considered and addressed. So because there is unreliability and paucity of symptoms, so there is not a single bedside tool which would help you rule in or based on symptomatology alone. Talking about radiology, CT scan is a good tool. However, it has its own caveats. For example, it was seen in a retrospective study that patients with AML have 88% of them had a baseline abnormality in the radiology. So with that, we talk about microbiology. So this is a publication where they have outlined how to go about diagnosing bacterial pneumonia in cancer patients. So the best tool would be to identify an organism in the most sterile specimen that we can get, that would be giving us the most convincing diagnosis. So BAL remains the diagnostic tool of choice for immunocompromised host pneumonia. And the standard of care yield, we know the standard of care doesn't yield us much. So this is what the study also says, that 25 to 51% was the yield. However, the yield was better if it was prior to the sample was taken prior to antibiotic therapy and performed soon after the onset of pneumonia. Diagnostic yield, of course, will be enhanced if a rigid protocol of BAL is adhered to, and it was also seen that the performance was better if it was done in the first 4 days of symptoms in HSCT patients with suspected pneumonia. So using these pointers, probably it would be we have a better chance of clinching the diagnosis. So talking about the context and how to go about it, I'll talk about the multiplex PCRs that we have, and the assays that we talk about are BioFire film array assays, the panels and the specimen types. So this is the pneumonia panel we know of. So here you can see there are 15 targets, common bacteria, there is semi-quantification of bacteria. There are atypical bacteria, those are not quantified. Then there are viruses, and there are 7 AMR gene markers. And the sample type being BAL and sputum and endotracheal aspirate with a high sensitivity and specificity. Now there is another panel that we talk about here is the RP 2.1 panel with 45 minutes in which you can get the report. And there is one more additional virus here, which is not there in the pneumonia panel, that is in bold, that is SARS-CoV-2. And it has pertussis, parapertussis as well. So these are the panels that we talk about, and this is the sample. The sample type here is the upper respiratory sample, that is nasopharyngeal swab. So when do we go for an RP 2.1 or a pneumonia panel plus? So this is the algorithm. If we are able to take a lower respiratory tract sample, if bronchoscopy is indicated, BAL fluid, nothing like it. But if the patient is able to expectorate a good sputum sample, then the lower respiratory panel needs to be performed. The Journal of Clinical Microbiology says if these samples cannot be taken, the nasopharyngeal sample can be a good surrogate for what is happening inside the lung. However, still there would be 10 to 15% of times where you can miss the real diagnosis. However, that being said, if we are going for an RP 2.1 in a patient, we suspect have pneumonia with targets that are there on the RP 2.1, we should be able to interpret that information based on the limitations of the RP 2.1, because it would be missing 10 to 10% times of the cases. It is just a surrogate. So this is how the algorithm looks like. If able to take the sample, low respiratory sample with pneumonia panel plus, but if we are to collect, we go ahead with the nasopharyngeal swab, and RP 2.1 is our panel that has to be run. And if the patient gets better, that is fine. But if the patient deteriorates, then we'll go for a lower respiratory tract sample. This is another guidance paper that has come up recently. This was the American Transplant Society, which convened a consensus amongst certain experts, an expert panel was convened where they found out that where these panels can work. So they reviewed and appraised available analytical and clinical data for advanced diagnostic tests, because there are numerous novel diagnostic tests that are available. So they developed certain pragmatic approaches on how these panels can be used. And the highlights of the consensus conference were: for pneumonia, upper respiratory tract panels, they concluded may be potentially useful in the initial workup if there are diffuse infiltrates on chest imaging or GGOs that are there. For focal nodules consolidations, a lower respiratory tract panel would be more useful. Talking about semi-quantification, how does the semi-quantification work? So the basic principle of semi-quantification in the BioFire is based on the principle of semi-quantification of sputum culture that was initiated in 2004. So in 2004, the ATS gave guidelines on how to, there were cutoffs. So for sputum, it was 10 to the power 6 because it has more, there is more likelihood of oral flora, and for bowel sample it was 10 to the power 4. However, in 2016, the IDSN ATS moved away from absolute cutoffs and they moved on to relative quantification. So whenever we see on a report, there is a relative ranking, and based on predominant abundance of the pathogens that are detected, that makes the chances of that organism being a pathogen more likely. So this is the principle pneumonia panel as well. So there are no cutoffs and there is no consensus on what would be the exact cutoff discern a colonizer from a pathogen. So there have been several papers though. So if you're not having any standards, we have to go by the best quality of sample to conclude if you have caught hold of the pathogen or the colonizer. Although the pneumonia panel IFU doesn't say so, but good lab practices would always say that a report is as good as the sample that we take. So if we send in trash, we'll get a trash report. So we have to conform to good lab practices and cutoffs. And there are, of course, we need to have a priori knowledge of the colonizers or the commensal flora. So in the nasopharynx, we know strep pneumoniae, Staph aureus could be a colonizer. Of course, the clinical context, we know that in HSCT, initially just after transplant, the chances of bacterial infection are more. And after 100 days, the chances of strep pneumonia infection more so. After 6 months of infection, the chances of encapsulated organisms being a pathogen becomes more relevant. Discordances we'll be talking about in the panel on culture negative and BioFire positive. Why this happens? There is a rationale to it. Of course, prior antibiotic administration, more so in malignancy patients who are on long-term antibiotics, empiric therapy could be a reason. So a BioFire coming positive and culture coming negative is not actually a BioFire coming false positive. It is actually the culture coming false negative because there is higher sensitivity of molecular tests. So these are certain guidelines which also support these findings. I'll be talking about shortly about the Buchan et al. Study, which is a landmark study on 259 bowel samples. And they found out whenever we are getting a value of 10 to the power 4 copies per ml in the pneumonia panel, we don't really know what is it, a pathogen or a commensal. So this is what the paper says. The clinical significance of additional culture negative low concentration 10 to the power 4 copies in pneumonia panel requires further investigation.
Dr. Devjani, it will be good if we can move on to the discussions because we are running short of time.
Sure. So we'll be talking about the discordances and discrepancies with the subject matter experts. And with this, I'll start the panel discussion with this context. So my first question would be to Dr. Shayan. In your clinical practice, so that we are not over-diagnosing, what are the indications of use of the RP 2.1 on pneumonia panel in your clinical setting in these patient populations?
Yeah, so you have to separate the two patients, cancer and HSCT. So if it is a patient of HSCT, you have to see whether the patient is in the pre-engraftment phase or the early post-engraftment or late. Because like the table you have shown, the organisms that cause infections are different. So initial, if it is pre-engraftment, then definitely the gram-negative infections are more common. And just after post-engraftment, some viral infections as well. So in that case, we can use this panel definitely. But when it is going to the late engraftment phase, in that case, the fungal infections are more common. The fungal organisms are not being covered in the pneumonia panel. So in that case, it's better not to use that. And in cancer chemotherapy patients, very important history taking is when was the last chemo taken and what was that chemotherapy medicine? Because if it's a B cell related thing, then there's certain other infections are there. It's a T cell. So the immunology of infections is different in both cases. Again, you have to think of what organism might be causing this disease. So if you think that it's a CMV or a PCP, again, those are not covered in the pneumonia panel. So we have to keep it separately. But yeah, if you think that if the patient is intubated, if patient is then there in the ICU for quite some time, and you feel that there might be a VAP, so in that case, pneumonia panel will be definitely very much helpful.
You, Shashwati ma'am. To clinch the diagnosis, we know every sample has its challenges either in the collection or in the interpretation with respect to the pneumonia panel, if we talk about, or the RP 2.1. Your comments.
So I think that's a very important thing to understand because they cannot, we often should not be comparing sputum because it may not be possible to, do a BAL, or if the patient is very hypoxic, so that patient may not be the perfect candidate to undergo a bronchoalveolar lavage. And a lot of patients are not intubated, especially in immunocompromised patients. A lot of them, we would prefer that they would rather not be intubated. But again, when you test a sputum, like you've already mentioned, the interpretation of the pneumonia panel should always be in context of the quality of the respiratory sample which is provided. So if it is a good quality sputum, it has shown to be quite reliable, and there have been studies which have compared the concordance between the organisms which have been found in the pneumonia panel versus the culture. So there is often a very good concordance if it is moderate to good quality sputum, but there is a lot of discordance if the quality of the sputum is quite poor. So that is an issue. And of course, all of these things will need to be individualized, which particular sample you can send, depending upon from patient to patient.
Thank you, ma'am. Thank you for the excellent answer. My next question is to Dr. Yogiraj, sir. Sir, how do you interpret polymicrobial or multiple organism detection in the panel? I think that is a very frequently asked question. And how do you address it?
So this is a very frequently faced problem. What we do, we see whether it is sputum induced sputum or it is a sample from deeper tissue like a bell or mini bell. If it is a bell or mini bell, we have to accept that this is a representative sample. But if it is a induced sputum, then we have to look at what microbiologist is saying about rapidly seeing the initial sample, whether it is corroborating the usual acceptable sputum scenario, like for 4:1 ratio of pus cell versus epithelial cell. If it is corroborating that, then it is acceptable sputum and it is an acceptable sample for it is a representative for lower respiratory sample. Then we are assured this is probably representative of the lower respiratory tract. Then if we get multiple genes, so what we will think? So multiple genetic isolate means if it is more than 10 to the power 5, we will accept it. Below anything, we can ignore. But if there are often 2 or 3 things, we get more than 10 to the power 5. So in that time, we have to think about what is the presentation of the patient and what is the radiological evidence of pneumonia in this patient, and which organism is matching with that. Even if in this scenario, often we get at least two bacteria that can present like that, like E. coli, Klebsiella you are getting, like a Acinetobacter and E. coli you are getting. Then in this situation, we are in a situation where we have to give multiple pathogens in this context as a causation of the disease. And in a HSCT or who is in early pre-engraftment or went home just after engraftment and coming back, initial part, we have to consider this could be a causation of the disease, because patient already got multiple antibiotics during his transplant. And also in cancer chemotherapy patients where they have often given multiple antibiotics, these patients can have multiple infections with different resistant bugs. In these situations, probably we are over treating, but we cannot resist ourselves giving antibiotics based on multiple infections.
Absolutely. Under diagnosis, we can't take the chances here, especially when these patients are already immunocompromised. Next question is to Dr. Showman. So, my question is, what are the challenges reporting results when you are reporting these results? Where are the areas where you face maximum queries from the clinicians while reporting out pneumonia panel plus?
Okay, so I would like to say that the queries are quite similar. There's my clinicians right now, they are discussing about it. Whether it is a multiple pathogen, if it is a multiple pathogen, that whether all of them are significant, whether one of them is significant, if there is some genetic target of resistance, drug resistance is detected. So what to, how to go about it, whether how to plan my treatment choice and all. So I would say this discordance or difference, rather I would like to prefer this term, would definitely be present or can be present if a culture is prescribed simultaneously along with some kind of PCR panels. Now, what may be the different causes? Let's keep them apart. But most important thing is that while interpreting the particular report of the PCR panel or even the culture also, because sometimes even that we also get multiple organisms in the culture, not only in PCR panels, and that is also sometimes with similar kind of colony count, with dissimilar kind of colony counts and all. So the most important thing is that whether this particular result is going to, whether it will affect my treatment choice or not. That is important. Whether it is a 2 organism or 3 organism, my number of antibiotics doesn't exponentially increase depending on that particular number. But whether it is a gram positive or gram negative, significantly gram positive or significantly gram negative, whether some type of organism has been detected that will influence my treatment option or treatment choice, that is more important, I would like to say. So if I had not gone into that particular controversy, that which one is the most important organism that has caused that particular infective condition and which one is the colonizer, I would like to say that clinically my patient is infective and I have gotten predominant pathogen type, and I have also gotten that target to treat for. And now the difficult part is that when the phenotypic sensitivity is not actually matching with the genotypic sensitivity one, and that also to some extent can be palliatable. But if there is large differences there, then the difficult part lies actually. Suppose I have detected a carbapenem resistant gene, but my plate or my panel is showing that carbapenem is sensitive. So in that particular point of time, I would like to say that the typical explanation is the gene is present but may not be expressed. The physician's choice is like that. If the gene is present, I do not know whether on the 2nd day or 3rd day it is going to be expressed or not, whether it is a chromosomal or it is a plasmid, whether it can be induced or it's not possible to be induced. So there are a lot of confusion lies over there. So a better option will be to target for the enzymes. If it is the enzymes is there, then definitely it is a difference from the PCR panel result and the phenotypic sensitivity result. And if the enzymes is not there, then I think we should rely more upon the phenotypic sensitivity result. And that is an important take home, that whether I am actually prescribing a PCR based panel or not, I also should consider the, that conventional culture as a thumb rule, right?
And most of the discordances are in gram negatives, or have you seen the gram positive AMR gene and phenotypic susceptibility discordance as well?
Actually, fortunately or unfortunately, most of them are gram negative actually.
Yes, yes.
So the isolation of gram
That is-
positive organisms are so less
And
that the
straightforward gram positive.
Right.
We have MREJ, which is MRSA, it is confirmatory.
Exactly,
So,
exactly.
But in gram negative, we have many mechanisms which are off the panel. So,
right, right, right.
Thank you. Yeah, so to Dr. Shayan, what are the gatekeeping mechanisms which prevent you from overdiagnosing, where the clinical context, overpowers and supersedes? How do you go about it?
If it is not a cancer chemotherapy patient or HSCT, then definitely overdiagnosis becomes a problem. But if it is in this scenario, in this hospital, then definitely underdiagnosis becomes a problem. So, yeah, we would definitely look for the organisms which is causing the infection. If we do for a SARI patients, we are doing the multiplex PCR for the this pneumonia panel. We suppose we got some organism, we are treating the patient, but patient is still not getting well. So definitely there are chances that there might be other organism as well. The opportunistic infections, like maybe CMV, like other adenovirus or PCP or anything else. So most important thing is in the clinical context, we have to make a differential diagnosis that what is the source of the infection and what are the organisms that can cause this infection. That is the most important part. Then you start looking for those organisms, and eventually you get on finding them and treating them. So gatekeeping mechanism is most important, is the clinical thinking and doing a pretest probability that what can be the cause.
Thank you. And genotypic phenotypic dilemma we have already discussed. And ma'am, to you the last question of this panel is how well and how timely are you able to de-escalate or escalate with the pneumonia panel results, and how well do they translate into improved patient outcomes, your experience so far?
I think the negative predictive value is probably the biggest value addition if you send these multiplex PCR panels. The idea is you can de-escalate with more confidence if it is negative. But if it is positive, then sometimes it may become difficult, especially in an immunocompromised scenario. So I would say if a virus is diagnosed, then you can give certain additional therapy. If Mycoplasma legionella is diagnosed, then you can give more specific therapy. Or if they are negative, then you can actually do away without treating this particular organism. So the negative predictive value is probably much higher in this context.
So much. And one last from all of you, I would say, any unmet needs with syndromic PCR. I think there are certain pathogens which are not there, which is always a concern. But apart from that, what are the unmet needs or caveats? Dr. Yogiraj sir, could you enlighten us?
I think it has to be considered with conventional method. It has to be seen with a initial gram stain by the microbiologist, and we have to consider that report along with our, because it is also a point of care testing. It takes a few minutes to have a gram stain. So you combine that result with the PCR test. See if you are getting a gram positive bug in your sputum, and your multiplex PCR is telling all about gram negative, then we must consider about the gram positive one, because that is being seen. So we must not forget about our conventional method, and apart from that, we in future, if it's possible, we must combine different tests that are rapid diagnostic tests, like T2 bacteria, these kind of things, along with this, and see whether this combination can give us better result. So that could be a AI kind of project. So that's future.
We'll take that insight. And with this, I conclude the panel. Thank you so much for your expert inputs. Thank you so much.
Thanks a lot, Dr. Dey. So I would like to give you a small token of appreciation from Tata Medical Center. I would request Dr. Tapesh Bhattacharya to just hand over the gifts to our moderator and the panelists. Dr. Devjani. Dr. Shashwati Shina. Dr. Shoman Shah. Dr. Shayan Chakraborty. Thank you. Thank you all. When you move on to the next session.
So we move on to the next session, and next session will be a little interesting topic, that is in scope of ECMO in cancer patients. What is the current evidence? And in that regard, I like to invite Dr. Dipanjan Chatterjee, who is the head cardiopulmonary critical care unit of Medica Super Specialty Hospital. And in advance, I like to thank Dipanjan for waiting for such a long time. And please, over to you, sir.
Hello. At the end of the fag end of the day, my topic has been made a little bit helpful by the previous speakers on stem cell transplant. So, why do we need to discuss at all about ECMO in cancer patients? Is there any need? If a patient comes, a cancer patient who is undergoing chemotherapy with hypoxia, do we ever think of before giving oxygen? Do we ever think if the patient is dyspneic before putting the patient on ventilation? Then why do we have to think so much that whether if it is, even if it is indicated, we will give the patient ECMO support or not? So to discuss this, what is the burden of cancer patients in our ICUs? It's usually around 16 to 18% of the patients are thought to have cancer. Of which solid tumors around 12 to 15 and hematologic malignancy 3 to 4%. So what percentage among these cancer patients do they need ICU care? Approximately 5 to 6% of solid organ tumors and 11 to 18% of hematologic malignancies, they all require ICU admission because of organ failure. And this organ failure may be a manifestation of the disease process. The cancer itself is progressing to the extent that the patient is having an organ dysfunction, or is because of complication or the side effects of any therapy. So these patients in the ICU are different because there are a lot of causes, starting from infectious complications. They are immunosuppressed. They may be having tumor lysis syndrome, electrolyte disorders. All these things are unique to the patients of cancer. But with improved care, the survival of cancer patients is increasing. Not only the ICU care, it's also the routine care of the ICU, the cancer patients has improved quite significantly in the last 10 years. And you can see that the mortality of ARDS is gradually coming down, but still it is significant. The mortality with severe ARDS, the 90-day mortality is almost 80% in these patients. So we need to think. Risk factors for short-term mortality. They include age, severity of illness, mechanical ventilation, comorbidities, late presentations, and as well as severely advanced stages of tumor with cachexia. But they do not include the kind and stage of cancer, the neutropenic status of the patient, if the patient has got a recent chemotherapy or not, or if the patient has an autologous stem cell transplant. So all these criteria, they do not affect our the short-term mortality. They may affect the long-term mortality, but short-term mortality is not affected. So the critical care of these patients has gone a sea change in the last 20 years. And this is the consensus statement which has come out in 2018, where we say that which patients do we need to admit in the ICU? The patients whose survival, long-term survival is good and whose prognosis is supposed to be good. In them, we will go all out and do full code ICU management. Means we'll do everything for the patient. So this thought came in 2006, and you can see that these patients who are newly diagnosed malignancy, they or the patients who are having in remission, who are on curative therapies, first line treatment, first life expectancy is more than 1 year, whose cure is not likely, but still they would be surviving more than 1 year. All these patients, we will go all out to treat these patients. But certain category of patients who are poor performers, whose prognosis is bad, in those situations, we will not be going all out for them. So we need to categorize patients. Which are the patients who have a life expectancy good, who will be improving, rather than whose prognosis is bad. So what category of patients do we put the patient on for ECMO? There are 4 types of cancer patients who needs ECMO. The hematologic malignancies, the solid tumors. There are certain tumors which are causing compression of the mediastinum, so their ECMO will be a savior for them, as well as for to prolong life so that we can get time for chemotherapy. So coming to the hematologic malignancies, which are the most common patients who will be needing ECMO. This was the study which came out in 2014, and they had a very brilliant outcome. They had approximately 14 patients, and the most common complication was bleeding in 50% of them. And you can see that even on ECMO, these patients, 5 patients were getting chemotherapy. Out of the 14, 7 survived. And even after 36 months, the 7 survivors were alive. So these authors, they postulated that ECMO is feasible in these patients with acute respiratory failure, and we should not shy away from giving ECMO to these patients. But there are other problems also. What about the nosocomial pneumonias, infections in patients on ECMO? Do we have any evidence that patients on ECMO, they have more nosocomial infections? No. These patients will be having nosocomial infections because of their immunosuppressed status, and ECMO doesn't add up to their increased nosocomial infections. But this bright study was not followed in the later on studies which came out, which showed that quite a few studies were done in Korea, which showed that the outcomes were not very that good. ECMO in 23 patients, VA is 14, VV is 9, winning success is 6 out of the 14 in VA, 3 out of 9 in VV, and in spite of winning success, only survival to hospital discharge was 1 patient in VA and 1 patient in VV. So the outcome is not always rosy. So even the author suggested that we need to have a caution before we go for ECMO in these kind of patients. But their patient load was a little bit different because these patients who went for ECMO, they were acute leukemic patients rather than the previous cohort. What are the practical problems that we have in these patients of ECMO? They are neutropenic. They may be having thrombocytopenia. More than 50% of the patients will be presenting with thrombocytopenia. And on ECMO, they will be having a coagulopathy or a DIC-like features. These patients may be needing chemotherapy, and there can be infections which can be bacterial, atypical, pneumocystis, as we have seen before, or fungal, or the lung changes can be non-infective also. It's maybe because of the malignancy itself is causing the lung changes. So our diagnostics have to be more accurate. We are more into doing CT scans, bronchoalveolar lavages in these patients. What are the changes do the ECMO make? The PK/PD issues during chemo in these patients, because the volume of distribution increases, the metabolism changes, so the PK/PD issues are there, and the toxicity may be different in patients on ECMO. So we need to be pragmatic in our approach, but we can give chemo during ECMO because chemo can be life savior in many of these situations. ECMO after stem cell. As we have seen in the previous lecture, there are a lot of complications of stem cell transplants are respiratory. ARDS occurs in almost 16 to 20% of the patients, and out of these, 3/4 are severe ARDS. So what do we do in these patients? Can we manage them with ventilation, with oxygen, etc.? If not, then what to do? So there are various papers that have come up. This was a paper which came up in 2014, which found that 37 patients on allogenic stem cell transplant, of which only 7 survived. That is only 9% survival. But if we can divide these patients who are getting early ECMO within 240 days or after 240 days, the survival is significantly different. So the late onset ARDS in these patients, the survival is really significant, almost 46%, whereas in early, it is very dismal. So stem cell transplant has been shown that ECMO in these patients is sometimes very disheartening in the results. So what about the solid organ malignancies? Here also the picture is not very rosy. And this article, they showed that if the patients are having recurrent or progressive malignancy, or they are having a severe granulocytopenia, and these patients, they will not be benefiting from ECMO. Another article, they have very clearly showed that patients with the progressive disease, they are not recommended to undergo ECMO, because the survival rate in these patients is only 30% in 60 days if it is very rapidly progressing tumor. So the researchers, they have suggested that it's only a supportive care in solid tumor patients, in those patients who have a very good functional status. Their functional status has to be good. Only then you should go for ECMO in these patients. The another section that I was saying that we very commonly do is medicinal tumors which are impinging on our airways or our great vessels. There we put the patient on ECMO and then we go for surgical resections. If the patient has a tracheal tumor, then again ECMO is a savior because we won't be able to continue oxygenation if we are resecting the trachea. And in patients with pheochromocytoma, they may be going into a cardiac failure where ECMO is a savior. So ECMO as a bridge to chemotherapy, because some patients may be rapidly going downhill, and if we can give chemotherapy, they will improve. To buy time, we put the patients on ECMO, and there are quite a few literature which has showed that the patients have improved after chemotherapy, and we can wean off ECMO. So, and ECMO should not be ruled out as the first instance as a salvage therapy for cancer patients where we have a stable disease who are eligible for full code ICU treatment. So ECMO should not be ruled out. Whenever we get a patient of cancer who is referred for ECMO, don't think that we cannot put the patient on ECMO. If the patient is a suitable candidate, we can go ahead for patients for ECMO. So the take-home message is finally, it's a relative contraindication. It's not an absolute contraindication, and it is a life-saving measure in many of these patients. But the outcomes may not be as good as in other routine patients. So a multidisciplinary approach is necessary to decide which patients will be improving or which patient may benefit with ECMO. So if we go for further reading, there is a free article in the net. This came out in June 2023 itself, and it is quite lucidly explained the use of ECMO in ARDS for oncology patients. Thank you.
Thank you, Dipanjanda, for an excellent presentation. And you are very well aware that 2-3 occasions I have requested you to review our patients because families are aware about the term ECMO, that it can be life savior. And even in advanced cancer patients, they expect to at least take an opinion from an specialist, and you come and help us in that regarding the counseling part and taking a decision for management. Thank you. A small token of appreciation from Tata Medical Center. Please accept. So we are nearly at the end. So the penultimate presentation, again, it's very relevant with our regular practice in oncology and ICU. And what is the concerns of respiratory perspectives when you are talking about different types of chemotherapy and radiotherapy. And in this regard, I would like to request Dr. Tapesh Bhattacharya to take the podium, and his topic is on chemoradiation and lung protection. What is a non-oncologist should know?
This one.
Good afternoon. So thank you, Sudipto and Shomodip and the entire team for giving me this wonderful opportunity. So I am complete mismatch in this forum. And what I want to say that my experience is that even if a patient has underwent pelvic radiation and went to a dentist, then they ask whether I can extract the tooth or not. So still it is like Hirok Raja Deshe, you have seen that magician with that mysterious machine. Still it is thought like that. What will happen, we don't know. But it's not the reality. So that I am going to present and wipe away that misconception. So if you see radiation therapy in chest, it's lung cancer, esophageal cancer, lymphoma, breast, sarcoma. There are a lot of role of radiation. So what is our concern? Concern is radiation-induced lung injury, and it's a severe complication of thoracic radiotherapy. How toxic it is for lung? So if you see RILI, it encompasses any lung damage due to lung exposure to ionizing radiation. And typically it is classified in early and late toxicity, and it could oscillate between asymptomatic and severe manifestations. So if you see the RILI grading, that is CTCAE 5 currently followed. And clinical grade 1, it is asymptomatic, and ground glass opacity is less than 25% of lung involvement radiologically. Grade 2, yes, symptomatic, requiring treatment. Extensive ground glass opacity is 25 to 50% of the lung involvement. Grade 3, symptoms with oxygen requirement and clear evidence of focal consolidation with or without evidence of fibrosis and more than 50% involvement of the lung. Severe symptoms, grade 4, with persistent oxygen requirement or assisted ventilation. There can be dense consolidation, atelectasis, traction bronchiectasis with significant pulmonary volume loss. So if you see the RILI phases, acute exudative phase, that is around 1 to 3 months of radiation, proliferative 3 to 9 months, fibrotic phase 9 to 24 months, and from the it is all calculated from the end of radiation therapy. What are the early changes? It can be acute phase changes which appears within 1 to 3 months and lasts till 6 months. There can be ground glass opacities, consolidation, irregular or poorly marginated opacities. So here we can see So here we can see the ground glassing, consolidation, and irregular or poorly marginated opacities. Late changes, it appear after 6 to 12 months. Fibrosis with air bronchogram and traction bronchiectasis, sharply defined margins. Here you can see. So what is the treatment of RILI? It's mainly oral glucocorticoids for patients with a subacute onset of radiation pneumonitis, moderate to severe symptoms. Example, dyspnea that interferes with daily activities. Prednisolone usually used 0.75 mg per kg, that is ideal body weight. Approximately it comes around 40 to 60 mg per day for 2 to 4 weeks, followed by a taper over a long period 3 to 12 weeks. And if the patient experiences relapse of symptoms, we return to full dose for 2 weeks and attempt a slower taper, particularly when the dose is 20 mg per day or less. So what are the risk factors for radiation-induced lung injury? If we see the treatment-related factors, it depends on total radiation dose. Obviously, if the dose is high, there is a higher chance of toxicity. If I deliver large dose per fraction or my per day radiation dose is more, there will be higher chances. What about the irradiated lung volume? How much lung volume we have irradiated? Irradiation technique, yes, there is definitely improvement in radiotherapy techniques from 2D to currently SBRT or particle therapy. Chemotherapy, what kind of chemotherapy has been used sequentially or concurrently along with radiation? Immunotherapy, this is a new tool in the armamentarium. And if you see the lung cancer, now there is a huge role of immunotherapy. And in the curative setting, obviously after concurrent chemoradiation, there is role of immuno. And also in the metastatic setting, there is definitely role of immunotherapy. And there are some patient-related factors. Yes, if the age is more, the patient has COPD, ILD, chances of radiation-induced lung injuries are more. So before going for radiation, we always go for a PFT, DLCO, and 6-minute walk test. So these are the gold guidelines we know. For us, if the FEV on post-bronchodilator is 60% and absolute value is more than 1 liter, then we usually go for a radiation. But sometimes we find patients which is between 40 to 60%. We send them to the pulmonologist or internal medicine guys. And after the lung function optimization, we go for radiation. But as far as SBRT is concerned, we don't have this kind of cutoff. Some patients who are not going for PFT or DLCO, they can't perform. There we also check the 6-minute walk test. So here is a case scenario I am presenting. This is Mr. ZK, right lung mass, adenocarcinoma lung. And he was actually planned for definitive CTRT. Started on 24th July 2018 and completed on September 2018. OPD visit on 27/11/2018. Patient complained of cough. Let's see. So here you can see there is a right-sided lung lesion, and here in the CT scan also you can see, and this is the sagittal image where you can see this was the lung lesion. So what has been done? This patient was treated with 3D conformal radiotherapy. Say 4 to 5 years before, we were doing this kind of radiation. So this was 3D conformal radiotherapy, not as crude as 2D, but this was the reasonably okay. So here you can see there is a lot of exposure to lung with the low dose radiation. So what happened? This was the CT scan picture in 2018 and end of 18 and 2019. This was the radiation pneumonitis appeared. Here you can see this was in November 2018. These are the radiation induced changes, and 2019 it was like that. But this patient was treated with 3D conformal radiotherapy, which is now mostly we are not using. If we see the technological evolution in radiation therapy, we have moved from 2D, 3D, then IMRT, IGRT, TOMO, CyberKnife, LINAC. There are a lot of improvements came. Why? Main difference is via higher precision through better integration of imaging and more interfaces between machines user and between professions. So it has been sophisticated. This was the 2D form of radiotherapy. Like here we only see the bony landmarks, the anatomical landmarks. In that way, initially the crude form of radiotherapy was planned. So at that point of time, radiation toxicity was much higher. With 3D, it has improved, and further improvement in techniques. Now I will show you how it has come down. So before going for any radiation planning, we need to go for a proper metastatic workup. For that, PET CT is mandatory. And this PET CT not only helps in the staging workup, but it also helps in target volume delineation and how we can reduce the toxicity, how we can reduce the error. Actually, it helps. Here you can see this is the FDG uptake, and here you can see there is a collapse. So if I have not done the PET CT and if I have done only the CT scan, then my target volume will be quite large, and a lot of lung will be overexposed. So which will lead to a lot of toxicities. But nowadays it has actually helped us. So now this is the PET CT image. This PET CT we actually fuse with our CT scan during radiation planning. And now what will be my target volume? Now my target volume will now like this. So I need not treat that collapse area. So which was actually in the CT scan era. So it was wrongly done. So this is the help of the functional imaging, which actually reduces the errors, which actually reduces the interpersonal variability also. I may have drawn something else, my colleague will draw something else, but when we have the help of functional imaging or PET CT scan, it may be more precise or accurate. So this was the 3D CRT, one scan I have shown before, that patient, Mr. ZK. This was also a 3D CRT, where we have put radiation fields from different directions. And you see, some dose will go to the opposite lung also, and there will be chances of more radiation exposure. But nowadays what we are doing, this is a typical right-sided lung mass, where we can see the FDG uptake. And now what we are doing intensity modulated radiotherapy. It is very conformal kind of radiotherapy. But for delivering this kind of radiotherapy, you need a daily image guidance, because when you are too tight, you may not miss anything, because lung tumors are moving. So I can miss also. So for that, with IMRT, I need daily image guidance. So IMRT, how we have done? See how conformal our radiation is. It was quite a large mass, and we have conformed our radiation like this. So other part of the lung exposure is very less, which can be possible with IMRT. Here we can see even with the low dose area, this was a high dose area where it has adequately covered 95% or 100% dose has covered your tumor. And see around that we can see a halo or a low dose region, but that also was not like before. Now it is much conformal. So what happened? This patient I have treated in November 2022, and after 1 year, the disease has completely responded. There is no tumor you can see now, but there are some radiation pneumonitis you can see, but it was not like before, which was treated with 3D CRT. So always lung radiation does not mean that there will be a huge pneumonitis, and I'm treating pelvis, I'm asking for somewhere else that whether radiation effects are there. It's not like that. So if you see the dosimetric gains, with 3D CRT, it was like that. You can see the low dose area is covering almost the entire lung. But here with IMRT, we can save this part of the lung. It is reduced. So this is another patient of mine, which was this. You can see again the right-sided lung mass. It was adenocarcinoma. It was localized. Mediastinal lymph nodes were not there. What we have done, we have treated with SBRT, that is stereotactic body radiotherapy, where we give daily high dose. Almost I have treated with 60 gray in 5 fractions. So within 5 days, I have completed the treatment and 60 gray has been delivered. So per day, I have given 12 gray almost. So here you can see this is our dose distribution currently. So how we have achieved this? This we have achieved with the 4D CT scan. CT scan means basically your 3D imaging you are doing. When time has been integrated, because here respiratory motion is there, when time has been integrated with your 3D component, then that is known as a 4D CT. So we are taking consideration of the motion during CT scan, and you know how is the trajectory of the motion, and this kind of radiation we can deliver now. So what happened to this patient? So this was the low dose region. Now you can see I have seen the low dose area also. Low dose area also quite conformal. It's not that large. So here I will show this video how 4D CT has been done. So see, this was our target volume. Your lung tumor is moving and it is exactly within my target area where I want to deliver. And every day we do this kind of daily image guidance and we check that whether it is within the target or not. This is possible with the 4D CT scan and with the improvement in the imaging. So this patient, this was the initial CT scan, and now after almost 2 years, here you can see some radiation changes are there, but definitely it has responded very well. The patient is asymptomatic, coming to my OPD regularly. This is another patient. Here you can say this patient has COPD also, and this is the small lesion in the left side of the lung. FDG uptake you can see here. This is again the fantastic dose distribution of SBRT, such a conformal dose. And if you see the low dose region is like this, again I have shown. And what happened to this patient? This is again after 2 years follow-up. You can see only some ground glassing. The tumor completely disappeared. So this was also treated with SBRT, 60 gray in 5 fraction. So you can't say that, okay, radiation has been delivered, that means there will be a lot of radiation pneumonitis and all sort of infection or treatable cause should be seen along with thinking. When you are thinking of the radiation pneumonitis, you should think of the treatable causes also. So now if you see the beam profile, so now you have heard that in Chennai Apollo proton has come, in TMH Mumbai proton has come. We actually tried for the carbon ion, which was, you can see the profile, how sleek it was as compared to proton or X-rays. So actually we were treating for carbon, but due to COVID and the economic breakdown, we have not yet got it. But this is the best sort of particle therapy available in the world. And now there are only 13 centers available. So if you see the particle experience, this was one patient which has been treated. This was actually Japanese data. So I can show you the dose distribution of particle therapy. They actually don't show this kind of color wash, which I have shown, but this was the dose distribution. And this was the kind of radiation pneumonitis happened to this patient. This was with the particle therapy. And this is again the result of particle therapy. That is, this was the initial dose distribution and CT image after 18 months. And here you can see slight normal tissue, skin and lung reactions. So they have done excellent with particle therapy. So for this kind of radiation, so we have shown the improvement in techniques. You have the functional imaging, which reduce the errors. You have done the PFT properly. You have optimally selected the case. So these are all the method of protection, how we can protect the lung. And obviously before going for planning, in TMC, we have this kind of protocols for lung, heart, and all the organs, where when we see the planning, we see whether my dose constraints are met or not, whether I am within the tolerance limit, then only we can deliver a safe radiation. So this is our SOP. Similar kind of SOP we have for SBRT also. And this was the Pacific trial. Stage 3 lung cancer entirely changed. Stage 3 lung cancer, either treatment is for neoadjuvant chemotherapy followed by surgery, or you can go for chemoradiation. Now the durvalumab, which is the immunotherapy, which has been added along with the chemoradiation, and now we are routinely giving durvalumab to our patients. What happened? In patient, it has shown improvement in both PFS and OS. 5-year survival data came, and in patients who received durvalumab as compared with those who received placebo, pneumonitis or radiation pneumonitis of any grade, 33% versus 24.8%. That means immunotherapy arm has a higher radiation toxicity, pneumonitis, because the patient has already been exposed to radiation, and then again you are giving immunotherapy, which has some autoimmune side effects. But if you see the grade 3, grade 4, there was not much difference. So this was the post-immunotherapy toxicity, chemoradiation, then immunotherapy given. So for this, we have the NHS protocol, how we are going to deal with the immunotherapy toxicity. This is a grade 1, grade 2, grade 3. And when it is not getting controlled with steroids, you have options of infliximab, you have the options of mycophenolate mofetil. So this is the NHS protocol, and I can't give the whole of the workflow, but here I have shown something. So how you are going to prevent radiation pneumonitis? Yes, is there any role of drugs? improvement in technology, imaging. You have the PFT, all these things, amifostine, pentoxifylline, pirfenidone, S inhibitors, nintedanib, bevacizumab, all these things trials, but there is no robust data to say that, okay, we can recommend some drug to prevent radiation pneumonitis. At present, it is not there. So prevention or protection strategies are appropriate patient selection, which patients will go for chemoradiation, which will for hot radiation, sequential chemorad, immuno. You have to correctly select your patient, go for a PFT, 6-minute walk test, optimum treatment regimes, functional imaging, you should go, improvement in radiation technologies, SOPs according to your institutional protocols should be followed. Then only you can deliver a safe radiation. Radiation pneumonitis will be less. So as long as there is patients breathe in our lungs, our story is being still written. Thanks for your kind attention.
Thank you, Dr. Topesh. I think these are very important and relevant topics for our knowledge. And I don't think any queries from the crowd. Thank you. Just a small token of appreciation from us. Thank you. So we go to our last session. I don't think cancer medical management cannot be completed without palliative care. And as I work in a cancer hospital, I'm pretty aware how important their role is. When most of the other specialties has failed to give comfort to the patient, they step in and they do a remarkable job to comfort the patient and to ensure they are comfortable and peaceful journey to that their end. So for that, we have Dr. Srikanth as a consultant palliative care medicine specialist in Tata Medical Center. And his topic will be on palliative care management of respiratory symptoms of cancer patients. And I'd like to invite Dr. Gaurav Kumar, consultant palliative care, to join as a chairperson.
Thank you. So we come to the fag end of the session and fag end of the patient's life. So, but the spirit remains. So, the most complex situation which all of us face is managing breathlessness, because we have hardly anything that we can really talk highly of that can really help patients with breathlessness. So I'm just going to cover the presentation in the sequence. So just for your knowledge. So starting off, dyspnea or breathlessness is a complex subjective symptom. So I'm sure each of us face it every day in our clinic, that impairs the quality of life of patients, of not only chronically ill patients, terminally ill patients, but patients with any form, maybe having COPD concomitantly, or patients coming in terminal illness. All of these patients really struggle with breathlessness. A recent systematic review was published, which said that patients in the last 2 weeks of life, almost 62%, almost 2/3 of the patients do struggle with breathing difficulty. And when patients really reach the end of life, or when they're in the fag end of their life, they have just not one symptom, but also concomitant symptoms, like a cluster of symptoms, what we call it, is anorexia, fatigue, pain, in addition to breathing difficulty. And that often makes it, one, very difficult for patients, and also for physicians treating them, a very complex situation, because one leading to the other and the complications of it. And especially in that same paper, it was shown that breathlessness increased significantly in the last 3 to 10 days of their lives. But often what happens is we talk about cancer, but breathlessness is very high, and especially patients with COPD and ILD may have cancer as well, and it really becomes multifold in them. I'm sorry, I'm not going to describe the diagram, but this diagram just depicts how complex the system is. Like, we often see breathlessness, patient comes to you, we treat the patient with reversible causes, and that's all. But there is something much more to it. For example, the brain is a very complex milieu inside, which is actually kind of coordinating how the patient perceives breathing and how the patient send out the efferent signals. And this is often more complicated by one, what meaning the patients attribute to their symptom burden, and what affective state are they in, what emotional state are they in, and how that contributes to breathlessness. So if you see, this is a pictorial depiction of what actually patients go through when they have breathlessness. And if you see, when the patient has breathlessness, there's an advanced cancer, malignancy, lung cancer, metastasized, having not much to live. So naturally, there is this breathing difficulty is further aggravated by certain other factors, such as, sense of hopelessness, guilt, perceived loss of control on one situation, an impending death, a fear of impending death or impending symptom burden, and what more. And likewise, it's not just the patient, but also the families go through such similar symptoms, some such similar emotional feelings, such as, hopelessness. I'm not able to take care of a patient well enough. A feeling of guilt that I'm not able to treat the patient, and frustration, burnout. And if you see these symptoms, when we look at it in isolation, just as a physical form, it's very easy to treat. We just treat pain with morphine, we treat breathlessness with, controlling symptoms. But if you look at the entire thing, the holistic aspect of it, it's more complex. And that's when we as physicians, we as a team really need to look at the multiple aspects, because these symptoms, physical symptoms, can get aggravated by any of these psychosocial or even spiritual or existential distress. How do you manage refractory breathlessness? Frankly, I'll be dividing it into two components. One is the pharmacological, the other is of non-pharmacological. For want of time, I'm not going into the details of everything. And for want of time, I'm not going to be touching upon the load of a psychologist, psychiatrist, or individual roles that each of them have, like respiratory therapists and other people. But I'm going to be talking about something more tangential, what is, what I can cover in the session. So how do you manage breathlessness? So first is the principles. Like, I'll just cover the principles here, which says that treat the treatable. So just because the patient has turned palliative care overnight, or the patient has turned to end of life, perceived end of life, does not mean that we do not treat the treatable causes. To something very simple like removing the fluid, to giving antibiotics, and to something more like maybe a stent in a case of a SVCO. But this all depends upon, like in the previous sessions, the survival. What are the 6 month survival? What are we expecting the patients to be living for? How many more months? So based on that, we gauge the situation and treat the treatable as and when needed. Do your best to ensure that, if a patient has breathing difficulty because of infection, the patient with a good performance, like what we call it in ECOG PS1, has suddenly become breathless and become ECOG 3, PS3 or 4, we know that if we can treat the infection, if that is the cause, the patient can still maybe get along well with this life. Do no harm. Ensuring that at no point during the journey, we are providing unnecessary interventions like putting the patient on a ventilator and we know that the patient is imminently dying. Maybe do no harm. But all these things cannot be something that a physician decides. And often it is paternalistic, where physicians take the call for the patient or the families take a call for the patient. It's important that we have clear goals of care discussion, where patients, family, and physicians and the team sit together and discuss what is important for the patient and why a particular treatment may not be helpful, and what is the patient's and family's viewpoints on why and why not for a particular treatment. Try to align your treatment to the patient's requirements, wishes. Sometimes the patients having breathlessness would want to go back home. Can we organize oxygen at home so that the patient survives at home? Be reassuring to instill a sense of hope. Despite a hopeless situation where the patient is almost on the verge of dying, try to instill a sense of hope of being there with the patient, reassuring the patient of your presence all the time. And of course, as I mentioned to you, a multidisciplinary team where you could have a respiratory therapist, you could have a social worker, you could have a psychiatrist or a psychology team who helped with various forms of breathing problems and helping patients transition to it. Now, I'll be touching upon on pharmacological management, and frankly, I am going to be talking only about refractory breathlessness, which means that I'm not going to be touching upon the reversible causes. We are assuming already that the reversible causes have been handled and the patients are still having breathlessness, which means they are refractory to the reversible causes. Could be cancer treatment, could be infection, could be any of these parameters. So we are looking at how do we manage pharmacologically. The mainstay of treatment and what's available today is an opioid, morphine. So morphine is like a panacea. So we know that morphine helps in pain, morphine helps in breathlessness and also cough. So recent evidence suggests that there was a study which was conducted, a Cochrane review, which rather was conducted, which clearly depicted that morphine is the good drug of choice as against placebo, because it does definitely bring down breathlessness significantly in patients with moderate to severe breathlessness. This is another study which was about a lot of pharma companies are coming up with newer drugs, and they feel that the 10 milligram morphine is a very cheap drug. So let us look for something more innovative. So they have come up with SR morphine, sustained release morphine, which is marginally more expensive than the existing morphine tablets. So there was a study which was recently conducted in 2020, where they showed that, and this was a study which started off with a low dose sustained release morphine, which means that morphine, when administered, it actually gets released into the blood over a period of 8 to 12 hours. So that's a sustained release morphine. So can a sustained release morphine relieve refractory breathlessness as against a placebo? So what was the ways of looking at this? There were two ways of looking at it. One was visual analog scale, a subjective sense of breathlessness reduction. And also these patients were asked to take SOS regular morphine, which could be a 5 milligrams or a 10 milligram morphine, SOS for a breakthrough dyspnea, breakthrough respiratory distress. So they were allowed around 6 doses of 2.5 milligrams of regular morphine, as and when they felt that they had these exacerbations of breathlessness symptoms. And it was found out that so although both the groups did not have significant difference in how they presented, but there were certain findings which were very, very interesting in the study, is that patients who were in the placebo group had a 55% higher intake of SOS morphine or the PRN doses of morphine. So that means that the number of morphine doses that the patients in the placebo group used, the SOS morphine, was much higher than the ones who were on sustained release morphine. And again, when they looked at a subgroup analysis where they looked at further down with worst breathlessness, because when we use morphine, we use it for really bad, really worst breathlessness, it was shown that there was a significant reduction in breathlessness, a subjective sense of breathlessness in patients with worst episode of breathlessness. Now, morphine. Now, newer drugs are coming up into the market. So we are using methadone for pain control. So recent studies have also started looking at if methadone can also be used for breathing difficulty, patients with refractory breathlessness, because methadone is one of the drugs where patients having side effects of morphine, for example, severe neurotoxicity because of morphine, or patients who are refractory to morphine itself, or with severe renal failure, patients can be given methadone in such situation. But of course, keep in mind that methadone is also a relative contraindication to patients with renal failure. But if spaced out well, if the dosing frequency is kind of modulated, depending, there's a way we look at prescribing methadone, is kind of more prolonged. Over 3 to 7 days, we give medication. We slowly up titrate the dose of methadone. If that is given, patients still do well with methadone. And it is seen that the average dose of methadone that was required was 3 milligrams in 24 hours. And methadone did bring down the breathlessness score by 5 points on the visual analog scale. So methadone is an alternative to morphine in case of refractory breathlessness. So there's a lot of misconception and fear of using morphine. So when people talk about morphine, people either, tag morphine to death or tag morphine to respiratory depression. So physicians often fear using morphine, especially in the community. So what happens is that they have found out that in a recent study, they found out that morphine did cause some bit of respiratory depression, but it was a non-serious respiratory depression, and that too in 4 patients out of 1,000 patients seen. And there was a non-significant or clinically not very relevant respiratory adverse effects seen with morphine. So morphine is still safe. Even in cancer patients having COPD, morphine can still be safely used. And there are many studies that are being done in patients with COPD where morphine is shown to be very effective and also with very minimal side effects. So morphine is no contraindication to lung disease or COPD. Now, benzodiazepines often, the other thing that comes up is, when can we use benzodiazepines? Is benzodiazepines an alternative to morphine? No. So benzodiazepines can be used in patients if anxiety or other issues are coming up where it is related to anxiety disorders, where benzodiazepine can be added, especially when we give sedation to patient, terminal sedation or palliative sedation, we add benzodiazepine in case we feel that the patient is very anxious or restless. But benzodiazepine is not proven to be very effective in controlling breathlessness in case of refractory breathing difficulty. There was no significant reduction in the episodic breathing, and also there was the adverse effects were more in patients who were getting benzodiazepines, such as drowsiness or somnolence. Now, what are the non-pharmacological? I purposefully kept the non-pharmacological measures a little later because by now, when patients come to have morphine or methadone, patients have already undergone non-pharmacological measures, correction of the reversible causes. So, but still, it's important that we bring it here because a lot of research is going on across the globe where can we use handheld fans, because there's a lot of research, a lot of money being pumped in to see if handheld fans can really be effective. Second, a lot of misconceptions that still run. Okay, palliative care patients and especially hospitals, why give so much oxygen to the patient? Oxygen is not going to be very effective. But as physicians, it's important to understand that there is a demarcation. So oxygen is effective for breathlessness related to cancer patients. So cancer breathlessness responds well to oxygen therapy. But we've also seen in our experience that when a patient has high flow oxygen going on, when a patient gets oxygen beyond 10 to 12 liters of oxygen or NRBM, such are the patients where we really need to start them on morphine infusion, because those are the patients where they have an intractable breathlessness, and we then have to start them on infusion morphine to bring down their breathlessness. So handheld fans are also very effective ways of controlling breathlessness, but it has been shown mainly for non-oncological conditions like COPD, where handheld fans have shown to be very effective. It has a therapeutic effect because it triggers a trigeminal nerve, which then has a very soothing effect on the brain. Conclusion, I finally conclude. There is some low quality evidence showing that benefits of use of oral morphine and parenteral morphine in refractory breathlessness. There is no evidence because there's a lot of studies and case reports which are being seen that nebulized morphine, nebulized opioids can be tried. No, there is no evidence to prove they're that they're really effective. Currently, there is insufficient evidence to recommend the use of methadone, although one study which showed it was a case series of 12 patients. So not that it was very effective. But however, even if used, it is used in the ratio of 2.5:1. 2.5:1 is the ratio between methadone and morphine in the routine treatment of refractory breathlessness, but may be used as a second line or third line treatment. Airflow delivered from oxygen cylinders can improve breathlessness in patients with advanced cancer, known to be effective. Handheld fans can act as an adjunct and depending upon the intensity of breathlessness. There is a need for further research on pharmacological management with use of methadone. There are some studies which are coming up in the use of antidepressants like sertraline for control of breathlessness, and which is ongoing. And some studies are still ongoing about fan therapy and oxygen therapy, where the degree, the rate at which the fan, the fan can deliver the air, all these things are still ongoing, and research is still on in that area. Thank you so much. Thank you. Thank you.
The end of the session of third Tata on Intense ID, I would request Dr. Sui to hand over the gifts from us to the speaker and the chairperson. Dr. Gaurav. Well, I would request Dr. Mukherjee to hand over the gifts to our three delegates at the end of the day. These are very small token gifts. These are paintings for children who are suffering from cancers, which have been converted to cards, which just bundled it together and given to you. Please come. Please come. Thank you.